Шановні колеги, всім добрий ранок. Вітаємо вас на другому дні нашої конференції. Конференція присвячена захворюванню легень.
Dear colleagues, good
І
morning.
сьогодні
Welcome to
ми
the
з
day
вами
two.
будемо
And
говорити
today we
також
will be
далі і про
speaking
туберкульоз, і про
about
інші
tuberculosis
захворювання,
and
які
other
або супроводжують
conditions that are
туберкульоз, або
like going
маскуються
hand in
під
hand with
туберкульоз.
TB
І
or
перша
masking as
сесія,
TB. And the first
четверта,
session,
котра
session number
зараз
4,
розпочинається, вона
that is
називається
starting up
«Клінічні
right now.
рішення
It's called
впровадженні
clinical solution
інноваційних
implementation
методик
of the
лікування
innovative methods for
туберкульозу,
treatment of
основи
TB.
міждисциплінарного підходу».
Grounds for
Тобто ця
interdisciplinary approach. So
сесія,
this
як ви
session,
зрозуміли з назви, вона більше все
as you
ж
can see
таки
from the knowledge, it's
стосується
more so regarding
стів,
the
які або займаються туберкульозом, або
people dealing
проводять
with
диференційну
TB or
діагностику
doing
з
differential
туберкульозу.
diagnosis
І в
on
цій сесії
TB.
ми
And
з
in this
вами
session, we will
поговоримо
be
про дуже
talking
важливі теми.
about a
В
very
першу
important topic. And then the first is the differentiated approach in managing people with TB and TB-like conditions. And this topic was not really prominent in the past few years because the past few years we have actively implemented new medication, improved quality of treatment, and then the most important time is for us to try out the new regimens to see how they're doing, and then what is the optimal way for antibiotic treatment for them. Additionally to that, we cannot not cover pediatric TB, and we will be speaking not just about the principles of management of pediatric patients with TB, but we will be speaking about the organizational things and the experience of our colleagues from Latvia, how to improve mechanisms and algorithms to support children in ambulatory stage, and especially if the ambulatory treatment is being done by the doctor of general practice or family doctor. We can also speak about the general modern approach of surgery, and if you're speaking about the TB, for a big number of people, one of the stages of treatment can be surgical intervention. Therefore, to avoid this matter completely, like what are the main indicator, contraindicator, where it's a place for physiosurgery, and how different the approaches are for treatment in TB, the shortening and duration of treatment is, for each patient can be treated for 6 months and sometimes even 4 months. And then, as we heard before, throughout the day one of the conference, a international expert have shared with us the information that soon enough, the treatment of TB will be going for just 1 month. So where in this changed algorithm, where is those shortened antibiotic therapy will be placed to surgery? We will discuss this. Therefore, get ready with your questions on this topic alone. And if we are to be touching based upon the matters of provision of care to people that has faced the issue of TB, we can't really uncover the support function, support and care, social support for TB, and mental health with TB, and those mental conditions that are obscuring people with TB to finish the treatment course, and then what kind of methods, modern methodology for mental health support can be used by patients so that they would not be disrupting or discontinuing the treatment and the highly effective therapy that has been started for them. This is the session during which we will be working for 2 hours. This session will finish at 12:20 Ukrainian time. This is why we have a lot of time to talk about all those things and also to give an answer to your questions. This is why, once again, let me remind you that you can, to all the speakers, to write questions into the chat, and during the discussion, we will voice them out. If there's a lot of questions, then we will be seeing how much time do we have, and maybe a portion of questions we will be We will give the answers in a written way or in the chat or after the conference will be concluded. Additionally, just like to mention about the organizational matters. Today is the last day of the conference, and so that you to receive the points for continuous professional education, you need to go through testing. In the end, the testing will be available only from the last session. Testing includes 15 questions, and then based on the requirements of the quality of education center, we can give 2 minutes for questions so that the survey will be going for 30 minutes. Therefore, please calculate your time. We won't be able to extend the time for testing in the past years. When we're given a day or even 2 days so that everybody who wants to go for testing. But unfortunately, the requirements of the quality of education training center change the requirement that the testing has to go during training event. And so the end of our training event, which is the testing, and you have half an hour for that. We will be repeating this information constantly. And I also want to say that yesterday there has been a lot of questions about the recording of the screen of the conference. And just like to mention yet again that the recording is accessible on the YouTube channel National TB Hub. So at any moment you can open this channel, and then it's free of charge, no restrictions whatsoever on that YouTube channel. I think this is it from my side on just anything miscellaneous we have finished, and then we can start moving along with the agenda. And the first presentation, we would like to welcome to the floor Marina Pohrebna, Senior Scientific Expert of Yanovsky Institute, our Scientific Department of the TB of National Scientific Center Psychiatry, Pulmonology and Allergology of Yanovsky, Candidate of Medical Sciences, and then there was the presentation, differentiated approach to TB in conditions of war, important challenges that require our attention. So please do go ahead. No, thank you so much. Thank you so much, dear colleagues. We will be starting. And the first slide, the issues that we will be discussing upon today. TB, unfortunately, continues to stay one of the leading global problems, and the presence of comorbid conditions is one of the key factors that is influencing the effectiveness of treatment in conditions of war in Ukraine. The influence of other conditions have become more meaning than before because there is a disruption of medical infrastructure, migration of the population, which complicates the early detection and adequate treatment. Those conditions are increasing in numbers, and the comorbidities and risk factors as well. Mental health disorder, diabetes mellitus, dependencies, HIV, and other states that in their own way have a negative influence on how TB is going on. And then as the result, patients with comorbidities, they have a higher risk of development of unwanted events, disruptions, and unsuccessful treatment that is being showing us that we need to have the differentiated population-oriented multidisciplinary approach to their management. During management, people with TB in conditions of war, it's insufficient to just use the standardized treatment regimens. The modern WHO recommendations are urging us to have differentiated, human-centered approach when a clinical decision is being made by individual specifics of every patient, presence of comorbidities in that patient, and then risks for disruption and discontinuation of treatment in that patient, the possibility that unwanted events and also the psycho-emotional states. And after that, there you might have an individual plan for treatment or patient with taking into account the monitoring of the unwanted events, and then a big place is given to social support of such patients. Regarding the comorbidities, and then a special meaning on the WHO training, the comorbidities like HIV, diabetes mellitus, and chronic conditions of lungs, also mental health disorders and other things. With what do we have, and how can they influence negatively during management of a patient with TB? They can have a later diagnostics with the more complex TB, higher risks of unwanted events, and ineffective treatment and death. And then by looking at how big of an issue that is, and our Center for Physiatry and Pulmonology and Oncology named Dr. Yanowski, we have planned and have conducted. We finished the first year, and then right now there's the year two of the scientific research that's called to improve the approaches to differential diagnostics and treatment of the long TB connected with the comorbidities and conditions of war. The first year of finishing this topic has finished. We have a few scientific tasks and objectives we have fulfilled during year one of this topic. And so the first objective was to see the main comorbidities of lungs, mycobacteriosis, sarcoidosis, HIV, for example, diabetes mellitus, and also mental health goals, dependencies, and addictions and their influence on timeliness of the diagnosis and effectiveness of treatment for lung TB and the short regimens for treatment. Another task that we were trying to cover in the first year of the to learn on the risk groups and the non-effectiveness of treatment or the development of significant consequences of TB among the civilian population in comparison with the military personnel. Another or the third objective, consider mental health, but I'm not going to go in depth because our colleague will be presenting a presentation and she will touch based upon the fulfillment of the third task of our topic. Regarding the methods and materials, we've looked for information in 337 patients for the detection of main comorbidities of the lungs and their influence and timeliness making a diagnosis and treatment of TB. 129 patient has been with the resistant TB, 214 was the just a wide spectrum resistance, so that there's different options from 6 to 9 months regimens for treatment in the short term. They went from the January 2022 till December 2024. Right now, we are collecting the delayed results. We had 4 comparison groups, so 2 groups. So the group 1 and group 2 for multi-resistant TB. And we have compared the 6 months and 5 component regimen that have been developed in the previous topic of research of our scientific department, and has been compared with the second group, the BPAL-M. So the first and the second groups, those are the patients that had the MLS-TP. And the third and the fourth group, we have compared the treatment for patient with the 160 patient had BPAL-M, and another one had a different regimen for 6 months, 5 component that has also been developed at our scientific center. If we are to compare first the group MLS-TP and then the comorbidities and states or unwanted events, you can see in the first graph the patient with the unwanted events or adverse reactions, and then 2 comparison groups. So you're comparing 5 component and BPAL-M. They have more among the patient with the 5 component regimen. This has also been confirmed in number of unwanted adverse events, and on the graph it's almost 49 patients with that against the 21.3. And also unwanted events of this stage 3, there has been more patient that has received that the laminate including regimens. The successfulness of treatment has been reached in the group 184 and then 4. If you are to take a look at the types of adverse events, then you can see that the number 1, we have the neurological, hematological adverse events, and also hepatotoxicity. If we are to take a look in the timeline of this occurring, then in the group of the BPAL-M, most likely the adverse events are being caused in the first initial months of that, and then in the group for the 5-component was dominant in the second months of treatment. So that overall, we can make a conclusion that patients with the MOSTB that received the dominant-containing regimens compared with the BPO-M, the comorbidities or adverse events has been diagnosed in much bigger number of people, so the 48.7 and almost 40% against the 21%. And if you are to take a look at the results of the treatment, and in the group number 1, this is 84%, which is the quite significant result, but in the second group, the effectiveness of treatment. So what we are seeing is that there is a correlation between the presence of comorbidities in state or unwanted events and the effectiveness of treatment. Let's touch base on the comparison group where we have compared the patients that have been treated using the wide spectrum resistant. There has been 2 groups. Group 3 where they had the BPAL, and the group number 4, which is 5-component regimen based on dolominate. The overall indicators are comorbidities, and it's we had more of them in one patient in the BPAL group, 55, if you can see, in 0.4 against 28.3. Comorbidities and states are unwanted adverse events, and they've met in the group 3, almost 94% compared with 35%, and then unwanted events of the stage 3, they're also most likely seen in treatment of BPAL-M. So if we are to take a look at comorbidities on the first initial stage, what we have is the hematological matters an issue. This is all connected with the use of linezolid. You know that this is more stock with toxic medication that we are using in treatment. But I'd like to also mention that independent of the fact that among the patient compared to the 5-component dominant including regimen, there has been much more comorbidities and the adverse reactions of 55 against 28 and 3% in treatment, and everybody had the same types of treatment. You can see the effectiveness of treatment. On the bottom, it's shown. So far, I can't use the clicker. The effectiveness of treatment in the first and the second group is more than 91%. So what does this tell us is that the capacity to reach a high level of results and the conditions of timely detection and correction of adverse events.
Once we start comparing these treatment regimens as applicable to MDR-TB and XDR-TB, just to compare the efficiency among themselves and to look at the prevalence of comorbidities and IDEs, then in case of XDR-TB, it was higher, particularly at the beginning and throughout the first month of treatment. And thus, having that factor as a burden is one of the factors which is reducing the BPAL efficiency. The high toxicity level was observed at the initial stage of therapy, which requires intensive clinical and laboratory monitoring of the patient. And last but not least, speaking of the conclusions, but timely identification of toxicity of the linezolid will allow to prevent toxic effects and support success of treatment. Taking into account such findings regarding the frequency of comorbidities, ADEs, the impact of, and also difference between MDR-TB and XDR-TB implications, we also looked at the overall health status of 456 patients with active TB or post-TB implications of their lung health. Now, and this covered the patient cohort of 2024 and beginning of 25. So speaking of susceptibility, we had 147 cases, 189 MDR-TB and XDR-TB 60 patient cases respectively. But what we wanted to find out would be what is the statistics with the most common and prevalent comorbidities of lungs and other organs, and also the general health status, including mental health, and as well as the impact on the timeliness and efficacy of diagnostic and therapeutic interventions. So now, please share your attention with the next slide, where we see the results. This would be the residual after effect of the patients after TB with the highest prevalence of associated lung diseases and the greatest comorbidity burden. As you can see, that would be 56.2%. Patients with DRTB would be having higher incidence and prevalence of concomitant infections, diseases, and conditions. And they can break down to look into details at the structure and features of such comorbidities. Then substantial part of that was identified among patients who suffered from non-hospital community-acquired pneumonia, obstructive lung diseases, and then lung diseases with organic irrevocable conditions and like emphysema, pulmonary fibrosis, almost quarter of them, 24.4%. Non-NTMs, non-TB mycobacteria, again, some numbers would be varying here between different cohorts, but they are also available within that comorbidity structure. And such structure would be depending on the type of the patient cohort. Patients with a susceptible TB would be suffering primarily from the pulmonary diseases, while drug-resistant TB, this would be associated with non-pulmonary implications, including HIV and different types of viral hepatitis. Looking at the structure of comorbidities to compare between servicemen and civilians, again, you can see the charts. The difference is quite obvious. Pulmonary, other organs, and general complications. So the structure is similar, although the numbers might vary among the civilians and servicemen. This clearly suggests that we can see similar patterns. In most cases, there would be at least one comorbidity, and a substantial part, depending on some percentages, but more than 30% would have two or more comorbidities. But pay attention to the fact that the number of patients who have zero comorbidities is within, well, actually it's a borderline value of 31%. Looking for greater details at the particular characteristics of the comorbidities, then as we can see, the COPDs, asthma and bronchitis would be accounting for 15%, protoectatic diseases and pulmonary fibrosis 8%, HIV infection 8%, and hepatitis 6%. There are some other indicated and listed here, but that would be ranging between 1 to up to 3%. But again, comparing civilians versus the servicemen, the prevalence would be similar, as well as complicating factors indeed. Next, we analyzed this information to ascertain that impact and timeliness of diagnostic and treatment efficacy is subjective to the following factors, such as type of the factor, whether this is active or passive form of TB, drug susceptible versus drug resistant, concomitant diseases and conditions such as bronchiectatic disease, pneumatic deprus, emphysema, and aspergillosis. Such disease as the NTM and sarcoidosis were not affecting this situation in any substantial degree. And taking this closer to the closing part of my presentation, I would like to make a reference to some of the patient cases demonstrating the impact of such untimely diagnosis. This would be a female patient, 58 years old, annually having 2 to 3 episodes, currently is under follow-up of the pulmonologist. Throughout the recent 2 months, she was complaining of the increasing coughing syndrome, sputum excretion, lost 5 kilograms of body weight, subfebrile temperature, and fatigue. She thought this would be associated with the chronic disease of bronchiectatic syndrome. She received 8 weeks of treatment course with 3 broad-range antibiotics, including mucolytics, as well as bronchodraining therapy, which resulted in short-term improvement, but complete recovery was not sustained. Later on, at the end of month 3, the body temperature started rising up to 38 degrees of centigrade, nighttime sweating, and bronchiectasia started as well. CT was requested for detailed diagnostic purposes, and here we can see not only the bronchiectasis, but also the new changes with some areas of destruction. After this CT imaging, the patient was referred to TB clinician and additional diagnostics with MVT plus and RIF minus confirmed. As the result, again, I'd like to emphasize that patients with chronic lung diseases, including bronchiectatic disease, COPD, or pulmonary fibrosis, any kind of uncommon or extended in time condition manifestation should be treated with caution, particularly looking at the recent WHO recommendations. People with pulmonary infections and diseases should also be referred to molecular genetic testing in order to have timely confirmation of diagnostics information and also timely initiation of respective course of treatment. And on that note, I'd like to thank you for your attention. We would like to thank you, Marina, for your excellent presentation. Indeed, this subject...
Ми завжди в фтизіатрії вважали, коли краткові режими, що основний важіль в ефективності
short regimens, that the major leverage in terms of therapy that we have as our tool would be the antimicrobacterial therapy as such. But now we do grow in consciousness that we should pay equal attention to other factors that we have in a given case, because sometimes the core therapy might not be potent enough if there are any additional elements of burden because of the comorbidities as well as other features and overall condition of the patient. So again, with that, we'll continue to discuss pediatric TB, and here we'll be making a reference to the experience of one of the European countries, Latvia, in this case, and we'll be discussing experience of outpatient care when provided by the general care practitioners and family doctors. This will be of extreme importance for Ukrainian GPs and family doctors. So again, please pay attention to the following presentation, which might provide us with an outline and some landmarks for the pathway that we'll be taking along into the future, learning from the experience of our Latvian colleagues. And in any case, this experience will be interesting, productive, and positive as an element of learning. And with that, we are happy to share this floor with our international partner, a close friend and colleague, Dr. Iveta Ozre, speaking on behalf of the Riga East University Hospital Center for Tuberculosis and Lung Diseases. Again, she is a pediatric pulmonologist, and the floor is yours, as well as our attention. And we're also looking forward to see the slides of your presentation.
Okay, then I can start, I hope, yeah? So first of all, Latvia's experience in timely detection, because it was title of my presentation, and afterwards a little bit about tuberculosis treatment and on outpatient basis in children. So, dear conference organizers, dear colleagues, thank you for the opportunity to participate in this conference and learn from you your unique experience in innovative approaches to diagnosis and treatment of TB and other lung diseases. I am confident that your knowledge and experience in TB treatment exceeds the experience of many countries, particularly diagnosis and treatment of tuberculosis in children. Unfortunately, children still continue to suffer from tuberculosis. In 2024, there were an estimated approximately 1.2 million TB cases among children under 14 years of age, and approximately 15% of them died from tuberculosis. And it happens nowadays when we have adequate treatment for tuberculosis in children. Tuberculosis here in children could start after exposure, because in such way we could identify those who are infected with Mycobacterium tuberculosis. We could treat them preventively. We could diagnose early tuberculosis in those who are already sick, and they will receive treatment, and children will not die from tuberculosis. How to find and where to look for children with tuberculosis? There are three main scenarios. First of all, it's systemic screening for children and adolescents with increased likelihood of exposure. The main group here is contacts of TB patients. And the other large group is systemic screening for children and adolescents at high risk for TB disease and infection. And then the third way how we can identify children, if they come with clinical and radiological presentation of TB disease, then we have suspects, and then we diagnose tuberculosis. Identification of children with TB during screening provides early identification and successful treatment outcomes. Children who are clinically sick already usually have more advanced disease at diagnosis. WHO has defined recommendations for groups at risk for TB, for children who should be screened on a regular basis for TB infection and TB disease. One large group, as it was mentioned previously, are children and adolescents with increased risk of infection with Mycobacterium tuberculosis, and once infected, progression to TB disease, HIV infected, this group comprises HIV infected patients, those who are planned to be treated with tumor necrosis factor alpha antagonists. This with yellow color, it's not WHO recommendation, but in Latvia we always consider children who receive for a long time glucocorticosteroids or other immunosuppressive drugs, and we try to check them more or less or regularly also for TB infection and disease. Patients undergoing hemodialysis and patients who are being prepared for organ or stem cell transplantations. But today I would like more talk in terms of, in the context of early diagnosis about children and adolescents with increased risk of infection with Mycobacterium tuberculosis, and those are children and adolescents from contact with TB patient. In groups at risk, first we rule out TB disease, and afterwards we diagnose TB infection, and if positive, then we treat TB infection, we prescribe preventive tuberculosis treatment. How significant is the risk of developing TB infection or disease after close exposure? One interesting study, recent study conducted by Martinez et al., and key findings from this study. 2-year cumulative risk of TB infection in children, or in TB infected children under 5 years of age, approximately 20%. In those children below 1 year of age who are infected likely due to positive tuberculosis scan test or eye graft, and who did not receive preventive treatment, the risk of developing the disease within 2 years, 18%. And also what's new, that we earlier thought that in those from 2 to 5 years, the risk is lower, but it turned out the risk of developing TB disease is approximately the same. Approximately 20% of children after exposure, if infected and not preventively treatment, will become sick with tuberculosis. Then a little bit lower risk from 5 to 9, and again higher risk in adolescents. It's very interesting information, and I was surprised, and I have now concerns about the effectiveness of our contact investigation, because what turned out that 61% of all pediatric TB cases and 83% of cases among children below 5 years of age, they were diagnosed with TB disease 90 days of initiation of contact investigation, which means that they were already sick during contact investigation, and tuberculosis preventive treatment could not prevent disease in those children. And we again return back to the fact that early diagnosis of TB in the source stage or index stage, which usually is adult TB patient, is of utmost importance. Findings about the risk of infection and disease after exposure by other study, conducted by Reichler et al. So they identified that risk factors for TB infection and disease from this study was age less than 5 years, HIV infection, tuberculosis skin test, Mantoux test positive, 10 millimeters more of in duration. And interesting that risk factors for TB infection and disease in case of close contact was more than 500 hours exposure. 500 hours, it is 1 day and more exposure, provides significant risk from becoming infected. And here we can see in this table pooled estimates of risk for TB disease among household contacts stratified by age and baseline tuberculosis infection status compared with general population. And with red, we can see that all household contacts, regardless of their age or TB infectious status, were substantially higher risk for progression to TB disease than general population. That is a risk in close contacts for development of TB disease. So the risk is significant, and WHO defined recommendations on screening, on TB screening and contact investigation. So, and what WHO say that household contacts and other close contacts should be systematically screened, and those who live with HIV should be systematically screened for TB at each visit in the healthcare facility. And also, systemic screening can be offered among subpopulations with structural factors for risk, like poor communities, homeless communities, communities on isolated or remote areas, indigenous population, migrants, refugees, and maybe even others. Principally, in overall, the goal of contact investigation is early detection of TB disease and TB infection among contacts at high risk of progression to TB disease. And our motto approaching to contact investigation should be that we realize that any TB case that is secondary to the index case represents failure of the country TB program. In such cases, following questions should be asked: why this person was not identified as a contact during contact investigation, and if identified, why TB disease was not prevented by TB treatment. But as we understand, it's really not significant in all cases. And if TB disease or infection is diagnosed in child without known source of infection, then we should mandatory perform so-called reverse contact investigation, look for infectious source or index case for this child. In Latvia, we did it always, and we had even, I think, many times adult TB patients who were diagnosed in such a way. Optimally, who should be tested? We should test all contacts who had real possibility of being infected with tuberculosis, but at the same time, we need not to overload healthcare system with an unnecessary work. And questions who we always have, prior organization of contact investigation, who to test, when to test, how to test, and what should be the post-exposure follow-up for those contacts. I would like to introduce with some factors influencing transmission of the infection from the source to recipient. We know that in most cases, the source of infection for TB is adult pulmonary TB patient who has positive sputum smear microscopy. And factors influencing transmission, its degree of exposure, which comprise intensity, airborne concentration of Mycobacterium tuberculosis, proximity of the contact, room volume ventilation, duration of the contact. The other, it's individual recipient susceptibility, which is important, and also Mycobacterium strain virulence, because we know that some strains cause only single cases, some strains cause outbreaks in TB patients. Here we can see dividing of contacts around the index case based on the degree of exposure. And we can divide in such way. Transmission is the first ring, which comprise close household contacts. It means that person lives together in the same household with source or index case, breathes the same air or shares the same air every day. And close non-household contacts, not common household, but regular and for longer time they were together with index case. For example, grandparents were looking for grandchild. Direct short-term face-to-face contact with aerosol-containing Mycobacterium tuberculosis in high concentration, for example, during bronchoscopy, were together with index case for more than 8 hours with such index case who had positive microscopy, or being together with index case who had positive culture for more than 40 hours, or spend time together with infectious source in the confined space, for example, in the car. So then the second ring where transmission is not so high are casual contacts, frequent visitors, friends, classmates, relatives. And the third ring where transmission of the infection is likely unavailable or very rarely available, social contacts in individuals who may have had sporadic contact with the infectious source case. And we can also reflect these rings in such way: close contacts, casual contacts, social contacts. In Latvia, years ago, we provided a study of children, 81 children, and their potential source or index cases. And genotyping was provided, and phenotypically and genotypically identical tuberculosis were identified in 61% of paired cases. And when looking how close were their contacts, then we identify that household contacts, 67 children, and casual contacts also in quite high degree, it was 33% of children and their matched infectious source cases. So always we have a question for how long time, what was the duration of the infectious period of our source case? And here in this table, we can see that it depends if the patient was clinically symptomatic if the patient had destruction of the lung tissue, and if he had positive sputum smear microscopy. And only if our infectious source case was clinically negative, did not have positive microscopy, did not have lung destruction, 4 weeks before the disease was suspected, he was already infectious. In all other cases, we should consider that our source case was infective already 3 months prior diagnosis of TB disease. When we diagnose TB infection, we should provide tuberculosis preventive treatment. Currently, WHO recommends the term tuberculosis preventive treatment, TPT. Again, if we come back to the study by Martinez et al., effectiveness of preventive therapy was 63% among all children and 91% among those who were likely infected with Mycobacterium tuberculosis based on immunological tests. It's high degree of prevention. And in the other study by Reichler and all, they offered preventive treatment in those who had positive tuberculin skin test, in those who were likely infected, and it was 1,448 patients. Out of them, 37% completed tuberculosis preventive therapy, 12% received partially, but 32% did not receive tuberculosis preventive treatment. In the group who received treatment, only 1 developed active TB, but in the group where patients did not receive TPT, 8% developed active TB disease. It's 40 times more compared with those who did not receive. WHO also defined recommendations on target groups for TB preventive treatment. So one group are those living with HIV, and regarding children, what is important that infants aged under 12 months who were in contact with TB patient should receive tuberculosis preventive therapy after tuberculosis disease is ruled out. And those who are older 12 months and who are living in settings with high TB transmission, regardless of TB contact, should be offered tuberculosis preventive treatment. Regarding household contacts, regardless of HIV status, children under 5 years who are household contacts should be given tuberculosis preventive therapy even if the infection testing is unavailable. It means that tuberculosis preventive therapy should be prescribed in children under 5 years, even we were not able to confirm TB infection. In Latvia, we never give tuberculosis preventive therapy in children younger than 5 years who were not confirmed with TB infection, but maybe it's a different story because we could follow up those children and check them again with immunological tests to ensure infection and afterwards follow up. So I cannot say that it was very correct. A recommendation of WHO is to start preventive treatment after exposure. And in those who are 5 years and older, and adolescents, and also in adult people, the TPT may be given if person was exposed and infected. In Latvia, we prescribe tuberculosis preventive treatment in all infected over 5 years of age, including adults who were contacts of TB patients. So I will not stay on other children and adolescents at risk because we discussed already those were groups at risk for TB in children and adolescents. Options of tuberculosis preventive therapy are familiar for you. I think basic regimens are isoniazid for 6 months or 9 months every day, 3 months of isoniazid plus rifampicin once per week for children aged 2 years and older, and isoniazid rifampicin daily for 3 months. Alternative regimens in children who are older than 13 years, we can use 1 month, 28 days isoniazid plus rifampicin, and or 4 months of daily rifampicin. WHO also recommends preventive treatment in those who are infected with drug-resistant tuberculosis if their source cases are sensitive to levofloxacin, to fluoroquinolones. But in such case, we should very carefully consider the need for preventive therapy. We should ensure that patient is infected with tuberculosis. Tuberculosis is ruled out, and the really intensity of exposure was of high degree. And then levofloxacin for 6 months can be offered alone or together with proteanamide or etam. And follow-up should be provided. Because one part of presentation was early diagnosis of TB in children in Latvia, I would like to stay on some slides which reflect how it influences on the epidemiology of tuberculosis in children. We have only few cases now per year of TB in children younger than 10 years, less than 10 cases per year. And what is the reason for the decline? First of all, it is adults. Effective TB control in adults, because adults are, in most cases, source cases for children. It's routine contact investigation, which was provided for decades, yeah. And it is diagnosis and treatment of TB infection, which we really did. So just one slide which reflects how TB control in adults influenced on the decline on incidence with TB in adults. Here you can see multi-drug MDR, XDR TB patients, but the same diagram follow patients with drug-sensitive TB. So here, 1998, MDR treatment program implemented. Infection control fully implemented 2004. New so-called new TB drugs, which is now already old, delamanid and bedaquilenol. Bedaquilenol provided by compliance, compassionate use in 2008. Then linezolid, afterwards rapid diagnostics, and then bedaquiline and delamanid in the schemes of treatment for patients. And we see the decline of incidence with TB, MDR, XDR TB in adults. Those are children with multi-drug resistant tuberculosis, absolute numbers by years. So, and regarding contact investigation, with orange color, we see children who are identified with TB during contact investigation. Most of cases of TB in children were identified during contact investigation. With gray, we can see children who were identified because of positive MAN2 test and further investigation. And with yellow, we can see children who were clinically symptomatic at diagnosis. And we see that when childhood TB department was closed in Latvia, practically all children were identified with TB during contact investigation, which provided early diagnosis. Most of them were not bacteriological confirmed, but they were diagnosed and they received treatment and were cured. Treatment of TB infection in Latvia. 6 months of isoniazid is the main regimen used. Now, for last years, we quite commonly use also isoniazid plus rifampicin for 3 months, or rifampicin alone for 4 months in case of isoniazid resistance in source case, and also levofloxacin according to indications if the exposed child is young, really infected, and has high risk of TB development. And even delamanid was prescribed, but not in child, it was adult person who was exposed with XDR TB patient and who had very high risk for TB disease. Prophylactic treatment is prescribed and provided by pneumologists. In Latvia, still by pneumologists, because we don't have so many cases, maybe 150 cases, less than 200 cases per year, those who need tuberculosis preventive therapy. Isoniazid can be self-administered, but if the rifampicin is included in the regimen, or levofloxacin or Azerdag, of course, it is always directly absorbed therapy, preventive therapy, usually by WhatsApp, through WhatsApp. I have never seen child who had received preventive TB treatment and who becomes sick with TB. Maybe it's not true. I saw 2 children, but they had other source of infection, and children were not prescribed to preventive therapy due to this other source of infection. But I have seen children who did not receive preventive therapy and become sick with TB later, including multi-drug resistant TB. Treatment of tuberculosis in children in Latvia. We, for decades, used drug regimens according to DST results of child surgical isolate, including second-line drugs. Already since 1998, we treated children with the same second-line drugs as their adult source cases. We never give them courses with fourth-line drugs, despite the WHO recommendations did not exist yet at that time. We always treated children who were clinically radiologically diagnosed without bacteriological confirmation. Ambulatory treatment of tuberculosis in children we started in approximately 1998. And the adherence to treatment increased, stigmatization decreased significantly when we treated children on ambulatory basis. Ambulatory basis till now is mandatory, directly controlled, prescribed, and observed by pneumologists. Unfortunately, we did not yet involve in large degree our primary healthcare providers in tuberculosis treatment, only few cases, because at this point, when we have less than 10 children with TB per year, we are able to cover the treatment by consultation of pneumologist and under observation of pneumologist, and because now we have digital possibilities to provide directly controlled treatment in children. But of course, in countries with high TB burden or in settings with high TB burden, primary care should be involved in the treatment of tuberculosis in children to provide directly observed treatment. And of course, most children who potentially may have TB infection and TB disease first will visit primary care facilities, and WHO also developed guidelines on models of TB care for children and adolescents, and recommendations sounds that in TB high burden settings, decentralized TB services may be used in children and adolescents with TB or for those who are exposed to TB, but they need not to replace secondary and tertiary care facilities for TB treatment. And family-centered integrated services, in addition to standard TB services, may be used in children and adolescents with TB or in children who are exposed. And that's all from my side. I would like to say that we admire and highly respect you colleagues for your knowledge and success in TB prevention, diagnosis, and treatment. And the world can and should learn from your areas. Thank you very much.
Дякуємо, пані Івета, за чудову
Thank
презентацію.
you so much, dear Iveta. This presentation was excellent. And thank you for generously sharing your experience and making the very clear focuses an emphasis on the importance of abiding by the algorithms of TB care for children and adolescents, including the outpatient care options. With that, dear colleagues, please use this opportunity. Do ask your questions. You may present them in writing and verbal during the question and answer session. Dear Yvette, I hope you can stay online with us until the end of this session, making sure that you can answer some of those questions. With that, let me invite you to continue following along our agenda, and our next presentation will be made by the surgeon, as we do remember that in many cases, when it comes to TB management, this is a comprehensive and complex effort with multidisciplinary team involvement, including surgical interventions of different sort. And the particular importance here, speaking of the presentation and information that we have in this next presentation, which will be appealing to the family clinicians, because starting with the month of September, namely the family clinicians will be also playing their role in the outpatient care settings, contributing to our TB response efforts. And this will be important for you to be aware of the cases who might benefit, namely from the surgical interventions. Definitely, this does not relate to all of the patients, but identifying the right patient case at the right time and referring that to the surgeon is of extreme importance. And such decisions will be made by the multidisciplinary teams, and thus you should be well informed about your role and place within the team. When should we invite and involve the surgeons? What are the indications for doing so? All of that will be the point for discussion with Igor Kalabucha, who is the deputy chair of our academic center, chairing the thoracic surgery department, the doctor of medical sciences and professor, and his presentation about modern approaches to physiosurgery, including surgical treatment during or after completion of the treatment course. This is my pleasure to take part in such highly representative level of an event. Unfortunately, I could not attend in person, so I have to rely on the modern technology in making my video presentation to deliver our point of view on the modern approaches to TB surgery, including surgical interventions in the process or following the completion of the treatment course. With your permission, I'd like to make a quick historical overview, explaining that TB treatment and care has actually been initiated even before the science of TB care has evolved as such. That was done namely using the surgical tools. We used artificial pneumothorax starting with the end of the 19th century when Dr. J. Carson back in 1822 and then Ferlanini later on were using a special needles for the pneumothorax initiation and manometry. Then it was followed by Jacobaeus later in 1910, who started using a cystoscope for visualization purposes to see the pleural cavity and also for making the merger between the pulmonary ridges, making sure that we can sustain the pneumothorax effect. And probably that was the first thoracoscopist in history. And then coming closer to our ages, we had very interesting historical facts about the drainage of pleural cavity using the thoracostomas and using the open techniques. And that was recorded at the Kievan Great Prince Sviatoslav back in 1076. Thoracostoma, by the way, and other drainage techniques were used by the classics such as the Morton and also as our counterpart, Dr. Pirogov, in the first half of the 20th century, when they designed the transtoracal drainage technique for intrapulmonary caverns resulting from TB. So speaking further of thoracoplastics, which was well known by our predecessors, who considered that one of the prerequisites for the healing process would be the putting at ease the parenchyma of the pulmonary tissues and reducing the volume of the chest cavity. And then, at the end of the 19th century, there was another strong enthusiast, and particularly this was the Friedrich Sauerbruch, who was also quite prominently renowned for using a special chamber of reduced atmospheric pressure. And then, as the resection and surgical plastic has declined in the prevalence of its use, but even today, based on some indications, these historical techniques can be utilized. And then, remembering that 1933 and 83 were the first historical cases for surgical interventions with the particular treatment of bronchi, the root and vessels. Further development of resection-based therapy took an evolutionary curve in 1950s, thanks to Professor Amosov. By the way, this was the subject of his diploma thesis. And also we should be praising Dr. Bogusz in the 50s, following which the next cohort of our predecessors and our teachers, particularly Professor Horovenko and Rodionov, who were practicing different tactics and strategies of surgical intervention for pulmonary complications, which kept them quite busy throughout the second half of the 20th century. So again, that would be a quick historical overview which resulted in design and development of the classic indications for surgical intervention and treatment of TB. We have to admit that they have been revised quite frequently, and thus resulted in the so-called consensus opinion regarding the classic set of indicators, which have remained almost without any change throughout the Nobel history, particularly starting with destructive TB, with sustained smear-positive bacterial excretion throughout the 6 months. The same relates to the TB case, not necessarily destructive, locally within a particular segment of a pulmonary lobe or within one lung under the same circumstances that were prevailing in the previous case. Then local and sustained modifications of the lung with cavitation or multiple cavitations and tuberculomas more than 2 centimeters in size and diameter. Another particular importance is with the drug susceptibility versus drug resistance or indefinite resistance profile of the patient, or when empirical medicated therapy is not productive over the course of 4 to 6 months. And of course, any kind of pleural complication of TB. which has always been, currently is, and most probably will be, the field and space for application of surgical profession in TB case management. As an example of that, please pay attention to this picture describing what the fibrosis and cirrhosis of the lungs looks like, with some cavitation and degradation associated. So now you can see how it looks in a CT image and in reality. So as you can see, this lung tissue, this is quite a cellular structure, which is soaked with purulent secretion, and respectively, there's no discussion about the quality of functioning and respectively life of the patient in such condition in case medication-based therapy is not successful and the surgeons have to be involved. Once we look at the CT image in this slide, we'll be able to see, well, again, there are different names suggested for this cavitation, such as the false cyst manipulation. But once you take it into your hands, you will see the following process and the result. So again, this might not necessarily be associated with some clinical manifestations, but this will be the focal lesion, which might not be appropriately visualized in a CT image, and at the same time sustaining very high risk for future relapses and complications in such patient. And definitely this would be the role and place for the surgeons without any competition as such under discussion. Now, let us take a closer look at tuberculomas following the completed course of medicated treatment. Definitely, there are standing recommendations regarding the removal of tuberculomas, especially if they are surrounded by the focal lesion with diameter exceeding 2 centimeters. So here you can see what tuberculomas are actually about, because in the image we can see quite satisfactory treatment result. Nevertheless, there is quite a substantial number of TB professionals who will find such result successful. But once you remove one of those results out of the patient's body and take it into your hands, you will be seeing quite a different picture. Thus, we have to discuss some changes which have evolved and progressed in the recent time, including the new drugs. Now we have the new regimens and the combinations of using such latest generation TB drugs. Здається, ми втрачаємо знову ж таки зв'язок із технічною частиною. And also, when looking to clinical microbiological remission, even with some sustained effect of the TB medicated treatment, and we can definitely remember the time when 50 years ago rifampicin came into existence. And thus, we can expect a very quick decay of TB surgery, but there is a very big question mark next to that statement. And then, the more so, that was an expectation 50 years ago. But then MDR-TB came to existence, and then XDR next to that. And again, this is a broader field for discussion. So let us look at other changes. First of all, speaking of the evolution and improvement of the methods and tools for microbiological testing, because now we receive a lot more information, detailed information, and clinician-friendly information within the shortest time possible for the timely diagnostic benefit, which allows us to stay away from empirical reasoning. Well, not staying away from it in the entirety, but maybe shrinking the share of empirical judgment in clinical reasoning and decision making. Additionally to that, we have major improvement of the imaging technology, because now X-ray standards and CT imaging standards provide for great informational value of the imaging, and then densitometric testing and examination are also reinforcing the strength of information and evidence that we collect as part of the diagnostic procedure, particularly in the cases where earlier we were relying exclusively on the so-called morphological testing panels. And thus we can look at the clinical picture, morphology, and also the results of the densitometric evaluation would be providing us with additional information about the patient. And thus, these are closely correlated between each other. And this is an excellent new technology and opportunities which are of extreme importance for us. And then the recent 20 years have changed quite fundamentally when looking at the variety of tools that we currently have in the area of surgical interventions, thanks to non-invasive technologies. Speaking of some, and that resulted in substantial reduction of the scope and scale of surgical interventions and post-surgical consequences and results, including the recovery, rehabilitation period, and cosmetic results as well, which in its turn allowed us to expand the variety of the techniques for intervention, and also to start using the surgical diagnostics as well as differentiated diagnostic approaches in comprehensive TB diagnostics. And thus, on the one hand, today we can see the reduction of the surgical intervention prevalence among the TB patients, but that is happening at the cost of improving the timeliness and specificity of diagnostics, which provides for well-targeted efficacy of the diagnostic on the first hand. Secondly, improving the opportunities for outpatient care and using digital and informational technologies to foster that. But not limiting to that alone. We still have to be mindful that as of today, there are still some grounds to assume and believe that the role of surgical intervention in case of TB patients, not only with the positive moments, but also with some matters for discussion in view of the reform which is still going on, sometimes putting us under the pressure with all of the positives and negative consequences.
Це то, що я виніс як виклики.
And negative ones, what I put as challenges, reduction in the TB facility, reform in its activity, reduction in capacity of highly specialized care in cases it's needed. And this is it's very important in the ability of highly specialized care on TB compared to pre-war period, and also for the restricting capacity and both the accessibility of highly specialized care continues to drop, and we have to recognize that. In the same way as there's no highly specialized health facilities, they reduce in its activity. So the reduction in the role of multidisciplinary approach in diagnostics, differential diagnostics, and the treatment of patient on TB, when assessment of those results and all those matters, and then both the physiatrician and clinician and the health organizer, health managers, and also TB surgeons, and then assistant specialists, an X-ray endoscopist, microbiological of high level, and then the access to that is not that big. And that way, what are the consequences of the challenges and changes that we are seeing in the past few years? We see the reduction in surgical activity in TB patient. This can be, of course, caused by a significant increase in capacity of ambulatory treatment and observation of patients, as the new effectiveness and then new results in assistance on new anti-TB medication from one side, but from another side, and then with war and issues, there is a reduction in anti-TB facilities because of war, and it's because of the health reforms and then as challenges, what we are seeing is the reduction in the network of anti-TB facilities, a significant formalization of its activities, and then the decrease in capacity and provision of highly specialized care. And this is the higher principle, because specialized care and then progressively we're having less and less, and progressively the volumes of their capacity in many health facilities, they're just closed up, and then there's endoscopic departments, and then it has to be in the civilized world to be used for the diagnostics and treatment of patient for TB, and also with the degradation of highly specialized care, there is a reduction in capacity and roles of multidisciplinary approaches in patients with TB. So only in highly specialized facilities there is a capacity to include the inclusion of patients, of the clinician, and then TB organizers, and then also surgeon and the diagnostic services. So X-ray specialist, microbiologist, lab specialist, And then taking into account what I was mentioning before, that with microbiological diagnostics, this is a completely different level as of today, and this is requires a complex meanings and all of that, an educated specialist. And we can discuss the attention to the scientific and educational process in physiatry, and
Ми усі кинулися у
we
реформу.
all started to get into the reform. We all started to, for patients, to be treated ambulatorily and by family doctors, volunteers, and whoever knows who.
Але ж у кожного
But
своя задача.
everyone has their own objectives.
І не можна, щоб волонтери
And you can't volunteers to replace the
спеціалістів
specialist.
Високотехнологічних, наукоємних і
Or scientific or
технічно ємних галузях. Ну, чим займаємося зараз?
and so what are we doing right now?
Є пацієнтка,
So there is a patient
яка лікувалася
that have been treated
декілька місяців
for a
спочатку.
few months. At first they were looking at it as a pneumonia, and they were giving them, it was non-specific things happening. So let me stop the presentation.
Інфільтративні вогнищеві зміни,
Infiltration changes
порожнини розпаду каверни.
because of the caverns drop, and then the patient has comorbidities, diabetes mellitus during treatment, and then we didn't reach some level of effectiveness because of that. We've made a decision and conducted a surgical intervention. We have conducted a video-assisted lobectomy as the future support of pneumoperitoneum to prevent the overstretching of parenchymal state, because the lower lobule of the left lung has been removed in the separate parts, but you can see in right upper part there's still state. And then the surgery went without any complication, and the support endoscopically have been confirmed at the minimal access. And as you can see here at the pictures, there's many tuberculomas present and many places of destruction, pneumoperitoneum, and also has been presented on this slide. And then in patients, been reduced in exudation, drainages as well. And it healed up well. It was done with the usage of the cosmetic technique. You're looking the result, and the results are in the CT, and everything else has been smaller, and everything else that happened in the lower part on the left, and the patient has been removed from there. And then the patient has received a supportive treatment to 6 months, and then in a good condition. They have been discharged because of the full finishing of the treatment and achievement of an adequate remission. Another example, this is the video thoracoscopy. And lymphatic node, this is the group 4 on the right, this is 4R.
виділяється
And right now,
вузол, розділяється його капсула, і ви
right now there's a
бачите,
distinction in
починає
its capsule,
починає
and then
надходити
it
із
starts to go in
лімфатичного
from the
вузла
lymphatic
казеоз.
node.
Казеоз видаляється,
So we are removing
розкривається
that, and then we are cutting
капсула
it, the
лімфатичного
capsule of the
вузла.
lymphatic node.
Далі
And then
видаляється вміст.
we are removing the insides
От, весь матеріал
and all the materials
був підданий мікробіологічним і морфологічним
and
дослідженням.
microbiological testing as well.
От завершується
And then
санація.
finishing up
Ви
the
бачите
cleaning up
ложе колишнього лімфатичного вузла.
the lymphatic node before, and then
Зараз інструменти
right
приберемо.
now the
ложе
instruments will be
лімфатичного
removed.
вузла. Там нічого не залишилось. І
There's nothing
виконується
there, and then
біопсія парієтальної плеври.
biopsy of parietal flora. And right now was the objective of morphological and other types of diagnostics.
Що цікаво.
What was interesting is
За даними
that
мікробіологічних
based on the
досліджень,
microbiological testing
мікобактерії
data,
туберкульозу
Mycobacterium
не
TB
отримані, не
has not
виявлені
been received,
ні
detected,
методами
not with the
культуральними,
cultural
ні
methods, not with the
молекулярно-генетичними.
molecular genetic methods.
Морфологічно матеріал
And then
представляв собою-
morphologically, the material has
представляв
been
собою газоозний некроз.
like
В результаті в
like
кінцевому
necrosis, and in the end of the day,
виставлено діагноз
the decision was made mycobacteriosis
без
that
застосування
without the use
хірургічних
of the
методів
surgical methods
абсолютно не вирішувалось. Воно
doesn't really
пацієнтка
solve the
роками
patient.
отримувала
Years after years received
різні емпіричні варіанти
different empiric
лікування,
options for treatment,
протитуберкульозними
and anti-TB
препаратами,
with anti-TB
виключали
medication, excluded constantly the presence or absence of
якась інша
saying that this is a different pathology, if it's a tumor, if it's not a tumor.
Отакі варіанти у сучасних умовах хірургами
In those conditions, by surgeons in the modern era,
вирішуються надійно, об'єктивно і дозволяють
objectively, and can
ну, вийти на зовсім інший рівень
get to a completely different level.
надання допомоги і взагалі, і хірургічної,
And then surgical care as well.
На сам кінець я повертаюся
At this moment of time, I'd like to get back to the place where I touched base before, and so we are having the decrease in surgical activity and treatment of patients with
Це
TB.
начебто
This is seems like
але
it's
чи
good.
означає, що пацієнтів, яким потрібна
And then for the
хірургічне
patient who would need the
лікування,
surgical
стало
treatment,
не впевнений.
it becomes less than
Тому
that.
що
And then because
погіршення зв'язку між службами у
the
центрі
different
і
services
регіонах
and the centers and in the regions
не завжди є достатніми.
not always are inadequate, and then
адекватно
not always an adequate assessment
оцінюється
of
стан пацієнтів. Там, не знаю, ті ж
then also
залишкові зміни туберкульозу легень на сьогодні перестали ділити на великі і
and
малі.
also for they stopped sharing the small and big ones, even though the separation has been there,
Воно дозволяло
and it was allowing us to
пацієнтами з великими залишковими змінами
with the small leftover changes to achieve support
позбуватися рецидивів,
to remove recurrences and then
Зараз,
prevent
знову
other
ж таки,
things. And so
після
right now,
застосування
after the
нових-
usage of the modern
нових досвіду застосування
experiences
нових
and technologies,
препаратів, ну, є певне таке
and then after TB
ура.
medication, and
Але
then
колись
there is a hooray. And then when rifampicin appeared, there was also a hooray that the surgery would go away, and then everybody got back to surgery. And right now, what we are seeing is the usage of novel medication
адекватні схеми, такі
and
вже
adequate
апробовані
regimens
років
and that are
5,
tested for 5
чи
years
трошки більше.
or
І
even
ми
probably
не
a
знаємо,
bit more, and we don't
ми
know
не знаємо, як буде з рецидивом.
how things are
Поки
going
що
to happen with
результати
the
всі дуже
recurrence. So
добрі.
far, the results are good,
Але до цього треба відноситись обережно.
but for that, you need to respond carefully. And then highly specialized care
пацієнтам,
to
які
patients
потребують
that have been requiring
хірургії, спонтанні
surgery,
пневмоторакси,
spontaneous
легеневі
pneumothorax, and other things as well. MPMO pleura, perforating TB when there is a disruption in shunting, pneumothorax, and then
з бронхоплевральним сполученням.
with the
Ці
bronchopleural.
пацієнти, їм можуть допомогти тільки хірурги.
And only surgeons can
Найменше.
help them. There's
Нам
less and less
розказують,
surgeons,
що
and then we are being told that the surgeons
вже не так актуальні.
are not
І
as needed,
пацієнти
and then
ці
the
просто,
patients are just
залишаються
staying behind, and then
і це жахливо, і це
this is awful, and this is inappropriate.
Знову ж таки, про
And
туберкульоз,
also
про
about
легеневих
TB and
локалізацій.
extrapulmonary localization.
Багато можна на сьогодні назвати.
And right now we can
де
mention a lot of the things
пацієнтам з
where
туберкульозом
patients with
ока
TB,
нададуть допомогу, з туберкульозом
they're
нирки.
providing the care and assistance, and then
Кістково-суглобовий туберкульоз, то взагалі
tuberculosis.
історія. Про це треба думати так само, як і про
And
хірургію.
then we need to think about this as surgery as well.
Серед цих пацієнтів з
And among those patients is the extrapulmonary,
немала частка
and
пацієнтів,
then
де
the small
будуть
number of
магнітне
people, then
лікування, хай не рік. Ну і те, що
and what was
зараз усім на належному рівні
and on the adequate level of the
мультидисциплінарно,
multidisciplinary,
оцінку при діагностиці
so that everybody else, and then
лікування хворих на
because of the
туберкульоз.
treatment, and
Я
then
вважаю це
I
неприйнятним,
think that
над
this
цим
is
треба
the
працювати
inappropriate because everybody has to
і
work on that, and then
достигати якогось
to reach
прийнятного стану.
an appropriate
І
status, and then
зберегти
to
науковий
preserve a scientific
потенціал у тих
potential
закладах
and capacity in the
психіатричних,
TB facilities,
в тому числі, наприклад, у нашому
and
центрі.
also in
Це
our
треба
center.
обов'язково зберегти,
This has to be
тому що якщо
preserved,
це не
because if this
збережеться,
is
це
not
буде
preserved, then this is going to be awful.
У нас поступово
We
спеціалісти
slowly but
вийдуть,
surely the
залишаться
specialists will go
волонтери,
out.
які будуть
There's
займатися
only
всім
volunteers that
на
will be
світі.
doing everything all
Може,
at once, and
дуже
maybe
з великим ентузіазмом, але
with the high level of
насправді
enthusiasm, but incapable of doing the things that's
тому
supposed to be
я
done. Therefore,
прошу
I would
всіх
ask for
з
everybody
одного боку не
from one
впадати в
side
розпач,
to
а з іншого боку
not to get into despair, and from another side not to get
реформи,
overexcited with the reforms and with everything that is happening.
Працюємо,
So,
колеги,
We are
працюємо.
working,
Дякую за
continue to work,
увагу.
colleagues. Thank you so much for your attention, colleagues.
Дякуємо,
Thank you so much, Igor, for such a, from one side, interesting, from another side, a presentation that's inspiring for many, many things and many opinions, ideas, and thus, this is why, dear colleagues, please, whoever is dealing with the physiosurgery, and I know that we have those as well, colleagues, and then colleagues present in our conference. And in the same way, family doctors, we are reading questions from you. This is a wonderful opportunity for you to discuss the future that is waiting for you. Those multidisciplinary interactions are there.
Як це повинно бути,
And how
яким
is it
чином
supposed to be,
мати
in which
доступ
way
до
to have access to
високоспеціалізованої допомоги,
specialist care and physiosurgery.
як би там не було, це в
No matter
будь-якому
what somebody
випадку
would be saying, this is
відноситься до
a part of
високоспеціалізованої
the highly
допомоги.
specialized
Тобто
care.
любі види операцій,
So any kinds of
це вже,
surgeries, anything, this is
для
a
пацієнтів, особливо з
for patients,
туберкульозом,
especially with
це
TB.
вже така ланка,
It's a
яка
part
може
that
бути
a
виконана
branch that can be
тільки
conducted
на
only
рівні
on the level
регіонального
of the
фізіопульмонологічного
regional
центру
physiopulmonological
або
centers or
кластерної лікарні,
supercluster
надкластерної лікарні.
hospital, cluster
Тому, будь
hospital.
ласка,
Therefore, please,
чекаємо на ваші
we are waiting
питання.
for
І
your
дуже
questions.
дякую Ігорю
And
Анатолійовичу,
thank you
що
so much,
він
Igor,
дуже
for
зробив таку
making such a great presentation. And
мало того, що були обговорені
even
показання,
though there
проти
are
показання до
indications and
хірургічного
contraindication
лікування,
to surgical
але
treatment has been discussed, but
організаційні,
the organizational matters
які
and how
дуже
to organize
важливі
things and systems that are
безпосередньо
very
зараз,
important, especially now when
міняється структура
there's a change in in the structure of anti-TB service, and then the putting the responsibilities into the primary care, and we are moving on, and we have in this session last and probably the most important presentation, because we all understand that in any specialty, not only in the TB specialties, but also the adherence to treatment is being played by an enormous role.
Якщо пацієнт не вмотивований лікуватися, то які б не були схеми
And once again, patient adherence is of extreme importance. No matter how well motivated we are, no matter what advanced technologies, including microinvasive surgeries, we offer to the patient, without the due adherence, this would be an effort in vain. And thus, I'm happy to invite my colleague Yulia Senko, who is the senior researcher of the Department for TB at the National Science Center for TB, Pulmonary and Allergic Diseases of the institute named after Janowski. Thank you so much, dear Natalia. Thank you for this wonderful opportunity to share our experience at our conference on Health Without Barriers, where we would like to share some of the results of our work, research project R2602. We mentioned about that in our opening session already today, but the importance of my message would be to emphasize that TB is one of the major and prevalent socially significant infectious diseases, and not only in Ukraine, but also in the rest of the world. Current treatment approaches are focusing primarily on the physical manifestations of the disease, while mental health status of the patients is usually neglected. Disease is associated with long-term treatment, social isolation, change in lifestyle, and very high psycho-emotional load. Deterioration of mental health at the same time might be one of the decisive factors affecting the quality of treatment and its result, and respectively health and life of the patient. We understand that TB is one of the major threats and burdens. We have millions of new cases reported every year, and substantial part of the patients require respective efforts in treatment and support, while Ukraine is one of the highest burden countries globally. So let us take a closer look at the psychological effect of TB, because we have anxiety, depressions, stigmatization, discrimination, reduced self-esteem, loss of and emotional fatigue as well, which is particularly challenging in the current environment in Ukraine. And thus we have to make sure that mental well-being is also addressed to prevent from damaging their physical and emotional life even more further. Because here we're talking about emotional as well as physical well-being, personal development, and subjective well-being, which are all constituents to the definition of the quality of life. Remembering that quality of life is one of the key criteria for assessing the efficacy of therapeutic intervention as well as treatment and rehabilitation effect. Trying to understand how mental health affects the TB treatment efficacy. First of all, it motivates the patient, reduces the depression and anxiety, develops the skills for emotional self-regulation, improving adherence to treatment and strengthening social adaptation, as well as overall quality of life. In other words, psychological support is a very strong element of comprehensive care that we are delivering to TB patient, which in its turn improves their treatment and rehabilitation effects. In our research, we covered 179 participants. 132 would be males and 47 females at the age between 19 and 35. Based at our Research and Development Center, the institute named after Yanovsky. Originally, we decided on the toolkit of survey forms and assessment sheets to be deployed, covering the comprehensive psychological support and psychodiagnostics at the final stage to assess the result and effect. We also looked at the anxiety scores of the patients who were provided with a treatment course at our center, and we used self-reported, the so-called GAD-7 survey form, covering 97 respondents, including 41 males, servicemen, and 56 civilians. This happened in 2025. The results, as you can see here in the diagram, suggesting that civilians had a higher percentage of people with smaller anxiety scores as compared to the servicemen, who alternatively had moderate to high elevation of anxiety scores. High anxiety score was reported at the same time, namely among the civilians, 7 versus 4%. This is probably associated with the emotional background, PTSD implications, loss of social roles in their regular lifestyle during the active duty and following it, suggesting that namely the servicemen require a tailored approach in managing the anxiety and depression conditions, which directly affects their rehabilitation and psychosocial adaptation as well. We also looked into the ratings of anxiety and depression. And here you can see the pie chart suggesting the anxiety testing results, where normal condition was observed in less than half of the respondents, and 21 and 61 respectively, and other percentage ratings were quoted regarding the depression. Again, mild, moderate to high. Well, pay attention that severe depression, percent-wise, is quite small in the share of results. Looking into the key approaches to be utilized, that would be mental health coaching and training, breathing and muscle relaxation, anxiety, depression, mitigation, art therapy, and also mentoring and coaching techniques, which in different combinations, thanks to individual approach, will be quite effective in strengthening their psychological well-being and the effect of our support. In order to implement the respective programmatic approaches, we also conducted individual psychological sessions, peer support groups, anxiety decretation classes, and also the internal locus of control, both individual and group sessions, with the expectation to have improved emotional status and reduced anxiety level among the candidates. And again, this would be manifested by the post-research surveying with the same candidates, and also assessment of the quality of life indicators. We also used the methodology for assessing the emotional self-assessment, emotional, and again, we are losing connection with the speaker. So again, we were looking into their well-being, fatigue scoring, as well as preparedness to fully functioning, include looking at the emotional status, perception, and attitude. And these would be the key results that we received. Almost half of the respondents, 46%, demonstrated very high positive attitude ratings, and activity would be the most vulnerable indicator because only 1/3 of the respondent demonstrated the sufficient results, which suggests emotional fatigue and well-being. That would be on the moderate with the high and low percentages being absolutely symmetrical, 22% each. Also, there were some trends observed, such as fatigue prevalence among females would be about 40%, while among males, this would be about 26%, which suggests that namely the female population is experiencing major emotional fatigue. Speaking of elevated mood, now we can see a different picture where the males respondents were demonstrating the lowest scores, which is clearly suggesting a majority of the respondents would be reporting the moderate level of emotional fatigue versus the emotional aptitude. Further on, we decided to continue the research with the sense of vital orientation. Essentially, it allows to assess to what extent the respondent believes their life is full and controlled. Look into different indicators that are important in overcoming personal and emotional crisis. But again, these would be some generalized indicators because individual scoring would be varying substantially in each individual case. But what we observed here is that wholeness of vital performance and the overall feeling of conceptual well-being would be reported at the highest rate, which are clearly suggesting the greater sense of personal responsibility for the decisions and actions that the patients are taking, including their physical life and any course of treatment. When conducting recurrent psycho-emotional assessment, we observed positive dynamics in most of the indicators under study. The generalized results would be the improved self-esteem, greater activity, better emotional status, elevated consciousness of their lifestyle, and acceptance. And in order to visualize how this was happening in real life setting, this will be a collection of snapshots of having art therapy courses where we would have the weaving process, which allows the participants to make a pause, to take a break, to feel themselves and realize what kind of contribution they are making with their thoughts, ideas, and expectations into the collective effort. So this would be quite a peaceful process, which is allowing you to seek for the internal balance between yourself and your environment when you take different threads of thoughts, subjects for discussion, and positions and attitudes as a contribution to this collaborative picture. And I hope now the video player will be helping this presentation.
важлива частина одужання.
And again, this is a very important part of the recovery and healing process where art and communication come together.
Пілінгу створювали листівки з яскравими візерунками з паперових.
This would be another art course with
Але вона творить також
postcard
під час роботи
crafting, where people could abandon some of the everyday routine and thoughts and ideas that were persistently abusing them, and instead trying to reveal some of their hidden talents and thus allowing to find extraordinary solutions to some everyday burdensome routine, and thanks to that, recovering the inherent balance and feeling stronger.
Також в нашому арсеналі ще
As part of our toolkit,
метафорична психологія.
we have metaphorical transformational game that we called the Wheel of Life, which was designed by Olena Tararina. And this is not just a game. This is the open space for sharing your recollections, your thoughts, ideas, and expectations, covering your health, your everyday life, your emotional condition, your vital resources, which are of particular value for the participants who can seek support from other members of the group, provide their support in a reciprocal manner, and thus such techniques or could be successfully initiated for implementation among the TB patient community, strengthening the emotional and mental status, declining the emotional stress, helping them to grow some confidence on the one hand and positive attitude to treatment, as well as social adaptation, improving their level of consciousness and thus improving the quality of life. And drawing to some conclusions as the result of our theoretical and empirical research, we have found out that mental health condition of the TB patients is a very important factor directly affecting their quality of health and life, as well as the process of treatment and recovery, thanks to normalization of their mental health status. Additional to that, managing the condition of such patients requires comprehensive support, making sure there are multidisciplinary efforts made using differentiated technique, targeting the improvement of the mental health and quality of life of the patients. On that moment, thank you for your attention, and we'll be happy to take any comments and questions in the chat. Thank you, dear Julia. This was a wonderful presentation, just like the video stories that you have included into your material, which are demonstrating the human face of the relationship between the patients, between patients and providers, which will be building the better report and compliance in our relationship. And of course, this will be directly and indirectly rewarding us with better patient adherence, since they understand that this is not just the matter of taking your drugs regularly, but this is the matter of the appropriate attitude and behavior throughout the course of treatment. With that, dear colleagues, we have about 10 minutes left for our question and answer session. I hope we will manage this appropriately. So again, we are scrolling up and down the chat on our platform. I can see some questions from yesterday regarding the non-TB mycobacteria, but also we have some questions clearly suggesting that the number of such patients will be growing. The matter is that this is not a homogeneous phenomena that we have to deal with. And this is not the matter of some exclusive opinion of our professionals. But the matter is that we can see the growing a number of people with aspergillosis, COPD, immune compromising conditions. We also have the growing number of patients on immunosuppressive therapy, target therapy. All of these patients are part of the group at the major risk of such disease.
It's caused by the pathogenic flora, most likely people from the risk groups. They confirm with that condition. And of course, the patient with post-TB changes, like with big post-TB changes. And so here, this topic is overlapping with surgery. If the disruption is in the lungs, it's quite big. And then if fibrous caverns that have not yet achieved, and then there's no indications.
Оцей субстрат, який
So
може
this substrate
викликати колонізацію цих залишкових змін нетуберкульозними мікобактеріями, і потім колись
and
в
then
процесі
after
лікування
in the process of treatment, and maybe there can be a risk factor to the development of non-TB
захворювань легень.
condition and
Так.
colonization of those
Я чому
changes
зупинилась
in
на цій
TB.
темі, тому що багато
And then in the
запитань,
process
ваша
of
дуже цікава
treatment, and
тема
then there's many
для
questions and an
аудиторії,
interesting
вона
factor
дійсно цікава.
in non-TB.
Тут є такі організаційні
So there are a few
питання,
organizational matters
які працюють в дитячих поліклініках, а не
and
в
then working in the pediatric
фізіопульмонологічних центрах
polyclinics,
з
not
вересня
the
місяця.
pulmonological center
Я
from
переадресувала
September.
і попросила пані Яні Терлеєвій, яка є нашим NTP-менеджером, і я думаю, вона на це питання дасть краще
And I think Jan Terleva
відповідь, ніж
would
ми,
answer
тому
that's
почекаємо,
doing better.
проглядайте
This is
чат,
why
на чаті
please look
вам
into the
напише
chat.
відповідь на це
She'll give you an answer to
запитання.
this question.
Потім дуже багато подяк
There's many words of
всім
gratitude to
абсолютно
everybody,
спікерам, які були в
speakers,
нашій
and then
сесії. І
and that has been
у
in
мене
every session.
питання,
And then I
Івета
have
з
a
нами
question. And
зараз? Тому що
as
до неї-
Iveta, are you here with us?
Я можу озвучити на українській мові, там переклад буде для неї на англійську, так?
Iveta, just a second. There will be a question.
Питання пані Іветі.
The question to Iveta from Tatiana. The child is 5 years of age and 2 months. A contact with the mother. Mother had a multi-drug resistant TB. Resistance to isoniazid, rifampicin, amikacin, kanamicin, and caprimicin as well. Vaccinated with BCG. The sign is 3 millimeters. The X-ray test is okay. MAN2 is negative. Do you think you would need to prescribe PTP 6 months of levofloxacin to the child, or to observe 6 months and then just do additional testing? And only after, if there is an increase in MAN2 without resistance, without the X-ray changes, to conduct then preventative treatment. But what if MAN2 is negative? You would just observe the child for 2 years, or would you do something? So I'll make a short summary on the question because it was long. So Iveta, the question was, the child that is with the mother, with the household contact, the susceptibility to fluoroquinolones has been preserved. And then the question is, what tactics to give levofloxacin for 6 months, or then to just observe? And if you would just observe the child and monitor it, in which cases? Or would you just give every child independently on any other factors you would need to give prevention using levofloxacin for 6 months? What is your opinion?
If I understand correctly, the child is not, infection is not confirmed. Tuberculin skin test is negative. True?
Так.
І
Yes,
рентгенограма
yes, negative.
нормальная. У ребенка больше 5 лет. Да? Мама
Да.
чувствительна к левофлоксацину. Ну, по
Да.
принципі, чисто I'm sorry. Formally, the child need not to receive prophylactic treatment because the child is more than 5 years old and not infected. I think that I would not start at this point. I would follow up. If possible, maybe next time IGRAS tests can be performed next time to ensure really if the child become infected and if infection is established, confirmed by interferon-gamma release assay, then yes, then levofloxacin should be prescribed. But if infection is not confirmed and the child is older than 2 years, then only follow up at this point.
Дуже дякуємо.
Well, thank
Дуже
you so
дякуємо.
much, and thank you so much
Звернули увагу
for
на те,
pointing
що
out
саме
the fact
головне в
that
цій
the
ситуації
main in this
виключити
situation is to
активне
exclude
захворювання у
an active
дитини.
condition in
І
the
тільки
child.
після цього
And only
ми
after
можемо
that,
далі розглядати
we can
питання
later on look at the
профілактичного
possibility of prevention, preventative
Якщо я
treatment, and
правильно
anything
зрозуміла,
else
так?
if I understood you correctly this time.
Дуже вам
But yet again,
дякуємо.
thank you so much,
Просимо
Iveta. We'll kindly
залишатися,
ask you to
можливо,
stay for
будуть
longer
ще
because maybe
питання.
there are
А
other
я
questions
йду
that will
далі
also be
по
addressed to you,
чату.
but I'm going around the chat looking at
Тут
questions,
більше
and here
далі
more
йдуть
so
питань до
there are questions to
торакального хірурга.
a thoracic surgeon.
Є запитання від
There is a question from
учасниці.
a participant.
Якщо, скажімо так, все підсумувати,
To
якщо
summarize the
є
question, if
ліпома розміром 46
there's lipoma or
мм,
something is it
чи
46
показана тут
millimeters,
хірургія
the surgical
торакальна, тому що
intervention is being indicated
лікар,
because
якого консультувались,
the doctor
не
to whom
побачив
they
показань
didn't
до
see any
оперативного лікування.
indicators to the surgical treatment.
Ігор Анатолійович, це до вас.
Igor, I think that the question is to you. Igor, your microphone is off.
Секундочку, тому що щось... У вас виключений мікрофон, Ігор Анатолійович.
Igor, your microphone is off. Can you turn the microphone on? Igor?
Так, раз, два, три, мене добре?
1, 2, 3, can you hear
Зараз
me
чути
okay?
прекрасно.
Now, yes, thank
Ну,
you.
чудово. Добрий день, шановні
Greetings, dear colleagues,
організатори, шановні
dear organizers,
учасники,
dear participants,
спікери, шановні
dear speakers.
співачі. Дуже приємно, друзі,
It's really nice to have this day two
у
on your
професійній
conference in a
атмосфері.
professional atmosphere.
Стосовно
And then regarding the
безпосередньо питання.
question that was
Ви
asked,
знаєте,
as you probably know,
мій досвід показує,
my experience
що
shows
будь-які описи
that in any
рентгенології,
descriptions that the x-ray specialist and the resharing conclusions or anything else never really gives a
ну,
answer,
забезпечують належне
doesn't provide
розуміння і
the understanding
відповідної якості оцінки.
and assessment as
Тому
well.
було б найкраще комп'ютерну томограму
To do the CT
у цифровому вигляді прислати
and the
до
digital
нас.
version to send to us, and then to that to add all of the
Матеріали стосовно
materials
операції
regarding the
лікування.
testing and
Або
treatment,
особисто з'явитися до нас на
and then
консультацію.
to get into the
Ми,
consultation.
безумовно, вирішимо це питання остаточно.
And we will solve whatever there is.
Якщо виходити виключно
And then if you would go out from what was mentioned so far,
можливо,
then, well,
є
maybe
сенс
there is a point in doing the video thoracoscopy
малоінвазивну процедуру, яка
and then
супроводжується
less invasive
відео-
procedure that is a less traumatic
дозволяє повністю
and allows for a full within the healthy
виявити
tissue
усі
to give you all the changes and everything else that causes concern to
дезінфекційний матеріал,
resection materials, and then the microbiological testing, genetic, morphological,
взагалі розставити всі крапки абсолютно
And then
об'єктивно, так як це
fully
має
objective
бути в
as it's
21
supposed to be in 21st century
вже
because
третій десяток 21 століття закінчується. Я вважаю, треба
Добре,
бути
Ігор Анатолійович,
відповідним.
дякую
Отаке
за
and
бачення цієї
and this is the vision of the situation. Thank you so much. And then Iveta, the question is to you.
практичне питання,
The practical questions
організаційне.
and organizational.
Безпосередньо, що б ви могли
And
порадити
then what would
нашим
you
лікарям
recommend to our
загальної
doctors of the
практики,
general practice or family
які ось
doctors?
з
What would you
вересня
tell us
місяця
family
будуть
doctors that from
входити в
September in
рамках
Ukraine will be
реформу
a part of the
в
reform
перелік
as
тих
the
спеціалістів,
list of
які будуть
specialists that are
лікувати
allowed to treat
туберкульозне онкологічне,
tuberculosis on the
і в
ambulatory
тому
stage,
числі
and also pediatric
тобто
tuberculosis as well,
маленьких
so that
пацієнтів,
for smaller
також
patients,
будуть
younger
лікувати
patients will also be
амбулаторно
treated in
сімейні
the
лікарі.
ambulatory by family
Яку
doctors.
б ви могли
And
дати
what
пораду
would be
нашим
your
сімейним
piece of
лікарям,
advice to
тому
our
що
family
цей
doctors?
перехідний
Because
етап
this
дуже
transition period,
складно
right, they're just starting
сприймається.
out, they're not
Є
perceiving it well,
побоювання
they're
виходу з
afraid of
загальної
doing that,
практики,
and
як воно
family
буде.
doctors, they never
І
treated
за
this
вашим
before. Like,
досвідом,
in your experience, what are the
як це
hurdles?
було у
What are the
вашій
bottlenecks?
країні?
What's the
Наскільки
hardest part in family doctors doing that?
як полегшити цей
And
шлях
how to
до
improve this
вперед?
pathway forward? What would be your pieces of advice for just starting out as a family doctor in
I
TB?
get you and understand correctly about the primary care, how to treat children in primary care on an ambulatory basis. Yeah. First of all, I think that primary care doctors also should follow the principle of directly observed treatment. Yeah. Don't give parents, don't give children drugs in their hands. If you are organizing ambulatory treatment based on, for example, Skype or WhatsApp, then yes, then you should give to parents the drugs and you will see how children are taking drugs. So directly observed treatment, it is very important point I see also in the primary care. The other is that I think that anti-tuberculosis treatment regimens will be prescribed and should be prescribed by pediatric pulmonologists experienced in the field. Yeah, and primary care doctors will give these drugs and will follow children will follow for adverse events in children. So primary care doctors should learn about the adverse effects which can arise using these drugs in children, and also what follow-up should be, how often blood count analysis or liver function should be detected, controlled. Obviously, I think that radiological control can be provided by primary care, but in case of some doubts about the positive effects, then children again will be consulted by pulmonologists. I would organize in such ways as well. The responsible person remains pulmonologist who prescribes the treatment to child, and the primary care doctor should have direct contact, easy connection with this pulmonologist to discuss every unclear issue.
Дуже дякуємо, Івета.
Thank you so much, Iveta, for the
Дійсно,
answer. And then
це дуже таки цінна порада.
this is an important piece of advice. And then
скажімо, така
also
порада для
a piece of advice that for the family doctors and everything else, that you're not staying alone one-to-one
проблемою дитячого
with
туберкульозу.
the issue of pediatric tuberculosis. So the pediatricians that are staying at the structure of physiopulmonological service, they will be coordinators. And then, as you mentioned before, then you will be having this opportunity And then
пацієнта
to refer
маленького
patient,
вашого
the
в
pediatric patient, to the
фтизіопульмонологічний центр,
pulmonological
на любі
center,
додаткові обстеження, або якщо щось
and
вам не зрозуміло, або для
and
того,
if
щоб
something's not
провести якийсь
clear,
медичний консиліум,
and to make like meetings, and then
якоїсь там конкретної
on
клінічної
the specific
ситуації.
clinical
Тому,
situation.
якщо
And then if
лікування
the
передається на первинну
treatment
ланку, це не значить,
is
що
being passed to
передається
primary care, doesn't mean
повністю
that
з
they
кінцями. Тобто
giving with
ваша
everything,
задача
and
так
then your
дійсно буде
objective
лікувати пацієнта,
then you will be to
але
treat the
ви будете
patient,
цим займатися
but
не
you will
самі,
be
ви
doing
будете
this not
цим
alone. You
займатися
will
в
be doing
складі
this together as the
інтердисциплінарної
part of the
команди,
multidisciplinary
фтизіатри
teams
або дитячі пульмонологи,
and
хто там на той
pediatric
момент у
pulmonologist or
нас в
whoever's
країні
there
на
in the
довгострокову
country and the
перспективу,
prolonged perspective.
звичайно,
And
будуть
then, of
обов'язково в
course,
складі
they
цієї
would be a part of that
мультидисциплінарної
multidisciplinary
команди, і у
team.
вас буде
And then you will
військового
be the
спеціаліста,
coordinator,
з
so
яким ви в
the
будь-який
specialist
момент
that in
зможете
any moment you will be able to
проконсультуватись,
consult
порадитись
and then
і скласти якусь загальну тактику
to
лікування
create a general
даного пацієнта.
tactics
Дуже
for managing
дякую,
the patient.
Івета,
Thank you
за
so much, Iveta,
цінну
for
таку, скажімо,
for such an important.
цінний досвід, який ви представляєте нашим колегам.
Thank you for a
І
wonderful
я
experience that you're
думаю,
bringing to your
після
colleagues. And I
цього
think
все ж таки, ну, хоч
after that,
трошечки
then
буде
a
у них
little
більше
bit, they're going to have more
впевненості, що все буде
certainty
добре,
that
і вони
everything's going to be
залишаться
okay and they're not
сам
going to stay one-on-one with
з
that
пацієнтом,
disease and with
який
the
має
patient that
туберкульоз.
have TB.
Ігор Анатолійович, хоче щось
Igor,
сказати?
do you
Ігор
want to say
Анатолійович,
something? Igor,
півхвилини.
they half a minute to you.
Дуже коротко, але це
Really
дуже
shortly,
важливо.
but it's an important thing that I wanted to mention. And then I listened to the presentation, but I didn't stress and highlight. Before war, we had a research conducted in a big, like long tuberculosis that we have removed and then went to testing morphological and others. And then on the stage of the treatment, they had the resistant TB, and then the leftover challenges, and then there is a need in the surgical intervention, and then around 40% of patients with the resistant TB, they have over 70% of all the patients, they have been resistant. So from non-resistant, they went to resistant. And I understand that the new anti-TB medication is really giving you a lot of hope, but as the practice shows, even with rifampicin, sooner or later, we will have the big changes after the new anti-TB medication, and we will be getting back to surgery. And this is why we need to remember this and then to detect and have the high vigilance. Thank you so much. Thank you so much for the comment.
Так, ну що, колеги,
And
я
so,
дякую
dear colleagues, then I
всім
want to say thank you to all the
доповідачам,
presenters. I would like to say thank you to
за чудові
my
доповіді.
colleagues for a wonderful
Дякуємо,
presentation. Thank you
пані
so much,
Івета, вам
Iveta,
за чудову
to your
презентацію, за
wonderful
чудові
presentation,
коментарі,
for wonderful
рекомендації
comments
для
and
наших
recommendation
спеціалістів.
for
Ігор
a
Анатолійович,
specialist, and to Igor
ваша
as well.
доповідь в чаті
Your
произвела
presentation
фурор.
in the chat was just
Можете
and
почитати.
so you can just read a few
У
comments
вас
and
є
then
така
you
можливість.
have this wonderful opportunity.
Тому і вам,
And
колеги,
then
також
to
всім
you, colleagues, I'd like to
дякуємо
say thank
за
you to
вашу
you and for your
зацікавленість, за жваві
wonderful interest
дискусії. А ми
for
будемо
discussion. We
рухатись
will
далі
be
і переходити до
moving on,
наступної
and then we
сесії.
will be
Знову ж
moving to the
таки,
next
ми будемо
sessions. We will be
періодично
also
протягом
periodically
нашого
throughout
стріму
the
повторювати
day-to-day. We'll
організаційну
be kind of
інформацію
repeating the
з
organizational
приводу
information,
тестів
some
в
main
першу
things about the
чергу.
test first and
Шановні
foremost,
колеги,
and dear
тести
colleagues, and
будуть
then the
доступні
test will
після
be
закінчення
after
останньої
the
сесії
last session
нашої
will be
конференції.
over of our conference,
Закінчення шостої сесії.
in the
Тести
sixth session, and then the
передбачаються
tests
по
are
програмі
foreseen on
з
the
17:30
from
до
this 5:30 to
17 до 17:30.
um,
Колеги
and
мені
then the
підказують,
colleagues are
тому,
telling me,
будь
and then
ласка,
this is
орієнтуйтесь
why
на цей
please
час.
try to stress upon this
Платформа
time. The
відкриє
platform
доступ до
will
тестів
open access to
саме
the
в цей
tests
період.
in that
Це
period.
зараз такі
And so right now, this
вимоги
is the
центру
requirements of the
якості
testing
освіти,
center
і
of
ми
quality of
їм
education, and then
слідуємо. Я
we are
думаю,
following them. And then
вам
I
вистачить
think that
півгодини
you'll
для
be
того,
enough
щоб написати
having half an
ці
hour to
тести
just write
і
those tests
скласти
and then to
успішно і набрати
put them
необхідний
in
бал.
successfully and to take the points needed.
Дякую,
And thank you so
колеги,
much,
і
dear
буквально
colleagues. And
2
then
хвилини,
just 2 more
2-3
minutes.
хвилини
2 to 3 more minutes. We will have a small break so that we can move to the next session. Thank you so much and have a great next session.
продовжувати. Також дуже цікаво.
Dear colleagues, please be invited to continue with the second session of our conference, and we will be talking here about innovations in pulmonary and TB care disease, discussing AI and modern information platforms for diagnostic treatment and training. And for the benefit of the first presentation, I'm inviting Yulia Dudko from Chernihiv Regional Clinical Hospital with her presentation about integration of the new artificial intelligence algorithms and solutions, particularly describing the PASC system and their experience in results of application in Chernihiv Oblast. Good afternoon, dear delegates. My name is Yulia Dudko. I'm an X-ray specialist of Chernihiv Oblast Clinical Hospital. And today I would like to share with you some results of our efforts about integration of the PACS system and artificial intelligence in the diagnostic of chest diseases. At the beginning of the war, our TB care center lost all of our equipment and assets, including the photofluorography device, which was used for outreach activities. And ever since, we, in an administrative matter, were merged with a clinical facility which was suffering from HR shortages and equipment deterioration, which made the confirmation of diagnosis a challenge, sometimes taking up to 5 days of time, which, as you can imagine, is very inconvenient and unacceptable for the diagnostic purposes. On top of that, there were some logistical issues regarding the transportation of the film and image production, especially remembering that we are close to the border with the Russian Federation, close to the frontline hostilities. So we have to make sure that everything is safe and reliable. And thanks to the PATH support as part of the project for strengthening TB response in Ukraine, we were provided with the PACS technology and AI solutions to support analyzing the images of chest X-ray. The PACS system provides for the storage of images and remote access. Mobile screening using the artificial intelligence solutions Lunet Insight allows for outreach activities for the X-ray images to be done in community settings, and also online accessibility of this technology for the benefit of the patients who were undergoing testing, including the sputum sampling. One of the PACS servers is installed in our clinical facility, bringing together 9 clinical departments and 1 mobile X-ray unit. All of them are merged into one shared architecture server environment. We install these elements step by step, starting with the PACS system, then mobile X-ray machine, and later in March 2025, we also have the server-based version of artificial intelligence, Heavy Archer. So now the patient pathway management has been improved significantly because all of the images are automatically uploaded to the PACS server and subject to artificial intelligence analysis, which highlights the elements under suspicion for closer review by the radiologist, following which the interpretation of results is available to the commission of clinical professionals who are making their respective decisions and actions based on that diagnostic information. Later on, in the beginning of this year, we expanded the coverage, and up until today, we have totally reviewed 7,000 images, having identified 313 TB cases. Thus, we can see that the time of diagnosis was reduced by almost 30%, while at the same time providing for additional detailization of the imaging interpretation results, making artificial intelligence a very powerful tool which is supporting the function of radiologist. Another advantage is that artificial intelligence is highlighting the changes which may remain unnoticed for a radiologist. We do have reported cases when patients who are quite asymptomatic were diagnosed thanks to the artificial intelligence contribution, highlighting the zone of potential impairment. So this would be an extra pair of eyes. And if there is initial interpretation which states the standard of norm, then after running the algorithm amplification, we definitely can pay close attention to the areas under study. But at the same time, artificial intelligence by no means will be replacing a health professional. It helps to reduce the risk of leaving some of the areas unattended. In order to demonstrate how it looks before interpretation with artificial intelligence and then having it augmented with AI indications. So here you can see the special zones highlighted where some pathological changes are available. Now, looking into the results of mobile X-ray intervention, where we totally screened 951 people. All of them are representatives of at-risk population, with 39 pathologies identified, including 6 obvious candidates, which have been confirmed basically on the next day, including 2 children. And all of such patients were immediately referred to start the treatment, which again emphasizes the importance and experience between the time of diagnostic intervention and the onset of therapy. So again, once we have real-time accessibility of images, regardless of a radiologist availability, so the mobile unit becomes quite autonomous to full-scale screening, even in remote locations and communities. And again, this system is fully integrated into our operations, and all of the findings are verified and validated by the radiologist. All of the members of the team are being trained and supervised, and if there are any results which are pending additional validation, then such cases are forwarded to the attention of the system administrators. And there I should be emphasizing that looking at this architecture for storage and communication of the images allowed us to strengthen reliability of the system even in the context of war, thanks to the operational experience of case finding in remote locations and having that fully integrated into our clinical routine. Just to finish with my presentation, I would like to emphasize once again that the main idea of this project is not to replace the function of a radiologist, but rather to support the clinical reasoning and decision-making, while the final diagnosis and decision to act will be left for discretion of the health professional. Thank you so much, dear Julia. This is an extremely interesting and practically sound and helpful presentation, which clearly demonstrates that artificial intelligence can definitely serve as an aid to the health professional. But remembering also that diagnostic is only one of the elements in the patient pathway. So speaking of other elements will be covered by Dr. Klemenko, Director of the Patient Community Development, TB People Ukraine, and she will convey a presentation about human support and digital solutions which are making as a help available to everyone, anywhere, and at any time. Thank you so much for the kindest introduction and welcoming our online audience. I hope this presentation as well as entire session will be appealing to you. My name is Olga Klemenko, and I speak on behalf of TB People Ukraine, which, judging by its name, represents the interests of the people with TB in Ukraine. It was founded by the people with TB and those who have the personal exposure and experience, which is patient-centered. We have a big team with 2 offices in Kyiv and Poltava, but we cover Ukraine nationwide via a remote communication network, which will be the matter for my presentation, with a clear focus on barrier-free environment in the area of TB that we are exploring and improving every day, thanks to our effort and collaboration with other patient organizations. We do agree that the role of healthcare professionals is of extreme importance and value. But in this slide, please pay attention to the role of the non-governmental sector, which is also extremely important in Ukraine, and we have to make sure that the community of health professionals also appreciate this supportive role and complementary function which can and should be delivered by the patients and their communities, making sure that the actual patients and the potential ones, they make an effort to become active in their role and place and having their rights also observed, preventing any occurrence of the fact when denial in services or delay in services might result in mitigating their preparedness or adherence. And definitely we should be encouraging their active involvement to the extent possible, remembering about the war in Ukraine. But speaking of our programmatic approach is to make sure that the dialogue between the patient and provider will be focused on the health of that human being, namely the human being under the burden of TB as we understand it, namely via perspective of the impact on socialization of the patient, psycho-emotional status, labor implications, education, especially when talking about the case of children. Because, let's say, stigma against children with TB, whether or not they have access to treatment, access to education, and other social and emotional well-being, because we have to understand that TB is curable indeed, but people are afraid of such diagnosis, and in many cases, namely stigma and self-stigmatization, results in denial of care. And this is where the patient community have to stand between the patient and provider in order to make sure that they can be successful in their performance.
Ми завжди говоримо, що за кожною цифрою, за кожною статистикою є людське життя. І так багато
Each number has a human life, and so we are looking for solutions and options. So what is influencing and timely detection
завершення
influences and the
лікування,
finishing
якою
the
людина
treatment,
завершує
what
своє
kind of
лікування, чи
how
туберкульоз
the finishing of
наніс
TB
шкоду
has
її життю, чи людина
harmed their life, or
соціалізувалася і
the person has
продовжила
been
своє життя,
socialized
ніколи
and
не
then continued
згадуючи,
their lives without
не
remembering
живучи
and
в страху цього
without living in
діагнозу.
fear
І
of
от
this
якщо ми
diagnosis. And
подивимося
so
на
if you're
25-й рік,
looking in 2025,
нами верифіковано більше 3000
we were able to
звернень. Ми
verify
розуміємо,
3,000
що
encounters. So we understand that
матеріальні
this
труднощі і
the
соціальний тягар, він в
technical
цілому для
difficulties and
України
social
під
burden
впливом
for
війни
Ukraine
зараз є
and the
актуальним
influence
для
of
всіх
war,
груп. Але якщо
it's
людина
needed for all
втрачає
the group. But if a
роботоздатність
person
через
loses
діагноз
the ability to
туберкульоз, при
work
цьому
because of
кожен день
TB, and
вона має
because
замість
of that
того, щоб
daily,
шукати рішення,
instead of
як
looking
попіклуватися
for
про свою
options and
родину,
solutions and how to take care of
бути
their family,
мотивованою
to be
приймати
motivated
ліки, через
to take
які, по
medication,
суті, вона і втратила свою роботу,
because of which they
таку
lost
людину
their
дуже
job, this
важко
person, it's really hard to
залишити в системі охорони здоров'я, щоб вона
leave in a
пройшла
health system
повний
so
курс
that they would go
лікування.
for the
І ми
full
можемо
list of
побачити,
treatment. And
наскільки
what we can
великий,
see, to
тобто
what extent
показник психологічних
the
бар'єрів і
indicator
впливу
of
стигми.
mental health
Понад
barriers and
600
influence of
людей,
stigma. Over
які вже з
600
діагнозом
people that
туберкульоз
already have the TB
зазнавали
diagnosis
депресивних
have been
епізодів,
through
зазнавали
depressive episodes, have
психоемоційного
been through
пригнічення, відчували
psycho-emotional
самостигму,
depressive
не
episodes,
відчували
self-stigma,
впевненості в
did
тому,
not
що
feel
вони
the
завершать
certainty that they
лікування
would be able
і
to
що
finish the
туберкульоз
treatment, and then
виліковний і вони
TB is
зможуть продовжити
treatable,
жити.
and that they will
Звісно,
be
під
able to continue to
емоційним
live under
тиском
this emotional
стресу,
pressure
в якому
of
ми всі
stress that
перебуваємо,
all of us
всі
are
ці страхи,
in, all
вони
of those
набувають
fears, they're just
більш
taking on
сильного
more of a
характеру і
stronger
впливу на
character and
життя
a stronger
людини.
influence to the life
Труднощі
of
з
the human
доступом
being.
до
The
медичної
complexities with access to
допомоги,
medical
труднощі
care,
пов'язані з
complexities
перебуванням у
connected with
медичному
being in the
закладі.
health
Це дуже
facility.
важливі
All of this
показники
are
для
an
нас, тому
important
що
indicators
саме з
for us
людського
because
досвіду
from
в
the
реальному
human
часі ми
experience and the real
формуємо
time we
свої
are
дії.
forming
І
our
працюємо ми
actions and we are
в двох
working
алгоритмах
into
для
different
того, щоб,
algorithms. And so that
перше,
the
отримати людина
first
могла
is
до
to
нас
get the
звернутися,
person who can reach
друге,
out
як
to
ми на
us. The
це
second thing,
реагуємо. Але
how are we
кінцевому людина
responding
має
to that? But in the end
залишитися
of
в
the day, the
лікуванні.
person
Для
needs to
цього ми
stay in
розвиваємо
treatment.
систему
This is why we are
One
developing the One
І
Impact system.
система OneImpact
And
це
One Impact
починалося як
system
мобільний
that started
додаток
off
у
as the mobile
2020
app
році
in
з 1000
2020
користувачів.
from
І на
with
сьогоднішній
1,000 of
день, на
users, and
25
now
рік, це
in
вже понад
2025,
11
this is
тисяч
almost
людей, які
11,000
користуються
people that
нашою
are using
системою. І
our
це
system.
унікальна
And this is
система,
a
яка
unique system
орієнтована
that
саме на
is
туберкульоз.
oriented for TB
І
specifically.
протягом
And
цих років ми
throughout those
робили все
years, we
можливе за
conducted
підтримки
and did
міжнародних
everything
донорів,
possible with the
у
support of
взаємодії
international
з
donors and
національними
interaction with the national
стейкхолдерами і
stakeholders
партнерами для того,
and
щоб ця
partners, so
система
that
була
the
доступна,
system
щоб
would be
люди про неї
accessible, so that people
дізнавалися.
would get to know that it
Адже
exists.
якщо людина
Because
потрапила до
if the
нас,
person has gotten
ми
to
зробимо
us,
все
we
можливе
will
для
do
того, щоб
everything in our
людина
power
отримала
so that this
подальшу
person would
допомогу,
get
і
additional
її питання
assistance and
було
care, and their
вирішене.
matters
Але
have been
головною
solved. And then
метою, я
the
не
main
втомлюсь це
objective,
повторювати,
and I
щоб
would repeat
людина
myself again and
продовжила
again, for the
лікування,
person
щоб
to
цей
continue
тягар,
into
який
treatment, so
йде
that
за
this
нею
burden that is coming
у
behind
зв'язку з
the
діагнозом,
person
він
because of the
жодним чином не
diagnosis were in
вплинув
no
і
way to
не
influence
привів
and
до рішення
would
перервати
not
своє
lead to
лікування. Ми не
the decision
охоплюємо
to
всіх
stop the
пацієнтів, ми не
treatment.
є
We are not covering
сервісною
all of the, we
організацією,
are not a service
але ми працюємо
organization,
з
but
тими
we are
людьми,
working with the
де
people
людям не можна було
where
допомогти в межах
you
інших
couldn't help
проєктів чи
without other
програм.
projects or
І це
programs
дуже
that
важливо
people just
розуміти,
couldn't be
тому
helped.
що це
This is
дуже
important to
високий
understand because
показник.
this is
Тобто
a really high
настільки
indicator to
існуючі
which
підходи
extent the
не
existing approaches
відповідають
are not
реальним
in
потребам
line with the
людини.
real needs of
Якщо
the
ми
human
маємо
beings, and if we
стільки
are having
викликів,
so many
коли
challenges
немає
when there's just
можливості
no
вирішити
capacity
звернення
to
людини.
solve the
Тому ми
any of the
продовжуємо
issues presented. This is why we
трансформуватися,
are continuing to
і далі в
transform,
нас
and then later on
тільки розвиток всупереч
we only have
обставин.
the
У цьому
development
році
further and
система
further.
зазнає
Despite the challenges this year,
повного
the system goes
оновлення
for
і
the full update and
трансформації і стає вже
transformation,
повноцінним
and is becoming a
кабінетом
full
кожної
cabinet
людини
for every person
для супроводу її
for
вже в
support of that
лікуванні. І
person
це
in
дуже
treatment.
важливо,
And this
тому
is
що
very important
для
because
нас завжди було
for us it was always
таким, як
the
важливою
in a
ниткою
way, an
комунікації з
important line
людиною,
of
щоб
communication
люди
was the person for
шукали
people to
інформацію,
look for the
отримували інформацію
information,
з
would receive this
достовірних джерел.
information from the
Ми жодним чином
adequate
не
sources. In
замінюємо
no
роль
way
лікаря
we
чи
are
соціальних
removing
програм,
the role
які
of the doctor
існують,
or social
але
programs
ми
that
дійсно
exist,
проти
but
того,
we
щоб
really
люди питали
going
у
against for
Гугла,
people to ask Google
якими ритуалами можна
what kind of ritual you
не
can use
знаю,
to, I don't
вилікувати
know, to
туберкульоз,
treat
якщо я не
tuberculosis
хочу
with if
пити
I don't
ліки.
want to take
Я розумію,
medication.
це може
And I understand
звучати
fully this can sound
навіть
like,
трошки іронічно в
even
сьогодення, але це
ironically,
існує. Це явище
it still
продовжує
exists, it's
існувати.
still
Люди
there.
шукають гриби,
People were
люди
looking
шукають
for
свічки, ікони
mushrooms, I don't know,
через страх
church
свого
icons because of
захворювання.
the
І, звісно,
fear
для
of
нас
getting the
дуже
disease, and
важливо
for us
було,
it's
щоб
very
люди
important for
потрапляли
people
і
to get
отримували достовірну
and receive
інформацію, тому
adequate
що
information,
це
evidence-based evidence-based information because this
шлях, а
shortened their
значить береже
pathway,
їх час, а значить береже
saving
їх
their time and
здоров'я
saving
і
their
життя.
health and
Тому
lives as well.
в
This
нашій
is why
трансформації
in
і в
our
сьогоднішніх
transformation
можливостях
and in today's
застосунку, які
capacity
будуть,
of the app
ми говоримо
that
про
we have
наповнення, це інформаційний
that
блок,
we
де
have a
люди
lot of
можуть читати
information there where people can
дослідження,
read the
наукові
research,
статті, досвід
scientific
інших людей.
papers, experience
Люди
of other
можуть
human
звернутися
beings,
по
and then
допомогу. Ми
they can reach
продовжуємо
out
цю
for care and
програму.
assistance. We are
Люди
continuing this
проходять
program.
опитування,
People are
тому
coming
що
for the
якщо ми маємо
questionnaires. If
те
you're
чи інше
having
питання або той
any
чи інший
questions
кейс,
raising
який
to us or
стався в
any
одній
case that
області, нам важливо
happened in one
зрозуміти,
region, it's
чи є
important
ця
for us to
ситуація
understand whether the
системною,
situation is a
чи
system-wide
це
kind of thing,
поодинокі специфіка
or
тої
are
чи
those the
іншої
singular
області,
cases so
і
that
люди
specific
залучаються в
regions
наші
and people are
опитування, і таким
being included
чином
into
все, про що говорить
surveys and
Європа
everything
Україна,
that
завжди
TB people
базується
Ukraine
на
is being
голосі
mentioned is
людей,
always
які в
based on the voices
сьогоднішніх
of
умовах
people
проходять
that are in
лікування.
today's conditions
Ця
are going to
інформація
treatment. This
достовірна
whole
і
information is
верифікована.
evidence-based and
І
verified.
в нас є модуль
We have a
психологічної
module for
підтримки,
the mental health
і
support, and
для
then
того, щоб людина
for a person to
могла пройти
be able to go
вправи
through the
самодопомоги,
exercise and self-care,
звернутися,
self-help,
записатися
to
на
reach out, and then
онлайн-консультацію в
to
зручний для неї
as
час.
for the
І
online
поки що цю
consultation
програму
and the easy to use time,
покриває
and this app
наша
is being so far
організація. У нас є
supported by
модуль
our
для
organization. We
підтримки
do have a
дітей
module
і
for
по
the support
роботі
of
з
children,
дітьми,
and then
модуль
working with
для
children, and then the module
ВІЛ-позитивних
for
людей,
HIV positive
зависної
people,
терапії та
opioid
інших
substitution
захворювань,
therapy, and
такі
other
як
conditions and
діабет,
diseases like
онкологія. Ми
diabetes,
намагаємося,
oncology. So we are trying to,
бачачи статистику,
by
наскільки
seeing the
багато в нас
statistics
людей
to
з
which extent
супутніми
there are many
захворюваннями,
people with the
давати їм
comorbidities, to get them
інформацію
the
по
information
суміжності
on
хвороб.
the
Звісно, не ми її
comorbidities, and then
пишемо,
we're
ми
not the ones writing them,
доповнюємо
we are
знову ж
just
таки
writing them
науково
with this
доведеною
scientifically
інформацією.
proven
Тим
information.
самим так само
And
люди
in the
можуть
same way,
попросити у
people
нас
can just ask
консультацію
us
вузьких
for a
спеціалістів
consultation of the
за згоди фтизіатра,
specialist of
комунікації
the
з лікуючим
physiatrist
лікарем або
agrees with the
сімейним
consultation
лікарем.
with the family
Ми
doctor.
визначаємо,
We
як
are
найкраще
decided upon what is
допомогти
the best way
людині.
to help this
Для того, щоб
person
це не було
be, so that
марною
this is
витратою
not
часу,
just a waste of time,
і дійсно було корисно
and
для
then it will be
людини.
useful
У нас
for
є
a
простір
human being. So we
здоров'я,
have
і це
a
також
healthy
важливо.
space, and this
Ми
is
зробили
also possible. We
онлайн-календар
did an
прийому
online
ліків,
calendar
штучний
for
інтелект
taking the medication, and then
буде
AI
нагадувати
will be
людині про
reminding
прийом ліків,
the
буде
human
проводити чекапи її
being
настрою для
to
того, щоб
making
фіксувати
checkups of the
через
mood
червоні
levels, and
лінії,
then
чи
looking for
продовжується
redlining. Are
позитив,
they
да, тобто
continuing
чи
to have
людина
this
має
positive
якісь
changes, and then
аспекти того чи
did they
іншого
have any aspects of any negatives,
зниження емоційного
or the reduction
стану,
of the emotional
і
status, and
там
then
алгоритми
the
розбудовані так, що
algorithms are
якщо
built in a
червоні
way
лінії
that if the
з'являються,
red
то
lines
штучний
are up,
інтелект
and then
буде
AI will be
розкручувати цей діалог
opening
для
this
того,
dialogue
щоб
up so that
сприяти
we
розкриттю
can aid
людини і
the
мотивувати
opening of the
її
human being and
звернутися
to
по
motivate them
допомогу.
to reach
Тому
out
що
for additional
інколи
assistance and
ми,
care, because
наш
sometimes
недосип або інше,
our
людина не здатна
absence of sleep, and
постійно
then the human being
верифікувати свій
cannot
стан.
constantly
Наприклад,
verify
навіть не
how
здатна
they feel,
верифікувати,
even
чи це діє
impossible to
побічна дія
verify if this
препаратів.
isn't
Тим паче, що ми всі продовжуємо
response,
жити
even
в
though we are
війні.
all continuing to live in
І
conditions
для
of
цього
war.
ці чекапи,
And
вони
because of them,
будуть
those
допомагати людині
checkups will be
зрозуміти, що
helping a
ось
human being to
прийшов
understand
час,
that this is okay,
давай,
the
якщо
time has passed, that
самодопомога не
if self-care
допомагає,
didn't help
давай ми
yet,
звернемось до лікаря.
so let's reach out to a
Простір
doctor. And
здоров'я,
then
він має
the
паралельний
health space
кабінет,
that has the
доступ до
parallel
лікуючого
room, the
лікаря. Це не
access to
медична
treatment
система,
physician. This
хоча
is
наша
not a health
система
system, even though our
має
health system has
функціонал
the
до інтеграції з
functioning to the
медичними
integration
системами.
with the
І під
e-health
час
as well.
пілотування
And
цієї
then during
системи
piloting
дослідження
of the
коректності
system and the
роботи
research of the
штучного
correctness of
інтелекту,
work of the
це буде
artificial
паралельний
intelligence, this
простір,
is
в
going to
якому
be a
медичні
separate space
фахівці,
where the
медична
medical
сестра,
workers and
лікар,
the medical
пацієнт будуть
nurses,
знаходитися в
doctors, and
одному
everybody
просторі.
else will be in just
І
the same space.
пацієнт і
And
лікар
then
будуть,
patients and
лікар буде
doctors, and the
бачити
doctors
звіти
will be
штучного
seeing the
інтелекту
reports on
про
the
стан
AI,
людини.
on the
І,
status of
звісно,
health of the
якщо
human being, and
будуть
if
щитуватись якісь небезпечні
there we
стани,
seeing
це
something
буде
dangerous,
сигнал,
then
та,
this would be a
тобто
signal
сигнал до лікаря, до
to the
медичного
doctor
персоналу, що на цю
to
картку, на цей
medically
код
created on
потрібно
this
звернути
code.
увагу,
You
тому
just
що
need
для
to
нас
point your attention
дуже
because
важливо
for us it's
конфіденційність,
very
збереження
important to have the
персональних даних.
confidentiality, preservation of personal
Тому
data.
ці алгоритми,
This is
вони
why
є
those algorithms
абсолютно
are
складними.
complex
І я
in
сподіваюся,
nature,
що
and I am
пілотування цих
hopeful that
моделей, воно
piloting of
покаже,
those models
наскільки
will actually
оптимізується
show
час
how
медичного
much do we
персоналу,
optimize the
адже
time of the
пацієнт
medical personnel,
перебуває в
because the
безпечному,
patient is in a
захищеному
safe,
просторі.
protected
Медичний
space.
персонал не
Medical
використовує
employees are
власні
not
месенджери,
using using
для
their
будь-якої
own
медичної
messengers or
інформації
anything else for
людей.
medical
Вони
information
працюють
about
згідно
the patient. They're
календаря.
working
Наскільки
according
це
to the
впливає
calendar.
на відповідальність
then
людини, тобто наскільки це
how much this
формує
is
звичку
influences the
людини
responsibility of a human
турбуватися про
being
своє
to take care
здоров'я,
of their
навіть
health
пити певну кількість
and
води
to
в день.
drink a sufficient
Тому
amount
що
of water,
туберкульоз
because TB
закінчується,
is finishing
але для
up,
нас
and
він не
then
закінчується
for us
останньою
it's not finishing
таблеткою.
up
Ми
as the
маємо
last
розуміти, що людина
tablet. We
має
need to understand that
повернутися
the
в
person
звичне
needs
життя,
to get back
що
into their
туберкульоз
regular
не має
life,
в неї
that
наслідки. Тому для
TB
нас
did
наша
not have
система, чому ми
consequences.
її
This is why
називаємо
for us,
простір
why are we
здоров'я,
calling this as the
це
health
щось, що
space.
допомагає
This is
людині
something that is helping the human
сформувати
being
оце
to
ставлення,
form
турботи
this
про себе,
treatment of
про
care
сон,
about
про
oneself, about the
культуру
sleep
звернення
culture of reaching out
до
for
психологів,
into a psychologist,
про
and then
відчуття
the feeling
вчитування
of
своїх відчуттів, своїх
understanding their own
настроїв. І
feelings.
таким чином ми хотіли б підтримати людей
And
в
that way
тому,
we wanted to
що
support people,
навіть важкі захворювання,
and
вони
even
бувають
complex
сучасним
conditions
підходом
are
і
with the modern
здатні,
approach,
тобто
and
його
they're
можна лікувати,
capable,
просто
so you can treat it by
використовуючи свій
just using
смартфон.
your smartphone.
Крім того,
Apart from that,
оці чекапи, про які я
those
сказала, вони
checkups that I
допоможуть
mentioned
фіксувати
before, they
прояв
will help us to
побічних
note
дій,
down
будь-яких
any adverse
відхилень з
reaction,
фізичного стану людини, про
anything that
які
goes
сповіщатиметься
awry, and
медичний
the
персонал.
condition
І
that
це
the medical
дуже
personnel will be
важливо,
informed
тому
about. And
що
this is very
не
important
може
because
пацієнт
the
комунікувати з
patient just
лікарем,
can't communicate with the doctor
неважливо, це амбулаторне
if it's an
лікування чи
ambulatory
психіатр,
treatment or
кожного
this is
дня по всьому,
psychiatry
що він
every day on
відчуває.
everything that
Оці
they're
чекапи,
feeling.
вони
So those
допоможуть
checkups, they will
зафіксувати
help to note
всі
down
побічні дії,
all
всі,
the
і потім
adverse
вже в
responses and
консультації з
reaction.
лікарем
Then
це
in a
можна буде
consultation with the
проговорити.
doctor,
Звісно,
this
якщо
can
це
be
важкі
discussed if this is not a
інтоксикаційні
complex
стани, коли потрібно
intoxication
негайне
where you
реагування,
just need to respond right
і
away.
все. Тому якби
And then
запис на аналізи, нагадування
the
про підготовку до
analysis,
аналізів,
and then
допомога
to get
підготовку з
ready for
аналізами.
testing, to
Такий
prepare
собі
for testing. So it's
асистент
such
твого
an
шляху
assistant of
лікування.
your pathway for
Це про
treatment.
наш відеодот.
This is
Звісно,
about our
ми,
video dot.
окрім
We are
того, що
also,
штучний
apart from the
інтелект
fact that we
є
are using
асистентом
AI,
людини,
which is an
ми
assistant to a
дуже
human being,
хотіли,
we are
щоб
also really
люди з
wanted to,
туберкульозом
for
не
people with TB,
дискримінувались
would
через
not
запис
be
відео,
discriminated from the
через
recordings
слово,
or
контроль,
something else, or
хоча контролювати
control or
захворювання ми
something,
маємо,
but we still are
але
obligated to
людину ми
control the
хотіли
disease, but we would
підтримувати.
like to
Тому
support a
в
human being
нашому
rather than just to control them.
ванімпакту
This is
є
why in One
відеодот,
Impact
і
there
люди
is video
зможуть
dot, and
проходити
people would be
лікування,
able to
знову ж
go
таки,
through treatment.
використовуючи,
And then yet
зберігаючи
again by
дані в
using
своєму
and preserving
телефоні,
their data in their
маючи
phones,
абсолютну
by having this
безпеку своїх даних,
a full and safety
розуміючи,
of
як
their
працює
data,
ця
by understanding
система,
like
хто
how the system is
обробляє
working,
їхні
who is
штучний
processing their
інтелект буде
video, and
навчений
AI will be
фіксувати
trained to
коректність
note down
прийому
the correctness
терапії,
of
буде
taking in the
давати
medication. They will
звіт
be giving the
лікарю
report to
про
doctors that
перебіг лікування.
how the treatment
Лікар
is
буде
going, and the
переглядати
doctor will be
відео,
reviewing the video,
особливо ті, які штучний
especially
інтелект
the ones that the
щитує як
AI is reading out
некоректні, для
as in
того, щоб вчасно
incorrect, so
впливати.
that timely
Але в
intervene.
цілому
But overall,
з віртуальним
with
асистентом
the virtual
ми
assistants and
сподіваємося на
everything else, we
більшу
are hopeful
довіру
for a
від
bigger
кожної
trust
людини
from
у тому,
every
що
single
будемо
person in terms
дізнаватися
that we
і
will get to
бачити,
know, and we'll be
як
seeing
перебігає
how does
туберкульоз
the
в
TB is
контексті
moving in the context of
додаткової корисної
additional
інформації і всіх
useful
можливостей,
information
тому
and
що
all the
якщо
possibilities
штучний
and
інтелект,
capacity.
не замінюючи лікаря,
Because
дійсно
if without
дійсно
replacing the doctor
зможе
and nurses, they would be able
оптимізувати
to optimize the
час,
time
не без втрати на якість лікування
without
і
losing
ефективність
for the
лікування. Ці рішення
effectiveness of
мають
treatment. These
перспективу в
solutions
нашій
have a
країні в
future in the
умовах
country
і кадрового
within the
дефіциту,
condition of
і
the workforce
навантаження,
deficit and then the
але
load, increased load,
зберігаючи
but they're still
основну
saying
мету, щоб люди
saving the main
лікувалися від
objective so the people
туберкульозу.
will be
І
treated from
трошки
TB.
покажу вам,
And now a few
що
words
ми робимо,
on what we are doing
що для нас система ванімпакту
and what the
віддзеркалені,
One
всі
Impact
дані, які
system
ми
and
отримуємо
so
від
all the
людей,
data that we're
ми
receiving from
трансформуємо в
from
програму. Ми
people, we are
намагаємося це
transforming into the
робити.
app. We are
І
trying to do that.
найбільше,
And
звісно, наше
the
те,
most
що ми
of our
вважаємо
things that we
досягненням, це
think that
існування
this is our
ресурсних
achievement,
кімнат
which is
для
the
дітей,
resource
які
rooms for children
дотичні до
that are
туберкульозу.
connected with
І
TB.
в нас
And then
в тому числі за
in the same way with the
підтримки
support
організації
of the
ПАС
path
і підтримки
organization, with
американського
support of the
народу, вже
American
відкривається
people,
7
we were already
просторів,
open 7
де діти
spaces
отримують
where
комплексну
children are receiving
психологічну допомогу,
comprehensive
вони відвідують
mental health
з ними
support.
працює психолог.
Their
Ці
psychologist
діти
is
не
working for them.
травмовані, вони
They're not
розуміють свій стан,
traumatized, they
і крім
understand
того,
their
вони
state
не
of health, and
ізольовані.
also
І
they're
хочу
not
звернути
isolated.
увагу
And I'd just like to point your attention Don't forget about your
це дитячі
t-shirts. We're
малюнки.
constantly
В
doing
нас
this is
є
the
багато
pictures
акцій
from children.
і
We have
заходів,
many
які ми проводимо на
activities
захист
and events
прав
that we are
дітей,
doing for the
тому
child
що
protection
від
rights, and
кожного
then
рішення
because from
дорослого
every
наслідки
solution
будуть
of the
зазнавати наші
adults,
діти. І
consequences will be felt by our children. And so by taking care of
майбутнє дитини,
the
хоча б в
future of the
контексті
child, at least in the
туберкульозу,
context of
ми з
TB,
вами можемо створювати
what we can
дійсно
do is we can
потужні,
create
орієнтовані
a
на
very
потреби
strong
людей програми,
human-centered
в яких ми не
programs,
можемо захистити
and
їх
then
від
where we
всіх
can't protect them
життєвих
from
явищ,
all of the
але ми
life's
точно
events,
можемо
but we
захистити
certainly
їх від
can protect
негативних
them
явищ
from the negative
туберкульозу,
things that
які
TB
не
can
будуть
bring that
травмувати
it's
людське
not going to be
життя. Ми
traumatizing
працюємо
human
над
life. So we are working
програмами,
on
над
the
статтями,
programs,
над
articles, on
методичними і,
methodological
звісно, над
recommendations, and also on
послугами
top
для
of
того, щоб вони
services, so
з'являлися
that
в нашій
the
державі
services would be appearing in our
за
country
фінансування
based on
держави,
the government
тому що
funding,
міжнародне
because
фінансування воно
international
нестійке
funding, it's
і
not
дуже
stable,
боляче, коли
and it's
гарні
really hard
програми
and painful when wonderful
закінчуються
programs are
з
just
закінченням
ending up
міжнародного
when the
фінансування. Тому
funding is finished.
я бажаю всім
Therefore, I wish you all
цікавої
to have a
конференції,
wonderful
беріть
and interesting
найкращі знання
conference,
для
take the
себе,
best
тому що
knowledge to
можливість
you,
навчатись
because the
і
ability to
розвиватися
learn and the
це
ability to
рух
study,
вперед,
this
і
is the
разом ми
movement forward, and
зможемо
only together we
дійсно
will be able
змінювати
to
наше
change
сьогодення для людей.
our
Дякую.
today for the people. Thank you so much for the
Дякую,
better
пані
tomorrow.
Ольго.
Thank
Ну,
you so much,
по-перше, за чудову
Olga,
презентацію,
for a
по-друге,
wonderful
за вашу
presentation,
роботу,
taken
таку
over for your
необхідну,
line
яку
of work,
проводите
which is
в
so much
своїй
needed that you're
організації.
doing in your organization.
Також надзвичайно
And
важливо,
also
що
such an
цифрові
important part that the
технології
digital
можуть
technology are
допомагати не лише
capable of
лікарям,
helping not just
а
to
й робити
doctors, but
підтримку
also to
людей, які
make the support for
проходять
people who
лікування,
are
які
coming for
потребують цього
treatment
більш
that
доступним,
require this, and
безпосередньо
make it more
і
accessible
персоналізованим.
and
А
personalized
ми
as
будемо
well.
рухатись
And
далі
we will be
і
moving
продовживши
on, and
тему
then by
цифрових
continuing the
інструментів
topic
у
of the digital
практичній
instruments
роботі
and the
лікаря,
practical
запрошую до
work of the
слова
doctor.
пані
We will
Марію
welcome to the
Дяченко,
floor Maria Dachenko,
представницю ТБ
the
Альянсу.
representative of TB
Вона
Alliance,
відповідає за
who is
розроблення,
responsible for the
реалізацію
development and
стратегій,
implementation of the
спрямованих на
strategy dedicated
забезпечення
to the
швидкого,
provision of
безперервного
the
і
rapid
сталого
and
доступу
continuous and
до нових форм лікування
uninterrupted
туберкульозу
access to the new regimens
національного
of
і
treatment by the
глобального
national
рівня.
and global
І тема
levels.
доповіді
And the
інформаційні
presentation
технології
topic, information
лікування
technologies and
туберкульозу.
treatment of TB,
Помічник лікаря в
the assistant
телефоні
to the doctor
сімейного
on the
лікаря.
phone and the family
Будь
doctor.
ласка,
Thank you so
пані
much,
Марія.
Дуже дякую.
Maria. Thank you so
Перше,
much as
дякую за
well. But first
можливість
of all,
сьогодні
thank you
бути
so
з
much for the
вами.
ability to be
Вітаю
here with you.
всіх
I welcome
учасників
everybody, all
онлайн.
the participants who is present
І
online.
перш за все хочу трішечки
And the first thing that I wanted to
розповісти про
tell a bit more about
саме організацію TB Альянс,
how the TB Alliance is organized
яку
and then
дуже
functioning.
коротко представили.
The
TB Альянс
short
це
list and
некомерційна
present TB Alliance is a
організація,
non-commercial
яка
organization that is
займається
dealing with
відкриттям,
the
розробкою та
opening,
забезпеченням
development, and provision
доступу
for the access to
нових
the
лікарських
novel
підходів для лікування
approaches,
туберкульозу.
treatment
І
regimens for
як
TB
ми всі
treatment, and then
розуміємо,
as we
в
all
організації
understand that
глобального
then
рівня,
the
які
organization of the
займаються
global level
розробкою
that are
лікарських
doing the
засобів,
development of the medications
в
and everything
напрямку як
else and the area of
туберкульоз,
work
вони
is TB,
фінансуються неприбутковими
their funding
організаціями,
with the
неприбутковими
NGOs or
донорами різних країн.
donors,
І,
foundations of
власне,
different countries.
питання
And then the
ефективності
question
витрат
of
для організації
effectiveness of
TB Альянс
expenditures for
є
organization
надзвичайно
like TB
складним,
Alliance is a
важливим,
very
тому що
complex
клінічні
and important
дослідження
part
це
because clinical
досить
research,
дороговартісна
it's an
історія, і
expensive
штучний інтелект
endeavor, and then
використовується
AI
не
is
лише
being
для
used is
забезпечення
not
доступу
just
до
to
лікарських
get
засобів,
access
але
to
і на всіх етапах
health products, but on
функціонування
all the stages of
організації, в тому
functioning of the
числі і на
organization,
етапі
and
відкриття,
also
і
in
на
the
етапі
stage of the
розробки,
opening
і,
organization,
власне, на
development
етапі
and organization, and
забезпечення
also on the
доступу. Дуже коротко
provision of
розповім,
access. So shortly,
яким чином
I can tell in
використовуються
which
вже
way
певний
do
час
we have for a
платформи
bit of
штучного
time the
інтелекту та
platform
машинного
for AI
навчання для
and
розробки, наприклад,
for the
знайомого нам
development
з
of
вами
the
режиму
well-known
терапії BIPAL та BIPAL-M
BIPAL and
використовувалось дуже
BIPAL-M.
багато
A
підходів,
lot of
які
different
також
approaches has
включають
been used that
штучний
also
інтелект.
included AI.
Це
And
перше
this was the first
аналіз, який дозволяє
analysis that
підготувати
allows us to
алгоритми
integrate
машинного
the
навчання
algorithms of
і
machine learning
сканувати дуже велику
and to
кількість
scan a
хімічних
very
сполук,
big number of
молекул на
chemicals,
перспективу і
molecules, so
оцінювати
the
їх
possibility and
перспективу
to
стати
assess their
лікарськими
possibility
засобами.
to become a
Це
medication. This
забезпечує те,
is
що штучний
providing the
інтелект
ability that
дозволяє нам
AI
уникнути
allows us to
помилок
avoid
при
making
виборі
mistakes in the
конкретних
selection of
компонентів майбутніх лікарських засобів.
components of future
Також
medications.
штучний інтелект дозволяє
And also
використовувати
AI
мережі
allows
для
us to use
масивного
neural networks
скринінгу,
for massive screening
проводити
and to conduct a assessment of drug-to-drug interaction or molecule-to-molecule interactions. We are trying to avoid mistakes by picking the molecules that will be establishing an adverse reaction or will be toxic in the combination.
Значно прискорює штучний інтелект
And
розробку
AI
аналіз
improves a
цих
lot
даних, які
the
ми
assessment of the
отримали
data that we are
в результаті
receiving and
клінічних
the
досліджень,
result of the
розробку
clinical research,
документів
the
для
development of
подачі, для
documents
схвалення препаратів,
for
нових
approval of
досліджених
medication,
препаратів
novel research,
регуляторними
and then
органами.
by the
Тобто
regulatory bodies so
використовується на
that they're
всіх етапах.
used in all the stages.
Також
And also,
замість просто оцінювати
instead of
існуючі
just
молекули
the
нуля,
assessment of the existing
штучний
molecules
інтелект
from the
допомагає
ground,
їх
the AI
проєктувати.
allows us to
Власне, він
create them.
може надати
So what it
вам
can do is it can
таку
give
модель
you
ідеальної
a
молекули,
model of ideal
яку ви повинні
molecule
потім
that
знайти
you
для
need
того, щоб вона
to
відповідала
find so
вашим
that they will
цілям.
be in line with your
Для цього
objectives.
також використовуються трішки інші платформи, але така робота також ведеться. Невідповідні молекули, тобто ті молекули, які
Another important factor would be in-compliance in case of molecular, which will be toxic because of drug-to-drug interaction, or those which might provide for the better number of such drug-to-drug interactions, which have to be preempted at the clinical trial phase, even before that. Also, there are some international platforms like TB Drug Accelerator, supported by the foundation of Bill and Melinda Gates, that bring together lots of different organizations, sharing their data and working together to find the most effective solutions for the future of TB care. And also the different combinations which have been designed with different token of AI support, such as simulation of drug-to-drug interaction, mathematic modeling of drug combinations. All of that is being allowing us to spare time, spare resources, to prevent from potentially experimenting with the combinations which might not be productive and finding the right solutions. One of the practical case and illustrations to that would be the BPAL, because this was the result of algorithm forecasting bedaquiline with predominant with 90% efficacy and compatibility, where mathematical model helped to generate the potent drug. And equal to that, the ancillary drugs, such as linezolid, which were included to that combination to make sure that BPAL would be as potent as it actually is today. Also, mathematical models allow us to assess the potential resistance patterns to predominate, and thus today we can be anticipating, as we are only designing the new molecules, which additional components to include into the regimen to make sure it will be potent against the potentially resistant strains to predominate in the future. So this is quite intensive and global effort which has been ongoing, and at different stages of this development process regarding each particular molecule and their component. Nevertheless, we do agree that artificial intelligence is a perfect thing to assess big data, but sometimes not explaining how that result was attained, and thus does not necessarily involve a high-profile expert and professional who will be assessing these links in between from the point of view of biological or pharma mechanisms. And also this relates to the difficulty of working with the pathogen, which has quite a strong and thick cellular wall, and that is something that artificial intelligence cannot simulate, particularly looking into the future. And this is where some man-made experience would be required. Lack of standardized data is another challenge, because sometimes the data is fragmented, especially in retrospective studies. There are different formats. There are questions regarding the quality and accuracy of the data, which will be translated into the poor quality of outcome, and of course the cost. The cost which is estimated for the similar tests and analysis. It's quite high, but yet such scope of performance, this speed of performance, which definitely requires quite significant investments into AI development and operation. But translating that into a real-life scenario where we can and should be using AI solutions in our everyday performance, this is where the couple of examples which I prepared for you will be quite helpful. Upscale TB and TB Navigator would be such examples, as they serve as a preview to the platforms to be localized in Ukraine together with our partners, with the Institute, National Public Health Center, and Ukraine, by the way, will be one of the pioneers to localize both of these platforms. And thus, we hope you find this appealing. There will be a lot of interest and feedback from you regarding their applicability, and this will be extremely helpful for us to continue improving such platforms to make sure they are quite meaningful for you in your clinical reasoning and practice. So let me explain what Upskill TB is. That's a digital learning platform. There is a national TB hub, which is an excellent online space for you to train for your CPD. Part of that is online, part is offline. By the way, there's always a question whether online training and learning is equally effective. In any case, and I believe the COVID times were quite helpful to teach us a lesson on that. But looking at the recent results of meta-analysis, we can see that the digital learning nowadays in 2026 is quite efficient. And in many cases, it demonstrates results which are comparable or even better to offline as compared to offline learning, because a lot depends on the availability, flexibility, certain freedom that you have as a student, remembering your busy routine. So having access to the augmenting platforms, augmenting meaning on top of the additional learning and training that you receive via the TB Hub, definitely that would be quite helpful in order to make sure that you keep your knowledge up to date. The Upskill TB, in its turn, is also a platform. I definitely will be sharing the links for you to consider. This is a free-of-charge platform designed by TB Alliance together with the partners from Indonesia, and currently it's being translated into different languages, including Ukrainian. So this is an online learning system which will be serving the purpose of keeping your knowledge up to date and replenishing your knowledge needs when and if required. And again, we are filling this platform with new blocks and new modules to make sure that it's quite diverse in terms of knowledge and expertise represented there. And we also will appreciate any requests from your side regarding the content to be represented there. And again, artificial intelligence here serves for the benefit of identifying the material and information for learning, and also delivering it in the student-friendly environment and format, and also providing you with additional materials and information, including publications, based on the nature of your knowledge request. This is where the AI assistant will be helping you to find the respective materials on top of the training module. Moreover, such platform provides different versions of training and formats, including video presentations, interactive cases, additional vis-a-vis forums for your consultation with different providers from different countries. As you can see, the Ukrainian language version is already available. But most importantly, we will be transferring all of the data, materials, and solutions to the National TB Hub, making sure that you can access them in a more convenient manner using the platform platform that you are comfortable with. Altogether, it has been translated into 8 languages. There's always voice-over function where videos are presented in the language of your convenience. Ukrainian one options is also in progress, so stay tuned for more. So video courses, interactive case management, discussion forum, pre-tests, post-tests, all of that is available for the convenience and learning for the students and candidates who would like to take either a fresher course or a refresher course. Also, that has inbuilt statistics, again available in the multilingual version with 8 languages. The experts who've been involved so far are represented here. They come from 6 different countries. I don't know if you can see any familiar faces, but in designing the future modules, we definitely will be inviting some of the national experts from Ukraine, as well as other high TB burden countries, and also those contributing to research and development in this sector, those collaborating with the World Health Organization, as well as the professionals who contributed to development of the BPAL regimen on behalf of the Alliance and having a lot of practical experience. Additional references and contacts along with the invitation to follow this link to get registered, to see whether this platform is appealing to you. But even without registration, you can access the platform, you can download the materials, so for future referral, even if you have no electricity and internet connection. So definitely this will be quite helpful knowledge hub and learning platform for your convenience. Another idea that we have designed for the benefit of integration in Ukraine together with our partners from the National Science Hub Center. Its earlier name was Managed TB. At that stage, it was a pilot intervention together with ICMR, our partners from India, together with the TB Alliance and other partners, which is an application which helps a clinician in clinical reasoning when it comes to prescription making in line with the national guidelines. I will demonstrate a couple of videos which demonstrate how it happens, but essentially this would be a digital guideline tool. Again, we won't be representing any individual data of the patient. It has to be secured, and we definitely do not store them, do not process, and do not share that. And any patient-relevant information will be codified under unique IDs. And then, based on the settings which are used by the clinician about the age, sex, body weight, or resistance data that you have from the laboratory, and such application will be offering to clinicians, based on the national algorithm, respective prompts regarding the regimen to be applied to that patient case. The target audience for such application would be most probably the family clinicians, as well as those professionals who might require additional updates because they don't communicate with such patients on a regular basis and might need some additional advice. So that's actually the case which triggered our intent to create such application. And again, seeing might better than hearing, and in Ukraine this will be available in Ukrainian language version with maybe a bit different visual interface, but now please wait a second. I hope this video will be rolling. Yes, now it should be rolling. So here you can see the opening page where you enter the patient relevant data. All of these settings will be designed by the administrator based at the National Scientific Center. And this can be modified depending on the national guidelines, which will be effective and up to date. And thus, the application will be only offering an advice. The final decision will be left with the clinician, with the expert. But here you will have prompts regarding the dosing, frequency of administration, and other important facts to be kept in mind, additional screening and testing which might be required. In other words, this would be a pocket tool which is friendly with application of clinical algorithms. And once we looked at its functional, we definitely realized that they should be updated in line with the clinical guidelines, and the regular updates will be boosted respectively to make sure we have full compliance with national regulations. This platform will also be quite fluent in terms of adaptation, and there will be multiple opportunities for additional modification without any delay to be initiated at the national level. And again, Ukraine will be the first country globally where such platform will be piloted, and we will appreciate any kind of feedback that you might have, as well as your comments and appraisal, because indeed we have to better understand how to make it better or worse. Definitely not worse, but better both for the Ukrainian users and users globally, making it more efficient in your work. I might be repetitive, but again, there are different countries who are considering great shift towards outpatient care, including therapy being prescribed by family practitioners or primary care providers in general, which is again one of the particular areas where such application could be helpful, and not only for the primary care providers but also for any other health professional involved under circumstances where particular advice regarding such regulations would be helpful. And making a summary, again, we have to acknowledge that artificial intelligence age has started. It's part of our everyday life, and there are different organizations working in the area of public health already using AI technologies, and TB Alliance is not an exception in that rule. There boosts the technology development. We also are developing the digital solutions for supporting the function of health providers for their training and learning. And looking to the future, we also can see many promising opportunities for cooperation with the National Center in terms of design, development, and localizing such solutions. So again, thank you for this wonderful opportunity, and looking forward to our productive cooperation. Thank you so much, dear Maria. This indeed was a very rich presentation in terms of content and information, and another obvious demonstration of the extent where digital solutions and artificial intelligence are becoming part of our everyday life and profession, including the clinical reasoning and decision making. Dear colleagues, please be reminded that you have an opportunity to enjoy in terms of suggesting your comments and asking questions, which will be discussed with our speakers by the end of the session. And with that, we are moving to our next speaker, and the presentation will be made by Madam Natalia Litvinenko, Chair of the Pulmonary TB Department and Head of the National Training Center for Professional Development Medical Workers at the National representative for pharmacy at the National Academy of Medical Sciences, and her presentation will be presenting educational platform as a guarantee of quality learning and the example of the National TB Hub.
Моя доповідь, вона буде логічним
Well, thank you so much. I think that my
продовженням
presentation is a
попередніх,
logical continuation to
тому
previous
що
ones
дійсно штучний інтелект
because the
крокує
AI
по
is
світу,
stepping in
крокує по
education and then
планеті, і все більше
more
таке
so
глибоке
it's
занурення цього
such a
інструменту
going in depth with this
спостерігається саме в
instrument
медичній
we're
галузі.
seeing
Ми
in
трошки вчора
health.
про це
Specifically,
говорили під час
yesterday we
сесії по
mentioned
діагностиці.
during the session on
Особливо те, що
diagnostics of
стосується
TB, and then
інструментальних
it's regarding the
методів,
instrumental methods in
бронхоскопії,
bronchoscopy,
радіології,
radiology,
комп'ютерної
computer
томограми.
CT,
Сьогодні була
and
дуже
other
цікава
things that
доповідь,
today
знову ж
there
таки,
has been
про
an interesting
використання
presentation on the
модулів
usage of the
штучного інтелекту
modular
при
for AI
скринінгу,
during
тобто
screening
оглядова
procedures, and then so
рентгенографія,
that the chest X-ray
флюорографія.
or fluorography, for
Все
example, can be
це
processed by AI.
повинно покращити
It's all has to improve
і наблизити медичну допомогу,
and get the
сучасну
medical
медичну
care, the
допомогу
modern
до
medical care
пацієнта.
to patients as
Все це
close as possible.
зрозуміло,
So
і
all
так
that is
воно і
clear,
повинно
and
бути,
then
але
it's supposed to be
навчання
that
не
way, but
може бути
training cannot
також
be
осторонь цього
also
процесу.
outside of
Якщо
this
ми
process. And
впроваджуємо
then
нові
if we are
інструменти в
implementing the new
сфері
instruments
виявлення,
in
діагностики і лікування різних
detection and
захворювань, так
diagnostics
само
of
якісь цифрові інструменти
some digital
на основі
instruments,
штучного інтелекту, чи просто якісь
and then
діджиталізовані
some
речі,
digitalized
також повинні
things, they
залучатися
also
в
have to
навчальний
be
процес.
included into the educational
І
process.
ми поділимося
And
нашим
now
досвідом.
we
Ми
will share our
використовуємо
experience, and we are using
сучасних
one of the
онлайн-платформ
modern online
навчання.
platforms for
Вона
training.
називається National
It
TB
is
Hub.
called the
До
National
речі,
TB
колеги,
Hub.
ви якраз
And
зараз
then,
її
dear
опробовуєте, ви
colleagues,
на цій
you're trying
платформі
it out, you're on the
реєструвалися, ви на
platform,
цій
you've
платформі
registered, and then
передивляєтесь стрім нашої конференції, на платформі будете
the stream of our
проходити тести.
conferences,
І дана
and then
презентація,
this
вона трошки,
presentation, it's
скажімо так, відкриє вам
will
скриньку
open
Пандори, а що
this
буває,
Pandora's
що
box,
відбувається
and then
з
what is
іншої
happening
сторони
from other
екрану.
side of the
Перш
screen,
ніж
essentially.
ми поговоримо про
Before
саму платформу і її
we
функціонал,
can speak about the
які
platform and its
передумови
functions,
створення
what are the
взагалі
preconditions,
нашого взагалі національного
then of
тренінгового
our
центру,
national training
тієї
center,
платформи,
and
на якій
then
ми
the
працюємо.
platform that we were working on.
Ми почали свою
And
тренінгову
then we
діяльність
started
задовго до
to
2020 року,
our training
але
activity till
сам
2020,
тренінговий
but
центр
the
був
training center
створений
was
якраз
established
за
at
кілька років до початку
and a
війни,
few times
але
before the
це був
beginning of the
COVID,
war, but this was during
потім
COVID,
в
and then
2022 повномасштабна
in
війна,
2022 the
і,
full-scale
звичайно,
invasion,
все
and
це
then
суттєво
all of
обмежило
that has
традиційне навчання
restricted
медичних
traditional
працівників.
training of
Тобто
medical
ці виклики,
workers. So
вони
those
нам допомогли
challenges that
зрозуміти,
helped us
що
to understand
треба
that
використовувати якісь
it's
інші
important to use other
інструменти, а не просто
instruments, and then
класичні
not
тренінги,
just
до яких всі звикли.
and
Одночасно,
challenges that we've all
це все
been through. So
співпало,
at the same
якщо ми
time, it's
говоримо
all
про
in
фтизіатрію,
together. If
про
you're speaking about
лікування,
the desiatry
виявлення,
or
діагностику
TB
лікування
medication
туберкульозу,
and
все
then
це
detection of
співпало
TB,
з
it's all go in
впровадженням
line with the
схем лікування
implementation of new
лікарського
regimens for
стійкого
treatment,
туберкульозу, оновлення нормативної
and
бази,
then
сучасних
update of the
клінічних
clinical base,
рекомендацій.
modern
І,
clinical
звичайно, не
recommendations, and
дивлячись
then
на виклики,
of
не
course,
дивлячись
because
на
of the
COVID, на
challenges,
війну,
because of COVID,
була
war,
дуже
other things, there
величезна
has been
потреба
a
в тому,
big
що в
need,
першу чергу фтизіатри на той
and
момент
desiatry for at that
вони
time
потребували навчання.
required training.
Україна потребувала на той момент
Ukraine
сучасного
required
освітнього простору,
a
іменно
modern
клінічного
access, for
простору,
example,
тому що ми
clinical
всі
space,
прекрасно
because all
знаємо,
of
є
us
чудова
understand
платформа
well, and there is a wonderful
на базі
platform
Центру громадського
and in public
здоров'я.
health centers.
Але, на мою думку, чим більше буде якісних,
But the more
високоспеціалізованих
highly
і
specialized
професійних освітніх платформ, тим більше
educational
буде
platform,
вибір у клініцистів,
the more
куди їм
choice they have
піти
to
навчатися.
where to start
І
training.
різноманіття якісних тренінгових центрів, воно
And the number of
створить
training
таке
centers.
позитивне конкурентне середовище в цій сфері. І ми долучилися до цього
we have
процесу.
added to this
Відповідь на
process.
ці виклики був створений
And then these challenges, there have
офіційно
been
наш National TB
our
Hub,
national
національний
TB
тренінговий
hub
центр на базі
and
державної
the
установи
training center based in the
Національного
National Institution, National
імунології і
Institution
онкології.
named
І
Dr.
тут треба,
Yanovsky. And then
звісно,
here,
сказати, що самі ми
first it's worth
цього б не
mentioning
зробили
that we
без
wouldn't be
підтримки
able to do this
партнерів, без
ourselves without the
підтримки
partner
донорів.
support,
Даний
donor
тренінговий
support in
центр
this training
був
center.
створений створений за підтримки
was created with the support
тоді
of
USAID, а зараз
USAID then, and
Державного
then
департаменту
the
США
State Department
і проєкту
to the
Support
US, and
TV,
then the
який
Support TV
реалізовує
project that is
міжнародна
implementing
організація PATH.
international organization named PATH.
Чому традиційне навчання перестало
Why
відповідати
traditional training
сучасним
is not in
потребам?
line with the
Ви
modern
логічно
requirements, and so
можете задати таке
logically
питання.
you can
Давайте
ask this
спробуємо
question. So
розібратися
let's
в
try
цьому
to get in depth
питанні.
with that, and then
Якщо у нас раніше
if
був якийсь
before we
окремий
had
тренінг,
like a separate training or
очний або онлайн захід,
online or
там
offline,
проводилось підвищення
then
кваліфікації
there
на
is
цьому
an improvement
навчальному заході,
qualification on that training
отримували
event, and then
знання,
they receive new
спеціалісти.
knowledge,
Ці
and
спеціалісти
then those
поверталися до
specialists would
практики,
get back to
застосовували ці
practice, they
знання у
would use it,
роботі,
the skills and
але
knowledge,
життя рухається дуже
but
динамічно, як і
it's
медична сфера.
dynamic and medical
З'являються нові
areas as well. New
рекомендації,
recommendations
нові
are popping up, and then
алгоритми
new algorithms
лікування,
for treatment
нові
are popping
препарати,
up, new
швидкі зміни в
medications popping
клінічній
up, rapid changes
практиці,
in clinical
оновлення
practice,
цих стандартів,
updates of those
оновлення
standards and updates of
підходів і технологій,
approaches and
з'являються нові
technologies. So
технології,
new
методи
technologies are
діагностики,
appearing, methods for
нове обладнання
diagnostics, new
медичне,
equipment, new
і
medical
знання
equipment,
поступово
and then the
втрачаються.
knowledge
І
is
оцей
slowly being
відсутність
lost,
цього
and so that
системного
absence of the
повторення та
system-wide
практики,
repetition in
воно
practice, it's
якби дало такий
has
поштовх
given this
до
push
тієї
to
концепції
the concept, and
тієї,
then
скажімо
to
так, такого виклику, як потреба в
the
повторному,
need and the
постійному
repeated,
повторному
constant,
навчанні для
repeated
підтримання
training for
компетентності.
the support of the competency.
Які типові обмеження традиційного
What typical
підходу?
solutions are restricted in
Це
there,
окремі навчальні заходи,
and then
на
separate
якісь окремі
events,
теми,
and
які
then
не
on separate
пов'язані між
topics that are
собою.
not connected between themselves,
Плюс відсутність супроводу
and
після
also
навчання,
no
фрагментовані
support after
цифрові
training,
інструменти,
and
які
then
використовувалися, як правило. Тобто
some
це
instrument
може
that has
просто
been used
платформа
before. So this
Zoom,
can be just a Zoom
розсилка по
platform,
емейл, можливо, якісь
sending on the
Google
email,
форми
maybe
для
some Google
тестування і
Forms
так далі.
for,
Але це кожен
and then but
тренінговий
every
центр, який не
training
має
centers
платформи,
that
він
doesn't
робить
have,
це хаотично на свій
it makes them
розсуд. І
chaotic
відсутність
in
системи
their decision, and then their
повторного
absence
навчання та оцінки знань. Але це
knowledge and
все
skills. But all
прекрасно,
of that,
коли
it's
тільки
wonderful when you
починалася
just started
система безперервного
this continuous
професійного
professional
розвитку, але ми
education
постійно
system. But
підвищуємо
Ministry of Health is
щодо
constantly
покращення
increasing the
якості
requirements and the
освіти.
improvement of quality of
І
education.
який же вихід?
And then
Вихід дуже простий. Це
what
для,
is the
скажімо, підвищення якості
for
викладання матеріалу,
the improvement of the
покращення якості
materials and
сприйняття,
quality of
спрощення
perception,
цього
and then
сприйняття.
improvement
Для
of the
цього
perception lines. For
наша
this
така
purpose, our
досвідом підкріплена думка, що
experience
кожний
exchange,
професійний тренінговий центр повинен мати свої
that every professional
освітні
trainings,
платформи.
and then
Потрібне навчання незалежно від місця
needed
роботи,
training
від
independently
формату
from the
проведення та
training, and
сучасних
then
викликів.
are the modern
І які ж ці
challenges and
виклики,
everything else, and what
наприклад,
are those
якщо ми
challenges?
говоримо про
If
освіту
we are
в
speaking about education in
у нас
TB,
з'явилися нові режими
we finally
лікування.
have new
Це
regimens for
зробили,
treatment,
і
as we
на
mentioned
цьому навчальному
before,
заході дуже
and in
багато
this
цьому
training event there has
приділяли
been
увагу.
many attention given to
Сталася
that, and then
неочікувана
there's an
пандемія
expected COVID-19
COVID-19,
pandemic
яка
happened to
загнала
be
весь світ в
that put the
пандемію,
whole
в
world
жорсткий
into the
карантин.
pandemic and into quarantine and
Але
other things. But
додатково до цього з'являються нові
together with
сучасні
that,
методи
there's new modern
діагностики,
methods for
оновлюються
diagnostics,
міжнародні рекомендації,
and then
плюс
there's new
додатково до всього
recommendations, and
цього
also
виклики
for
в
all that the
Україні.
military challenges in Ukraine, and then of
Треба
course
думати, як
we need to
удосконалювати
think how to
систему
improve
навчання.
the training
Якщо
system.
говорити
And
про шлях
then
національного
if you are to speak
тренінгового
about the National
центру,
Training
ми
Center pathway,
почали
then we
професійно
have started
займатися
to
навчанням,
professionally
ми
to
вважали, що
the
професійно в
training, we thought
2016
professionally.
І тільки в
And only in
2019 за
2019,
підтримки, знову ж таки, міжнародної
with the
організації
support of
PATH,
International Organization PATH,
був
the support
офіційно
TB,
створений національний
officially
тренінговий
created
центр на
National
базі
Training
нашого
Center
закладу.
on our active
Протягом
facility. And
21-22
then
років, не дивлячись на те, що
2021-2022, despite that there was pandemic, and
ми
then
розширювали свої освітні програми.
war
Ми формували
started,
їх степ-бай-степ, тобто
we
одна
formed them step
програма
by step, and then one app
іншу, і
moved
логіка
into another,
складання
and then the
тренінгового
logic of the
плану
training
була
plan
така,
doing, and
що
then
одна тема, вона є
the one
підґрунтям для
topic
того,
is
щоб
the backgrounds for
освітлювати наступну тему.
to
Тобто
install another
безперервність.
topic, so the
Плюс
continuous
додатково до того, по
education.
кожній темі
And then another
ми
topic, we
розробили
have
систему
developed
тренінгів,
the retraining
тобто
system,
повторення тих знань, менторингу,
repetition of knowledge. So we are
супервізію,
doing the
рівня отримання
supervision,
знань, і воно дуже
and receive
так
knowledge, and so
зайшла клініциста,
it started to
встановилась
be
клініцистом,
good for
це чудово.
clinicians,
Спеціалісти
um,
приходять на
and
ретренінги,
that they're going for retrainings,
і
and then
якби це, якщо все
and
спланувати
this, if everything to
правильно,
be
професійно,
planned
сучасно і креативно, то
modernly, creatively, and
людям
everything
буде
else,
дійсно
and
подобатись
then
і будуть приходити на навчання.
they would like and went for
Отримали,
training,
звичайно,
and
ми
so that they
провайдерство.
received the
Наш тренінговий
chances
центр
of
масштабований
providers. Our
по
training
всій
center has been
Україні,
scaled up
тобто
from
ми приймаємо
but
абсолютно
we
з
are
усіх куточків нашої
looking for
держави
all the pieces of our government, the
учасників,
participants, and then
наших колег,
our colleagues,
і
and
ми не
then
обмежуємося якимось
we are not restricted
регіоном.
in the specific region or
І
anything
в
of that
кінці
sort.
кінців
And then
освітні
in the end of the
заходи
day, the
перетворилися
educational
на
activity,
системну модель професійного
and then
розвитку.
the model from
І
your
якби мета всього
development.
цього – це якість.
And
Це
then
те,
the
що вимагає
quality
зараз
is what's
центр
required of the
покращення
center.
якості
And then
освіти. Там цей структурний підрозділ
this structural
Міністерства охорони
subdivision of
здоров'я навіть
Ministry of
є
Health,
у
they
назві
even
свого
included into the
структурного
name of their
підрозділу
structural
таке слово,
subdivision
як якість.
the word is quality.
Ну, якщо говорити по таким
And then if you're
блокам,
speaking about these
тобто,
blocks, and
яка
then
еволюція взагалі
what is the
повинна бути
evolution,
любої
there has to be
професійної
in the
моделі,
new
тобто
model, and
повинна
so
бути якась
that
підбірка
has to be like a selection of
майстер-класів,
trainings and master
тренінговий план.
classes, so
І знову
training
ж таки
plan,
хочу
and then
сказати, що тренінговий
I'd just
план
like to say
повинен
the
бути
training plan is
сформований по
supposed to be
якійсь
formed
логіці,
and
тобто
in
це не
some kind
повинні
of
бути
logic, so it's not
хаотичні
supposed to
теми
be chaotic
на
topics and
взагалі
then
різні теми
on a different
для того,
topics or
щоб
anything else, so
ті
that
спеціалісти, які
these
приходять
specialists that are
навчатися,
coming
вони
in
могли
to get
отримати з
training,
якогось
they could
питання і
get
базові
from some
знання, і
part
більш поглиблені знання,
more in-depth
більш якихось
knowledge
там вузьким питанням.
on
І
some
повинні бути,
wider things,
звичайно,
and then there
різнопланові
also has to
заходи.
be different planned activities.
Звісно, треба цей
And of
тренінговий
course,
центр
this training
офіційно
center has to be
створити,
officially
зареєструвати
created,
для
developed, and
формування
everything
освітнього
else. And
осередку
for the
національного
educational
рівня, звичайно,
part, and
провайдерство треба
also
мати.
need to
Як я
have the
вже
right to
казала, ми
conduct this
вважаємо,
training.
що
And then we
обов'язково
think that
повинна
it's a
бути
mandatory thing
освітня
that there
платформа,
has to be a
яка
training
дає доступ
platform
до
that gives you an
матеріалів,
access to
тестів,
materials,
квізів,
test
вебінарів,
cases,
аналітики,
webinars,
сертифікатів, все в
analytics,
одному
and
місці.
certificates in
І
one
це
place. And
створює
then
таку єдину
this
цифрову
creates the
екосистему
unified singular
навчання. Це
electronic
той
ecosystem for
сучасний
training.
рівень освіти, який,
And then
в
the
принципі,
certain
наближається
level
до
that is going
європейських
closer.
показників. І що стосується
And
нашої
what's considering
платформи,
our
National TB
platform,
Hub,
National
є
TB
цифровою
Hub,
платформою нового покоління.
there is a
В нашій
digital platform in
платформі
new
є три
generation.
блоки,
We have three
блоки.
blocks.
Це особистий кабінет учасника, особистий кабінет тренера і адмінплатформа.
So the user interface, trainer's
Правіше ви
interface,
можете бачити
admin
скріншоти
interface,
саме з особистого
and then
кабінету
the screenshots for the
учасників.
personal
Тобто є
rooms of
якийсь
participants. So
освітній
there is
захід,
like
який
an
має
educational event that they have
певний перелік
that has a
занять.
list of
І
tasks,
всередині це
and
ви
then
бачите верхній
inside you're
скріншот,
seeing
і
the
в
upper
нижньому
screenshot,
скріншоті
and
там, де
then
жовтенькі
and
плиточки,
that
це
has
вже
small
безпосередньо,
parts
коли
that
ви
this would
заходите
be when you're
всередину
understanding
якогось
that
заняття, там
a
уже
part of the
йде
training or anything else. And then
наповнення,
there's
залежно від
also,
того, яка тема
depending on
тренінгу,
which kind of
які
topic of
потреби
the training, what kind
тренінгу
of
і так
needs,
далі.
and so on and so forth,
Необмежена кількість занять
without the
може бути,
restricted
необмежена кількість наповнюючих матеріалів
the small
всередині
number of
кожного заняття.
materials
Тобто,
in
що у
every
нас
class.
там
So what is there
це
in your
відео і
personal
файлові
rooms, which is
лекції,
video and file
презентації,
lectures and
додаткові матеріали,
presentation,
література, тести до і після
and
тренінгові,
then
можна
test
робити
before and
тести,
after trainings, and
заняття,
then
запитання кейса учасників для
and
дискусії,
then
тобто у
cases for the
кожного
discussion. So
учасника, кожної
every
людини, яка навчається, є можливість
person
в
that's
будь-який
being
момент задати запитання.
trying to look,
Чітко всі
and then
бачать, кожен
everybody
учасник
can
свій
see
прогрес в навчанні, тобто
their
він
progress
може,
in training,
кожен
that they
учасник
can,
переглянути,
every
кожне
participant can
заняття,
review
які
that,
блоки
and
в
then
нього є по тому
what
чи
kind
іншому
of, if
заняттю.
they didn't pass anything, or
І, звичайно, сертифікати БПР,
then the
які,
certificates for continuous professional education that we are giving.
В чому перевага
And then what is the
цієї, цього
advantage
особистого
of
кабінету?
this international,
Незалежно
like
від
that they are working with
людина,
independent
якщо
on
вона
the
проходить
screen, and
навчання,
then
вона має доступ в будь-який
they have the
момент
access to
до
in any
особистого
moments
кабінету.
to
Що
their
таке
personal
особистий
rooms. And
кабінет
then the
тренера?
another room
задача цього
and
особистого
then the
кабінету
work
перевірити клінічні задачі і домашні
to
завдання
change the
учасників.
tasks and the
Це може
participants.
зробити
Everything can be done automatically.
автоматичний підрахунок
Automatic
результатів тестів, тобто
the
ніхто не
rules of the
сидить, не
test so that
рахує
nobody's sitting
на
down there
калькуляторі
and then now
відсоток
calculating
правильних
at the
відповідь кожного
correct number of
учасника.
answers for
Є
every
порівняльна
participant. There is
аналітика,
a
яка
comparison
миттєво
analytics
формується, наприклад, до і після тренінгового
before and after the
опитування.
test.
Автоматично формується
And then
список учасників і їх активність, тобто не треба
activities of
формувати
participants, so you don't need to
паперові
form
таблиці, списки, кудись там
lists
завантажувати
and
і так
everything
далі.
else. And then
Комунікація з учасниками йде постійна. Звісно, завантаження
then
матеріалів, запитів і ресурсів, ну і
the
планове-
materials and
планування
everything
заходів
else, and then
взагалі.
planning of activity.
Це ще раз якби
This is
повторення,
another
що входить в
thing,
особистий кабінет
comparing what is in
учасника.
the
І ось на цих
participant
фото ви можете
account.
бачити
And so this is
приклади
what you can see,
безпосередньо,
the
як
examples
на
of
лептопі виглядає
on the laptop,
особистий кабінет. На горі
the,
верхня
what it looks
фотографія
like,
це
and then
тести,
the
нижня
tests
це
are,
безпосередньо сам
then
кабінет. І також
the
остання
room itself.
фотографія
But
це
the
наша
last
платформа
pictures
має
is there.
абсолютно
Our
повноцінну
platform
мобільну
has a
версію.
full mobile
Якщо
version,
у
and
людини немає
then
можливості
if
з якогось
nobody has
комп'ютера,
the
лептопа заходити на
an
платформу,
ability
це можна
to
робити з
enter
телефону.
it can be
Абсолютно все
done
те
from the
саме, єдине, що за
phone, and then the
розміром,
only thing
звичайно,
is that
менше,
it's
просто,
lesser on the
скажімо
size,
так,
and
в
then it's
масштабі
just that in
краще,
this
звичайно,
scale, it's much better
навчатися на
to
більш-
study
більшому
for
екрані.
more of the
Ще раз, що таке кабінет викладача і
and then
адмінпанель?
the admin
Тобто це
panels,
можливість
which
все
can be
робити автоматично.
to do
Тобто
everything
немає
automatically.
ніякої потреби
And
ні
there's
адміністратора
no access
платформи, ні
to
тренера, що списати
not the
відгуки, складати
trainers or
якісь
somebody
таблиці,
else to make a
списки,
table, list,
аналітику, тобто все
analytics,
формує
and then
повністю платформа. Ось
the
як
platform
виглядає
forums. This is
адмінпанель.
panel
Наприклад,
looks
на
like.
цій фотографії ви можете бачити
On
навчальний
this part, you
прогрес
can
там
see the
якогось певного
progress for
тренінгу
a
з
training,
переліком учасників. Ось зелені ви бачите
and
такі
then you can see the
ползуночки, на яких видно, хто що
where you can
виконав,
see
у кого
who
які
did
борги.
what.
І якщо натиснути на кнопочку,
And
там де
then
діаграмка,
if you
там
have the diagram,
розгортається
there you
повна
have the
інформація
full
щодо кожного учасника, що
on
саме
the participants, what
заборгував той чи
specifically
інший
that
наш
person
колега, коли проходить
start to look
навчання.
for when they're going
Це
for
другий
training. And this
скріншот,
is
знову ж
the
таки,
second screenshot for the
це
administrative
список
panel, which is
учасників,
the list of
тобто, як я
participants.
вже казала, автоматично
And
все
then
це
automatically
перебирає,
everything is
зареєстровані
there,
анкети
and with the registration.
ці списки зберігаються
And then the list is being
за усі
connected
тренінги.
with all the trainings, and then they have filters, and then this list have filters so that you can have both in the progress and also in the participants list,
прізвищу,
and on the examples, under the specialty,
можна учасника забанити,
and then you
видалити,
can
якщо
ban,
хтось
and then
там
if
не за
somebody
профілем зайшов, там,
did
або
not
якщо
went
у
with
нас
their own
якісь там,
profile, and then if we
заходи
have
проходять
an
по
event that's coming in
узгодженим спискам,
and the
якась
previously
людина
approved
потрапила
lists, and then if
випадково в цей захід, то є
they somebody
можливість, знову ж
randomly
таки,
got
все це
there, so there is an ability
регулювати.
to regulate all of that. So why and how our platform is different from different services, and then the issue is with the two screenshot what it looks like, the clinical objective, and then to the pre-test and testing. So all of these stages of training are being integrated in the one environment, essentially. So we're creating one space for everybody. This is the National Hub platform. Test clinical cases, materials, and then for the admin and for trainers, this is analytics, communication, automatic issuing of the certificates. The platform itself generates certificates. So we are not developing and we are not putting by hand into every certificate the name and surname and everything else. Everything is being done by the platform. That you're doing this right now, it's in the same way it's going to be formed automatically. And then we have a big number of registered participants, and then you'll all go to tests, and then if you you have a few thousands of you, then you understand that it's going to be to form a list for a few thousand people. It's either 2 to 3,000 certificates. This is a big line of work. The platform is doing so in one click. So what do different users of the platforms are being used? And so as the participants, what kind of advantages? So the access to the tests and clinical cases and practical exercises for the development. And then progress, the courses and training activity, they're checking clinical objective, they're assessing the line of work to every participant, then automatic support for test and analysis, so that we are just analyzing, watching it through, and then we are not making the calculation ourselves. The communication with the participants through the speakers and everything else, and then the update of the contacts in the same environment. And then administrator or an organizers, and it's filled out with that, and then there is a overlapping of one event is happening for a few times, and then sysadmin doesn't need to fill, and then to additional event, and then and it's being done to a new event as well.
Детальна статистика, і безпека даних та відповідність вимогам.
And of course, we provide for the data security, integrity, and other security compliance. Looking into the variety of different events which can be facilitated in this platform, including webinars, conferences, online and offline, including all of the administrative proceedings such as registration, preliminary testing, sharing materials and feedback, all of that can be taking place via this platform. Another innovation launched this year would be a combined format events where, for example, the first part is taking place online. Usually that involves sharing the information, lectures, presentations, interactive sessions with case discussions included, and any other kind of interactive activities. And also that leaves enough space for you after such information sharing is fostered in the opening part over a course of 2 days of work, and the second day, the second part of such training or an online event will be focused on the material management and the feedback sharing. One of the examples is actually this conference. We're bringing together all of the advantages of such format. The first experiment we did when discussing the drug-resistant tuberculosis with the Support TB Alliance, which makes it quite feasible in terms of time and resources, because having a 5-day training is quite a challenge and quite a cost, but having 3 days in the online format followed by a 2-day offline event will make this more appealing and manageable. The more so that you can have different modules embedded into the agenda of such event, which take you to the final session of post-event assessment, examination, and production of the attendance or completion certificates. And of course, we have to look at the variety of subjects covered here. Modern TB, care and management approaches, including drug-resistant, ADEs, co-infection of infection and TB, pediatric TB, differentiated diagnostic. This is at the top of the charts on 1 hour alumni concomitant infections, associated diseases, modern microbiological diagnostics, and mental health, as well as mental and social support for people who live with TB. This would be my final slide, and you might have an impression that this is an excellent platform, which is functioning for numbers of years, and altogether we have 18,000 certificates produced as part of the CPD program. Earlier to that, before this system was established, we would be producing attendance and completion certificates even to greater number of alumni. All of the events, most of the events, as requested by the Education Certification Center, can be facilitated in our platform, including conferences, webinars, online and offline trainings, as well as combined trainings. This year, we have launched a non-pulmonary TB course, which also had a very good feedback among the students. More than 1,000 of colleagues have already registered for that course. So again, these are some promising numbers. Whether it's good or bad, enough or definitely not enough is up to you to judge. But in our humble opinion and in our humble efforts, remembering that we have the team of 4 people working in the National Training Center, me as the chair, Dr. Yulia as the didactic director, you met her in our conference already, and Anastasia Lefetova. I believe you know her quite well. She's managing our chat. All of those technical questions you are suggesting are managed by her effort. And looking at the impact we are making, speaking of the healthcare system and life and health of people living with TB, in our opinion, that would be quite an important contribution that we are making, because we are converting it into a modern tool and platform as part of continued professional development. Maybe this is just a small token, just a small share, just a minor contribution that we are investing, which helps us not only to preserve, but also to improve the HR capacity in this country at this time in this war. And thanks to our effort, healthcare professionals from different corners of our country received access to the modern recommendations, modern approaches and techniques. And the practice definitely suggests that even at the time of crisis, even at the time of war, you can and should find some mechanisms to share such innovations and knowledge in the healthcare sector with the broadest coverage possible. And last but not least, we became a platform for sharing clinical practice and bringing them together with national, international best practice. And we are happy to invite both national and international experts and speakers to different type of event. And we are doing our best to sustain that high level of expectations and performance, and to build some trends and traditions which will be fostering medical education in the area of TB and beyond that in the entire Ukraine. Thank you so much, dear Natalia. I believe all of our members in attendance of our audience were fascinated to listen to your presentation about such a powerful platform and mechanism that you have launched, allowing us not only to learn, but also to interact, raise questions and find answers, which is important. And with that, we have one more presentation as part of this session. We are happy to invite Alexei Kosivchenko, specialist on development and implementation of training programs in the area of international technical assistance projects, with a presentation about using AI to generate high-quality medical requests, basic steps and conditions for obtaining the relevant and professional information. Warmest greetings, dear conference participants. My name is Alexei Kosivchenko, and I would like to invite your attention to my presentation about using artificial intelligence to generate high-quality medical requests. what are the steps that you have observed in order to make sure you get the right answers to your requests. But let me first start by explaining how the generation of such requests take place. Because we are making a request with some context, which may not be presented in a format of text, but also a picture, a video, an audio fragment. Then the model is checking our constructed design of the request with the available algorithms and models, using additional tools for searching and analyzing files available in the big data systems. Then it will be generating the response, which will be matching all of the inputs. But there are some limitations and boundaries, because any generational model is not the original source of the respective information, and it may misinterpret some of the statements or miss some of the important elements in the continuum of data flow, or make a reference to a source which does not exist. That's why you need a high-quality request to be well formulated to enable the artificial intelligence to generate the respective response to your inquiry, which data to use, what should be the sources of such information, where the limit should be imposed, and what has to be validated by a human agent. So again, this is the difference between just a plain text generator versus AI augmented element in the medicine. To start with, we have to refer to the positional statement of WHO, which does not object using multimodal modalities in the medicine. Alternatively, they recognize the helpfulness in operations, administration, and communication between health professionals. But such potential opportunity should be bound with a very clear code of ethic and practical performance. For that benefit, I will be translating this into simple rules, which are quite fundamental. Number one, human has the control over decision-making. Then confidentiality and data integrity cannot be sacrificed for the benefit of convenience. Thirdly, artificial intelligence should be used in a transparent manner, transparent to the patient as well. Number four, any response should be scrutinized against integrity, non-biasness, relevance to the particular situation. And number five, accountability for any medical action cannot be shifted to the algorithm. WHO states quite clearly about the plausible or incomplete answers, as well as the risk of automatic trust, bias, and confidentiality breach, because even well-formulated request should be supervised by a human, and thus making the interaction with a model a better manageable one. Again, there is a question, why should health professionals use artificial intelligence? This is not the matter of delegating clinical reasoning and decisions, but just to reduce the burden of routine processing, and thus having more time to work with the patient and to apply clinical reasoning in 5 different areas, such as processing information, where summarizing some guidelines, comparing recommendations, or formulating a list of questions to be scrutinized. Next will be documentation processing. For example, drafting a letter, a memo, an SOP, any kind of template. Number 3 is communication. Explaining some complicated definitions using a plain language, which would be age-sensitive or language-sensitive and convenient for the patient. Then education and science would be number 4. Here we're saying that AI can be helpful in designing a case, designing a presentation, or doing some draft summary of a publication. Number 5 would be language support, including translation of conversation and materials. But in every case scenario, AI is an auxiliary tool If there are any patient-sensitive facts, then such environment should be secured for processing this information, and they should comply with the code of ethics of that facility. But most importantly, accountability and responsibility always lies with the clinician, because AI is an assistant, not a replacement. At this slide, I would like to invite your attention and discussion to the types of prompts which could be helpful today. Remembering this rapid development of AI, discussing the prompt patterns, which are quite helpful, but they should not be perceived as a magic formula to fit any case scenario, but rather as a type of interaction. For example, the pattern called persona allows to adapt language and style, but it does not make your request or response more relevant. Better, you should formulate the target audience. Are you targeting clinicians or nurses versus patients? How to identify the gaps, key assumptions, and the points and matters for verification. Another pattern for reverse cooperation is particularly helpful because first it suggests questions to collect the critically relevant context before producing the answer. Another pattern would be specifying a request, allowing the artificial intelligence to suggest a better version of the prompt prior to validation by the human. Another technique would be a few short, which would be quite helpful when you have to replay a particular format and style. And we're using up to 3 definite and obvious examples. And the final one would be the statement making prior to review and validation, but nevertheless without taking the merit of ascertaining the actual truthful manner. But again, sometimes you have to be quite specific about the style, format, boundaries, and the degree of criticality to which the human involvement should be deployed when working with artificial intelligence. But again, I would be suggesting that we should not be limiting ourselves with some rigid boundaries. They might be overlapping, starting with different areas, such as starting to set the task. When we explain what exactly we would like to have, memo, an SOP, a summary chart, or a summary of a document. The second block would be the data and the context. What kind of material are we contributing? Is it some kind of a clinical guideline, special instruction, a patient discharge sheet without personally identifying information, or maybe an image from a diagnostic proceeding describing the situation that in the information that we have available to ourselves? Thirdly, that would be the target audience, because the content will be the same for the patient, nurse, and clinician, but presented in a different version, different format, and using different definitions and terminology. Another important element of the high-quality prompt would be the boundaries and sources and verification. For example, using just this instruction without any suggestive dosing implications, please signify any uncertainties and list the elements for verification by a health professional. So again, you should not convert each of your requests into one full sheet in typing, but if there are any missing elements and gaps, then the model will be using assumptions instead of statements. But now, let me suggest having a quick interactive exercise which will help all of us to see what is good and not particularly well established with prompt generation. As an example, we are setting the task to describe how to use an inhalation device. You remember the 4 blocks that we have just discussed at the previous slide? So please put down in the comments to our broadcast what is missing in the request statement that you can see here in the screen. Please state at least 3 of them, 3 gaps, which you believe are significant at this stage in your opinion, and write that in the comments.
Так,
Okay.
подивимось, що є в коментарях.
Let me check the comment thread.
Так, ну добренько. Є
Okay,
правильні
excellent.
відповіді. Чудово. Як, в принципі,
Okay, there are
зазначено,
correct answers, as I mentioned
в
before.
коментарях, не
In the
вказано
comments,
насамперед тип,
It wasn't mentioned the
пристрою,
type of the
який саме
device,
інгалятор. Не
what type of
визначено,
inhaler,
для кого готується відповідь.
and to whom
Незрозуміло
the answer
формат
is. The
відповіді
format
має
isn't
бути
clear,
вказаний.
so what's
Чітко,
supposed to be,
покрокова
if it's a
пам'ять,
step-by-step
коротке
note, a
пояснення
short
чи, наприклад,
explanation,
перевірка техніки. І
and then
немає джерела та
and there's no
меж, на
source
що
and
має
no
спиратися модель і
restrictions. So
чого
where do
вона
they have
не
to,
повинна вгадувати.
and why do they have to mention?
На наступному слайді ми не просто зробимо запит довше,
And we're not just
ми
making it
додамо
longer
ті
because we're
елементи,
adding those
які
elements
реально змінюють якість
that
і
are
безпеку
changing the
результату.
quality and safety of the results.
Подивимось,
We
як
will
можна
have a look on
осучаснити
how
цей
we can
приклад,
modernize this example,
цього промпту з нашого
this
попереднього
prompt
слайду.
with our previous slide.
Поганий промпт, або
A
базовий
bad
такий
prompt
промпт
or basic
звучить
prompt.
так: напиши, як користуватися інгалятором. Він здається
Please tell me how to use an
зрозумілим
inhaler.
людині,
It feels
яка
like it's
тримає
easy to
пристрій
understand it
в
for
руках. Але для моделі в
whoever's
ньому
holding them in their
майже
hands, but in the
немає
model, they
контрольованого
almost don't have
контексту.
any controlled
Вона
context.
може,
They can, for example,
змішати техніку використання
the
різних
technique for
пристроїв
usage of
або
different
додати будь-які
equipment or
загальні
add
рекомендації, яких ми не
any
просили.
generalized recommendation that we did
Хороший
not
варіант
ask for.
промпту,
A
запиту
good
до
option for a
штучного інтелекту
prompt or for
починається
an AI
з даних.
starts with the
Ми
data.
додаємо чітку
We
фотографію
are
та, наприклад,
providing with
офіційні
information and then
інструкції.
official
Далі
instructions,
ставимо межу.
and then we are placing
Визначити
the
тип
borders to
лише за
the
чітко
type
виданими
on the visible
Якщо
signs.
маркування не читається, спочатку
If the marking
поставити
cannot be read,
уточнююче
first
запитання.
to
Потім
clarifying
визначаємо
question to be placed
аудиторію
first, and then
і
we are selecting the
результат.
audience and the results.
Наприклад, для пацієнта
For example, for
70
patients
років
of 70 years of age to prepare
українською 6 коротких
in
кроків
Ukrainian
і
6
розібрати
simple
типові
steps,
помилки.
and then typical
І
mistakes to
тут
be
ми,
looked
власне,
at.
обмежуємо джерело. Не додавати
So here is we're restricting the
рекомендації,
source not
з
to add
яких немає
recommendation
рестрикцій,
that
наприклад.
are not in the
І
packaging,
просимо
for
окремо
example,
зазначити, що має перевірити медичний
and what
працівник.
has to be checked by the medical
Зверніть
worker.
увагу,
You
ми
can put your attention
просимо
the fact that we are
модель
asking for this
перетворити
language model to
перевірене
turn
джерело
the
на
checked
зрозумілий
source to
матеріал
a
для
clear
пацієнта.
material for the patient.
Це хороший приклад того, як штучний інтелект може
It's a great
підсилити
example how an AI
комунікацію,
can
не
reinforce
виходячи,
communication without going
власне, за безпечні межі.
outside of the safe environment.
Сучасні моделі є
Modern
мультимодальними.
models are
В одному
multimodal.
діалозі вони можуть працювати
In one
з
dialogue, they can
зображенням,
work with
документами,
pictures,
документами,
documents,
голосом.
your
зручно,
voice,
але
and this
кожен
is
формат
easy
має
to use,
власні
but every
точки
format
ризику.
has their own
Для
risk
зображення
points. For
важливий
pictures, it's important to have
якість
the
і повнота кадру.
quality and fullness of the
Треба
picture. The
чітко
picture is fully
вказати, що
presented. It's
саме
worth mentioning what
аналізувати.
specifically
І
has to be
заборонити
analyzed,
вгадувати те, чого на зображенні, наприклад, не
and
видно.
not trying to think of something that's not on the picture or
Для
not
документа
quality.
слід зазначити його
For documents, worth
редакцію,
mentioning
дату,
the
статус,
edition, date,
і
status, and
попросити
then
спиратися саме
to
на
ask
нього.
to based on
Та
that document
посилатися на
specifically, and then
відповідний
refer to a specific
Водночас,
section.
чинність і
At the
застосовність
same time, the
документа
usage
ми
of the
обов'язково маємо
document,
перевірити
we have to
самостійно.
check ourselves.
При комунікації зі
During the
штучним
communication
інтелектом
with an
голосом,
AI,
тобто у
using your voice in voice interaction is critically important to have the short replics and then confirm the numbers, units, dosages, names of the medication, and other things. So the multimodality,
не скасовує промпт, вона додає
it
необхідність
doesn't cancel the
контролювати
prompt,
якість кожного матеріалу.
and it just helps you with
Якщо
the control of the
важливої
quality of every
інформації
material.
бракує,
If the important information is lacking,
модель має
then the
спочатку
model,
поставити
first of all, has to
уточнювальне
ask a
запитання,
clarifying question,
але не
but
заповнювати
without filling
прогалини
in the gaps
припущенням.
with the assumptions.
Ще один практичний сценарій – це
Another
звернення
practical
іноземного
example, which is the reach
пацієнта,
out of the
коли
international
немає
patients when
спільної
there's
мови.
no
Голосовий
joint ground.
помічник,
The
наприклад,
AI
такий
assistant,
як
for example, such as
ChatGPT,
the
може підтримувати
can
послідовний
support
переклад
the
протягом
consecutive
всієї розмови
interpretation,
і бути мовним містком для
and
первинного
then to be,
контакту, навігації або
and
короткого
then the
уточнення.
navigation and the short clarification.
Важливо одразу встановити
It's
чіткі
important to
правила.
have a specific rules and rights
Кожну репліку
to interpret
без
each
пояснень
line
і
without
медичних
explanation and medical
не
advice,
відповідати замість учасників
not answering instead
розмови,
of participants
критичні
of the
дані,
talk and the critical data,
назви
then
препаратів,
names of
дози,
the
алергії,
medication,
тощо,
allergies, and
обов'язково
everything else
уточнювати і повторювати.
to clarify and repeat.
Говорити краще короткими фразами
It's
та
better to speak with
робити
the
паузи
easy
після
to
перекладу.
to make pauses after the interpretation. You need to inform the patient on the usage of an AI and the personal data to be minimized as much as possible. But together that this is just an assistive instrument, but not a replacement of the medical interpreter's work. Or an informed consent, complex medical decision, or critical situation, you would need to have a good interpreter if they are available, but it's worth mentioning to test it out.
Цей голосовий помічник,
This voice assistant and then the function of interpretation.
В чаті GPT він
In ChatGPT, recently they have an update,
і він вміє вже
and now it knows to make pauses and then to add and ask, and in parallel even to look for information. As long as the discussion is going, very much recommend you to. It's very good for translations.
Після отримання відповіді потрібен не загальний
And after the
запит
answer, you
перевірити
not the
штучний
general
інтелект,
to
а
check the
4
AI,
конкретні рівні
but
професійного контролю.
or levels of professional control.
Перший пункт – це
First point is
факти і
the
джерела.
Facts and sources, whether the key ideas has been confirmed, if the documents have been confirmed. And then clinical context. Does the answer of this patient fits considering the contraindication, comorbidities, protocols, and then, for example, accessible resources. The level 3 is the gaps and assumption or biases, what the model might not take into account to simplify too much or to make it a stronger assumption. The fourth point that we want to point your attention, which is data and responsibility. Is it allowed to use the selected environment for this information? Has the data has been depersonalized and who is making final call? So the answers of the AI can be ready to use for professional checks, but not automatically for to be used. And as a finishing touches, there's 5 questions that you can use as the short checklist before every medical request to an AI. What objective does not supposed to fulfill, and then to whom, what language, and in which format you need an answer. And how can I check?
Якщо ми можемо чітко відповісти на ці 5 запитань,
and if we can answer those 5 questions, then for us we don't need to have a magical formula for prompt. We have created a process that is manageable
прискорити
AI
роботу
can
з документами,
reinforce the working with the
допомогти
documents,
структурувати і
help you to
адаптувати
structure and
інформацію,
adapt the information,
аналізувати зображення
analyze the
та, наприклад,
pictures,
долати
and
мовний
then
бар'єр,
to
як
fight the
в
language
ситуації
barrier, as
з
in the situation with
послідовним
the
перекладом
consecutive
допомогою
interpretation
voice
using
mode.
voice
Але
mode.
якісний запит лише
But a
спрямовує
good quality request is just
точність і
directing the
безпеку
model.
забезпечують
The safety and
надійні
everything else
дані,
being provided by the
чесні
stable
джерела,
data,
чіткі межі
active
та
sources, specific
професійна
mining, and
перевірка
professional
людиною.
checks by the human
Дякую
being.
за увагу.
Thank you so much for your attention.
Дякуємо, Олексій, за таку чудову
Thank you so much, Alexi, for
практичну
such a wonderful
презентацію, яка
practical
дійсно може
presentation that
стати
really
помічником
can become
нам,
an assistant
лікарям,
to
для того,
us
щоб
doctors
спілкуватися
to
штучним
talk
інтелектом.
to the
І
AI.
хочу відразу,
And I
раз ви
also
вже з
like
нами,
to, since
задати вам запитання.
you're
Я
here
так
with
думаю,
us,
що
to
до вас
ask a question,
звертаються
I think
лікарі
that
по допомогу.
doctors are
От
reaching
хотілося
out to
б
you
почути
to
вашу
get
думку,
care and
яку
assistance. I
найбільшу
would like to think
помилку
that
роблять
what is the
лікарі,
biggest
медичні
mistake that doctors are
працівники, коли
doing, medical
спілкуються з
representatives, when
штучним
they're talking to
інтелектом?
AI?
Що ми робимо частіше
What are
не
we
так?
doing wrong in most
Пані
cases?
Марино, доброго дня ще раз.
Marina,
Дякую
greetings to you.
за
Thank you so much
запитання.
for this question.
Ну, хотів би так
I would just
сказати,
really like to
що
say
найчастіше
that the
все
most
ж
frequent
це
one,
коли люди
it's when people
не використовують
are
власне
not
цю
using
опору,
this
про яку ми кажемо.
basics
Тобто
of the
прompt може
prompt. So
бути
the prompt can be
недетальним, не зазначеним
non-detail
чітко
without saying
межі,
specifically
джерела,
the sources,
література.
subjective
Коли
literature,
ми
or when
даємо запит штучному інтелекту один
asking an
з
AI
видів,
for one
власне,
of the
промптів,
types of the prompts,
промпт-патернів, коли ми
the
просимо
prompt patterns, when we are asking an AI to give us a link to sources that we're using, people are not usually checking or not pressing those searches and they're not following them through. And then sometimes it happens that right now, as a development of an AI, this situation is much more rare in occurrence than we had before, but the percentage of the hallucination is still high.
Вони можуть бути недійсними.
Those links might not be active. So it looks like
така правдоподобна відповідь,
a truthful answer that I mentioned before in the presentation that this is one of the risks.
Але насправді,
But in reality,
після переходу за
after
посиланням,
you're watching the
воно, власне,
link,
буде,
it's
не
just
існуючим
not
або
going to
просто
be
недійсним.
in anything that's of
Обов'язково
existence, and then
треба
you would just have to recheck everything and not using things for clinical decision making first, the information that is being provided by the ChatGPT.
Перевірка. І
You
також
need another checks, and so also one of the frequent issues that is being present, which is when, for example, like a big files are being loaded in Gemini or ChatGPT or in Claude. With all of those AIs, there can be the same issue that they're starting to hallucinate when then there's a big amount of information. If you want to translate recommendation of WHO from on the safe use of AI, for example, in one of the slides, there have been the link. You can go back and review them and then to find those recommendations and to read them out. It's very interesting. And then, for example, if you're loading and downloading the whole file into the AI, it will accept it and you ask it to translate it and then into Ukrainian or to do a summary. The risk that because of the amount of information the model will not be able to effectively process it and will give you not the most accurate answers. And some of the points, for example, right now is very, very high. This is why if you're using this for translation, summarization, scientific literature, anything of that sort, to divide it, the PDF by a few portion and then to do it block by block and to ask them to do the summary on each and every part, not in all the document, but then there is a risk that the AI can be doing something wrong. Maybe this is the most likely situation. Why the document has been loaded, but the answer might be at some stage not certain. The first 3 pages is all great, but then page 6, there might be a mistake. And then for a person, it's harder to check the document right up front. Then at least partially, if it's a presentation or an Excel, you're loading
підготувати
for
якісь
a
дані,
group
проаналізувати тощо.
to
Робіть
analyze something,
паузи,
then just make a
потрошки
pause and
завантажуйте,
slowly but surely don't overload the
чат, який ви використовуєте,
just
ось
one
це
chat,
діалогове віконечко.
just one dialog window, and
Для
then
різних завдань можете
for different
використовувати
objectives
різні
can
ці
be used
діалогові
different
віконці, тоді
dialog
відповідь
windows, and then
буде
the answers will
краще.
be better.
Дякую, Олексій. Ну, ще раз
Thank you so much, Alexei.
ідентичні поради. Я думаю, що лікарі
Thank you so much for
задоволені
wonderful
цим
advice. I think that doctors will take this into account and will be able to use it. Thank you so much once again. I'd just like to ask if Yulia Dudko is here with us, or
Добре, тоді наступне запитання
then
до
the
пані
next
Юлії.
question is to Yulia.
Хотілося б узнати,
We wanted to
як ви
ask
вважаєте,
you
чи
is what do
готові
you
на
think?
даному
Are
етапі заклади
at this
наші
stage health
охорони
facilities are
здоров'я до
ready
впровадження от
for
штучного
the
інтелекту
implementation of
та
AI
медичну службу?
into
І
the
якщо
X-ray service? And then
є
if
якісь проблеми, то які є
there are
бар'єри,
issues and what
що
kind of barriers are
перешкоджають
there,
вам?
what is obstructing us in moving forward in that area?
Дякую за запитання.
Thank you so much for your question.
Моя думка, що
My
всі
idea
заклади
is that all
готові
the
до
facilities are ready for the
впровадження
implementation of the
трансформації
and
своєї
transformation of their
епідеміологічної
X-ray
служби.
service.
Ми стикнулися,
And we have
напевно,
faced,
що з
I
найбільшою
think, was the
проблемою це
biggest
все ж
issue,
таки
which is the
супротив деяких
um,
колег,
resistance of some of the colleagues, some of the doctors, and we all understand that
деяким людям
some
дуже
people
важко призвичаїтись
find it
до
really
чогось
hard to
нового,
adapt to something new and
навчатися
novel,
новим
to
технологіям,
learn new
особливо
technologies,
колегам,
especially
які вже
for
працюють
colleagues
дуже
that has
багато
been working
років.
for many, many years before.
Тому перше це
And then the
супротив
first thing, which is this
колег,
resistance from the
друге
colleagues,
це
and the
те, що це
second thing is
потребує
that this requires a
додаткового навчання все ж
additional
таки.
training still. It's not
І
just out of the box kind of thing or plug and play, but most likely that some of the
скепсис, скептизму
skepticism
з боку все ж
from this
таки
side of
адміністрації, так?
administration of the
Тому
hospitals,
що і пацієнти
because the
наші
patients that we have are not ready to perceive
що їх знімки буде
that their
аналізувати робот, так?
scans will be analyzed by the doctor and
Але ми
not
завжди
by
пояснюємо,
a
що це
a
допоміжний
physical person. But this is an
інструмент,
assistive
потрібно
instrument. You
боятися
don't have to be
штучного
afraid of an
інтелекту,
AI.
потрібно
You
навпаки
just need to, on the contrary,
вникати в
try
ці
to
нові
get in depth
технології
of those
і
new
розуміти, що
technologies and
дійсно у
try
нас
to
зараз
understand
дуже
it.
велике
Right now,
навантаження,
there is
дуже
a
багато
very big load. There
пацієнтів
is a lot of
пов'язано
patient. This is connected
і
with
з
the
військовим станом, так?
military and
Тому
with others as well. And then
ймовірність там
the
пропустити
chances to miss
малопомітну патологію
a
все ж таки
not well-known
висока.
pathology
А так
is
як
still
ми
remains
застосовуємо
very
штучний
high. And
інтелект
since
як
we are using
допоміжний
AI as an
інструмент, це нам
assistive instrument
допомагає
for
в
us, this
подальшому
helps
мінімізувати ці
to minimize
пропуски і
those
покращити
gaps
все
and
ж
then to
таки
improve
якість нашої
on the
діагностики
quality of our
і
diagnostics
більш точно
and to be more
виставити в
precise and to
подальшому
give
і
a more correct
клінічний
diagnosis
діагноз
and the
і
clinical
співпрацювати
diagnosis
з
as well, and then
лікарями-клініцистами.
cooperate with the
В
clinicians
нашій лікарні
in
і
our hospital and
лікарі-клініцисти
the clinicians as
будь-яких
well as
відділень
any other
можуть
department.
застосовувати
They're
технології
capable of
штучного
using
інтелекту
AI
через цю інформаційну
through
систему
this
PACS.
information system PACS.
Тому, напевно, це
This is
такі
why I
три
think
основні
that those are
виклики, з
three main
якими
challenges that we
стикнулись ми на власному
have faced
досвіді.
in our
Але
experience
не
so
потрібно
far. But
боятися
you don't have to be really afraid of that,
нового, потрібно
of anything.
навпаки
You just need to embrace it
сприймати
and
це
perceive
як
it as
позитивне, за
a
цим
net
майбутнє наше.
positive, because the future, and this is
Тому
something the future holds for
треба
us.
працювати з
This
новими
is why we need to
технологіями.
just start using new and
Дуже
novel
дякую, Юлія.
technology. Thank you so much,
Сподіваюся,
Yulia,
що
and
ваші
hopefully
треба буде багато
and
часу для того,
we
щоб
won't need a lot of time
преодоліти
to
ці бар'єри,
fight those
сказали.
barriers that you just mentioned before. Also hopeful.
Також до пані
I would
Ірини
also have a
таку
question to
ще
Irina
запитання.
within the discussion,
Я
a
це запитання
question.
вчора задавала,
I
у нас
asked
була
this
сесія.
yesterday and we had a session on,
Пробачте, будь
I beg your
ласка.
pardon, to Yulia.
Пробачте.
And
Я це питання задавала
I asked
вчора
this question
спеціалісту по
yesterday to the
орбітальній
specialists on the
томограмі,
CT
які був у нас
tomography that
з
have been there in the
диференційної
differential diagnostic
І
session.
якраз
And then
в тому плані, що
in
ці всі
that
модулі,
portion, that
які
all those
включають
modules
штучний
that
інтелект,
are including
в
AI
радіологічній
in the
діагностиці,
radio
вони
and
в першу чергу
radiology, they are
заточені
first
на
and
те,
foremost are
що
allocated to the
вони
fact that
якось
the
100%
norm
розпізнають як норму.
they are
Є
seeing as
такі
norm in
рекомендації
100% of
від
cases.
керівників.
There
Я це
are
вчора казала на
manufacturer recommendations that yesterday I mentioned in the session that
була на
personally
конференції міжнародній,
I've been
і
in
ми
international
послухали
conference, and
усіх
so we
виробників, і вони прям, ну, як
approach the
позиціонують
manufacturers, and so
так,
they
що
position
якщо
themselves that if this
говорять,
module
що це
is
норма,
telling that
можна
this
не
is norm, then you
перевіряти,
don't
це
have to be
дійсно
checked, and
норма,
this is
а
most
тільки
likely
там, де
norm. And
він
only
бачить
when
патологію, це
they're seeing a
ну, відправляти до
pathology, then this
експерта,
has to be
до
sent to an
людини, який
expert, to
буде
a
далі
person
це
that will be
оцінювати. От як ви до
assessing it any
такого
further. So how are
алгоритму
you
відноситесь?
treating that
Наскільки
algorithm? To
дані
which extent
модулі
those
готові
modules
до,
are ready to
скажімо, такої взаємодії?
deployment?
Дякую за запитання.
Thank you so
Теж
much for the
скажу з
question.
власного
Let me
досвіду, з
tell you from
власної
my own
роботи.
experience, from my own line of
Дивлячись,
work,
з
that
якими модулями ми
depending on which
працюємо. У
modules
нас
you're working
є
with,
два модулі
because we
штучного
have two main
інтелекту. Це
modules for
який
AI,
менеджер
which is
корейського
maybe
виробництва
Enter of
і
the
Lead Insight
and
корейського.
Lead Insight from
Скажу
Korea. And
за
let me just
heavy.
tell regarding the
Штучний
heavy
інтелект заточений
AI is
розпізнавати
based on
норму,
to
так.
recognize the norm,
Але
yes, but
норму він
the norm
розпізнає,
it
знаєте, дуже
sees
детально.
as the
Тобто
really in detail, so the hyperdiagnostics.
Він
Because
навіть
it's even
розповсюджена проблема на
a spread out problem on the
рентгенографії
X-ray,
клітки,
the
він
chest
виділяє,
X-ray, for
наприклад,
example, it
сосни
highlights, for example,
як
nipples
патологічні
as the
зміни.
pathological
Але ж ми з цим не
changes, but we
погоджуємось,
are
не
not agreeing with that,
погоджуємось.
right?
Якщо він,
And if
наприклад, на верхівках легень
on the
на
apex on
початку
the lungs in
не
the beginning, they
розпізнавав
did not
кальцинати,
see that there is a
а пише
classification
норму, ми
and just saying
перепровіряємо
it's
такі
normal, then we
зміни.
are
Тобто я не
rechecking those
погоджуюсь з
scans. So
думкою,
I
що
don't agree with the
якщо він
idea that if
виділяє
it says
норму, то не
that
потрібно
it's normal,
перепровіряти.
then you don't need
На
to recheck.
початку, коли
At the beginning, when
ви почнете користуватися
you'll
даними
start
модулями,
using these
ви
modules,
зрозумієте,
you will
що
understand that
ви навчаєте поки що
you're
штучний
teaching
інтелект.
AI to
У
work.
нас з березня 25-го
From
року
March of
цей модуль
2025,
встановлений.
this module has
І
been installed,
перший
and then
рік
the
ми
first
навчали
year we were
штучний
training
інтелект. Ми
AI and
аналізували
not vice
кожен
versa. We
знімок,
were analyzing
навіть
each
якщо там була
scan,
норма.
even if it was normal.
Всі нюанси, з
All
якими
of the
не
nuances
погоджуються
that the
ендокринологи,
doctors,
ми
X-ray
аналізуємо
specialists
ці
were not
зміни і
agreeing with, we are
відправляємо
analyzing,
розробникам.
we're sending this
Ми
to the
пояснюємо,
manufacturers, and we're
в цьому
explaining that
випадку ти не
in
додивився,
such a case, you
штучний
didn't,
інтелект
the
не додивився,
AI
що на
didn't
верхівках
check
легень
fully
є
that on the apex of the lung there is the classification.
З кожною
With
такою
every
взаємодією з
such
розробником
interaction with the
чутливість
developer, the
штучного
sensitivity
інтелекту,
of the
вона
AI
збільшується.
is
І
growing.
вже
And
пройшов термін, рік ми
now the time
пропрацювали,
has
і я
went,
хочу
we've
сказати,
worked
що
for a year, and I would like to say
все
that
ж таки
sensitivity
покращилась. Тепер
has
він
improved. So
виділяє
right now
кальцинати на
it's seeing the
верхівках,
classification of the
наприклад, не
apexes, and then
виділяє
does
соски
not
як
sort of the
додаткові
nipples as additional
вузлики або
nodes
зміни.
or
Тому на початку все
shadows.
одно
And
ви
then
повинні
at the beginning,
розуміти,
you still
що
need to understand
ці
that
модулі
those
нові,
modules are
ці
new.
модулі
Those
тестуються
modules
якраз
are being
таки
tested on
на лікарнях, з якими
the hospitals
працюють.
which they're working
Тобто
with.
ми зараз
Therefore,
по суті
we
навчаємо
right now are
ці
just
модулі,
training
як
those modules as
працювати,
they
як
how to work,
розпізнати
how to
патологію, як
understand that there is a
розпізнати норму.
pathology, how to understand that there is something is normal.
Моя думка така.
This is why this is
На
my
даний момент
idea. So
можна
at this
сказати,
moment, we
що
can say
лікар
that
є
the
помічником
doctor is an
штучного
assistant in
інтелекту,
the
да?
AI.
Так, і я
Yes,
впевнена,
yes,
що
yes, and I'm
Говоримо про
sure that it's
штучний інтелект,
that
помічник
AI
лікаря,
is an
тут
assistant to the
навпаки.
doctor, and here vice versa.
навпаки, да, я впевнена, що от перші 5 років ми прям будемо навчати.
Well, I am absolutely convinced that in the period of the closest 5 years, we still will be learning and learning and learning. And as well as the AI will be learning and learning as well. And again, the model becomes more sensitive and is catching every possible detail of pathological modification. But if artificial intelligence start detecting the norm as pathology, we should be happy because that means the AI found something. And that means plus enhanced quality of imaging that will be serving in our best interest. Very thoughtful observation and helpful for our participants indeed. And I'm happy we're having this discussion. Thank you so much. I do understand we have almost zero time left, but still there is a couple of questions to raise for the benefit of this discussion. First of all, dear Olga, I had a lot of interest when listening to your presentation, so let me inquire kindly about the level of awareness regarding those people who need support from your organization. So your clientele, your beneficiaries, are they aware about your organization and how can they access it? Well, thank you for your question. This is quite a painful question to be addressed for our organization because the answer is no. If you're looking for a short version. Speaking of an extensive answer, this is not just a matter of one impact, but also last year we conducted a survey regarding awareness of patients, regarding their diagnosis and their treatment strategy, including the current patients who've been on medicated support for a long time, or who enjoyed social support for quite a long time. And quite a substantial part of that clientele did not have full information regarding their health needs, the details about their treatment course. And in case of the so-called stressful diagnosis, they should never be enough. It takes time to consume information, to digest information, and to convert that information to some conscious thinking. So definitely we need some well-established communication algorithms. It took us 8 years to establish. Now we are entering the domain of primary healthcare, and informational awareness there is zero. So we have to be well prepared. We have to work quite intensively to make sure that information flow, education patterns will be made appealing, accessible, and available for the people who otherwise are getting lost. They're getting lost between different types of services and service providers, and they come to see us. Yes, they heard the impact somewhere, but they cannot formulate their assistance request appropriately. They don't know where to go, what to look for, what to ask for, and how to accept the information and assistance that they can actually enjoy. And in the survey responses, we also are trying to better understand how they come to get infected, how they come to learn about their current status, what was the point of them accessing the system, what was the point of referral, what is their communication with a family care provider versus special care provider, because that means a lot, and we have to access that information and make sure that information is available to the patients, which will guide them along the therapeutic pathway, will guide them about their rights and freedoms, and they should know where to find that information instead of going to a doctor in case they get unemployed, inviting the clinician to address some of their social workers. Alternatively, they should not be discussing their migraine or rash with a social worker. Instead, they should know where to go and what to ask, and we need all of the answers to be made available for their benefit, making sure all of them access the system, access the information, and definitely we have not enough time, not enough resources, but we will be doing that. Again, last but not least, my final question goes to Madam Natalia as the chair of the training center. Could you explain just in general what is the future and what are the ambitions that your training center is persisting currently? Do you have an ambition of bringing together not only TB care, but other areas of expertise which are close to TB care? Well, first of all, we are planning that, and we do that together. And indeed, we have to be moving forward. We continue improving our platform with the support from our partners. And also we enjoy this opportunity like it originally was available and still is. And again, comparing the situation before and now, you can see the drastic changes, just like some basic trim in a vehicle versus the premium trim of the same model of vehicle, but way better equipped. But again, there's no limit to perfection, and we will continue improving our platform to facilitate even greater number of events types of events, and topics to be covered in those events. As you remember, we started with TB subjects exclusively. Now we step into the domain of differentiated diagnostics, which is as well as mental health, none other pulmonary diseases. Also, we should be covering that, having topical events associated therewith, and also elevating the status of the training center. We have the national status at this moment, but we should be seeking international recognition via certification process. Obviously, we won't be able to accomplish that independently, so we have to do it together with the partners, with the public health center. Also that all of our partners are very strongly committed to encourage and facilitate that process. So definitely just sitting still is not our performance style. Thank you so much, Natalia. I'm afraid we have exhausted our time frame, but before we finish, let me summarize once again. This is not the artificial intelligence which is providing the treatment by the clinician. Clinicians, they should be provided with additional tools to improve the process of treating and healing the patient. And on that note, I'm happy to thank all of the participants, panelists, and the delegates. Now we will have a quick break, and in a couple of minutes, we'll be flipping the page to the next, our final session under the agenda. And for all those who missed our early announcement, the post-event testing will take place online between 1700 and 1730 hours. And this will be a precondition to generation of your attendance and completion certificate and your CPD credits announcement. So with that, please be invited to have the rest, and we'll be staying tuned to see you soon.
Шановні колеги, ще раз всім добрий день і розпочинаємо нашу чергову сесію
Dear participants, good day to you. And we're starting another
який
session of our event that
присвячений
is dedicated to the
здоров'ю
One Health
без бар'єрів.
without
І дана
barriers.
сесія,
And this
вона
session,
буде торкатися
it's
основних
going to be referring to the main
вітчизняних
international and
підходів,
national
діагностики
approaches to
та ведення
diagnostics and
інших
management
захворювань
of
легень.
other
Ця
lung
сесія,
conditions apart from
напевно,
TB. This
сама
session,
важлива,
I think, is the most
тому
important
що
because
диференційна діагностика
differential
і правильне
diagnostics and
раннє
the correct,
своєчасне
early, and
встановлення правильного
timely
діагнозу це вже
diagnosis.
не
This
те, що
is
половина
not just
успіху, а
half
це
of success story, but this is more so 70 to 80% of
від того
success stories
результату,
from
який ми
the results
отримаємо
that we are
даної
getting
людини.
in this
І
person.
лікування, воно не
And then the
повинно
treatment
ґрунтуватися
is
на
not supposed to be
якихось
based on
умозаключеннях, а повинно
like
мати
conclusions,
об'єктивні
assumption, but needs to
міжнародно
have an
визнані
objective, internationally
критерії.
recognized
І для
criteria,
того, щоб
and
відрізняти
to differentiate
інфільтративні вогнищеві зміни в легенях,
infiltrative changes in the
ми, не
lungs.
дивлячись на те, ким є на даний
Despite with
момент,
who we
хтось
are,
із нас є
some of us
сімейним
are
лікарем,
a
хтось
family doctor,
пульмонологом,
some of
хтось
us are a
педіатром,
pulmonologist,
але
somebody is
розбиратися в
the
усій легеневій
TB
патології
doctor, but to
потрібно
understand all the
кожному
lung
лікарю,
pathology needs every
який
doctor
має
that
диплом
has a diploma
і який
and that
повинен в першу
has
чергу
to first and
правильно
foremost
встановити діагноз.
to correctly put the
Наша
diagnosis.
сесія,
Our
вона
session,
торкнеться
it is going to touch upon
бронхообструктивних захворювань,
bronchoobstructive conditions,
інтерстиційних
sarcoidosis,
пневмоній,
interstitial pneumonias,
неопластичних захворювань,
neoplastics,
онкоутворень в
oncological
легенях і
conditions in the lungs, and
бронхоектитичної хвороби.
bronchoectatic
І
disease.
розпочнемо ми
And we will
із
start
саме
off
бронхообструктивних
with the
захворювань легень,
bronchoobstructive
як
conditions of the lungs as
основного
the main
супутнього стану при туберкульозі,
comorbidity in
які
TB
існують нові
that
міжнародні
exist, what kind
підходи
of
щодо
new
діагностики
international
та
approaches
лікування.
exist on
І
treatment
я
and
з великим
diagnostics, and with the
задоволенням
great
передаю
pleasure,
слово
I would
для
like to
цієї
pass the floor for
доповіді
this
пану
wonderful
Миколі
presentation to
Островському. Він
Mykola
є
Ostrowski,
завідувачем кафедри фтизіатрії і
who is the head
пульмонології
of the TB
з курсу
department
професійних
with the
хвороб
course of the professional
Івано-Франківського
diseases of
національного
Ivano-Frankivsk
медичного
National Medical
університету,
University.
є доктором медичних наук,
He's a doctor of medical
професором,
sciences, a
заслуженим
professor,
діячем науки і техніки
a
України. Пане Миколо, будь
renowned
ласка,
professor. And so
запрошуємо
the
вас
Mykola,
до
the floor
доповіді.
is yours.
Слава Україні!
Glory to Ukraine.
Дякую за запрошення.
Thank you so much for welcoming me to this floor. And we are really starting off in terms of the comorbidities and then sometimes the pathology that's making the TB, and then that makes this much more vulnerable to the activation of Mycobacterium TB. And next 20 minutes, we can speak about the bronchoobstructive conditions. So we specifically know and remember that the diagnosis TB is supported with the chronic bronchitis. It's also supported with the chronic obstructive lung disease in the a bit rare number of cases, and for some reason, sometimes it's the bronchial asthma, forgetting that under the controller and the bronchial asthma is the inhalation corticosteroids. And so when you're speaking about the inhalational corticosteroids, we understand that when you're speaking about the system-wide corticosteroids, we have the system immunosuppression, but when we're speaking about the inhalational corticosteroids, hormonal medication, then we are speaking about the local immunosuppression that sometimes opens the doors or the windows for mycobacterial infection to sit on top of. And in the same way as in this tricho practice, and in the same patient with the diagnosis COPD and bronchial asthma, we have a specific protocols and list of people and a list of things. And so that by citing the Fashenko Ukrainian Pulmonological School, National Pulmonological School is going hand in hand, or like was the time, and our local national protocols are in line with the global strategies on planet Earth. Therefore, when we are mentioning about the diagnostic, differential diagnostics, and the treatment of such a pathology as COPD or bronchial asthma, I would just like to quote Ian Paul II that not live, not love, and not dying to triumph, but there's also those diagnoses, they're not just putting this to your own discretion, we have strategies. So why did we take the obstructive pathology of the lungs? So here is everything done top 10 list of mortalities in the world based on the WHO data. You can see that number 4 place the chronic obstructive lung disease. You can see the place number 5, which is infection of lower airways, and you can see the place number 10, the consolidation of our yesterday's and today's meeting, which is the pathology that's called tuberculosis. Regarding the differential diagnostics of bronchial asthma, so here it's very much simple. I would just like to remind you that bronchial asthma is a heterogeneous disease. Bronchial asthma usually starts in childhood. And so this is a disease is more so to the younger cohort of the patients and the stages of its manifestation. In the same way, compared with the chronic obstructive lung disease or chronic bronchitis, and also if you take the pathophysiologically, if this is the dominant cells in the bronchial asthma are eosinophils, and that type of inflammation compared to the chronic obstructive lung disease, where the main part is played in the big groups of patient is being played by neutrophils, and this is a typical example of neutrophilic inflammation going on. And the most important part for us, for after which the diagnosis COPD or bronchial asthma does not have any legal force, which is the assessment of external breathing function. We need to remember that in asthma, bronchial obstruction is reversible, and in chronic obstructive lung disease or COPD, the bronchial obstruction is irreversible. With the latest years, we're looking for and observing drifting, essentially, bronchial asthma as a typical eosinophilic process into the side of neutrophilization of the inflammation, and vice versa. What we're seeing is that in chronic obstructive lung disease, they're growing in numbers of eosinophilic manifestations that makes us always to remember that on the eosinophilic process, the most intellectual influence would be is the usage of anti-inflammatory treatment, inhalation corticosteroid, which ones we will get in depth later. And that way, which way this pathogenetic picture will open up as of today? It's all of that is very dynamic. COPD can be brightly neutrophilic in a few years, and then the domination of eosinophils. And after that, and vice versa, then are getting back to neutrophils, and the same comes with the bronchial asthma. And this picture is showing us that as of today, I think the most top thing is not just the endothelial dysfunction to which we got used to, but there is the actual matter of the dysfunction of epithelium of the respiratory tract, and which side this process will go to, we can only control, for example, as of today, the lymphopoietin. And so that we have such a volcano, we have a weapon that can model this transmitter. This fire medication was the non-hormonal medication, which was successfully used in our patients. And we want to mention that for all of us to understand here, then we are speaking about the bronchial asthma. We do have the controller inhalation corticosteroid, and we cannot take bronchial asthma. And selective diagnosis and the diagnosis, they've been merged together with the TB without the usage of controller medication. Number 1, which is the disease-modifying therapy for bronchial asthma. And this type of intervention in a chronic obstructive pulmonary disease that's not there, we're still searching. Maybe the influence in TSLP, aspires, and then will probably be declared as the disease-modifying treatment in COPD at a time. As you can see, that the chronic inflammation leads to the structural changes in lungs, and this is going to be finishing up with the destruction of the parenchyma of the lungs. So we understand specifically that the chronic inflammation under the influence of triggers present here, see viruses, bacteria. Also, mycobacterium tuberculosis will cause the structural changes in the lungs, will cause the destruction of parenchyma, will have a hyperplasia, remodulation of the airways, remodulation of the epithelium, respiratory tract, and then with the inflammation and a lot of mucus destroying alveoli, and emphysema and everything else. And this would be providing the restricted parts of the breath. So when we're speaking about the chronic obstructive pulmonary disease, so that for us, we understand what is the background of the treatment of the chronic obstructive lung disease or pulmonary disease. So when Peter James Barnes, he was the pulmonologist of the Queen, then the only reversible mechanisms of the chronic obstructive pulmonary disease is cholinergic mechanisms. And so we know that COPD is supported by this stable bronchoobstruction from the description of AI or from our intellect or description of rentgenologist. We know that there is an X-ray picture at the beginning stages of COPD, which is the lung gates of the lung, and then so where it is the Stauchmolocus morbi, which is the bigger bronchi and the medium bronchi as well. On this location of the bronchi, in an inhale, they have 90% of resistance to air. So when we have a strong bronchoobstruction, we understand well that the bronchus has been shortened, luminous molar. So what is the air velocity? The air velocity will be higher. And this air, by having the higher velocity, will be entering at the intact or a healthy bronchus of a smaller caliber in the patient. And later on, by going through the terminal bronchioli, then they're rushing through to alveoli. And instead of just as they opening as a flower, 16 times a minute, every breath in going to be the entrance of the higher pressure air and the alveoli. So what would be the response? There's two ways: either just collapsing, which is called emphysema of the lung, or it starts to have starts to produce connective tissue, and this is called pneumosclerosis. And emphysema and pneumosclerosis is two reversible ways to COPD to function. This is why we understand that to have a high quality and to fight bronchoobstruction and COPD, we need to widen bronchus and median bronchus, what kind of receptors they have, and then they have M-cholinic receptors. And in TB or non-TB, chronic obstructive lung disease. And then they're trying to get stable bronchoobstructions and then fighting the medication and prolonged bronchiolitis. And then depending on the number of exacerbation, the patient is separated clinical groups A, B, and clinical group C. So when we are speaking about the clinical group A and B, we understand that they have a zero complication. They can be a simple complication or exacerbation, then that's incorrectly to say that the patient doesn't have any exacerbation, only that they can get in clinical group A or B. They have a right for a simple or mild exacerbation, but don't have what has to be in the doctor's head, that we have under control the inflammatory process, but there is still bronchoobstruction, after which the COPD cannot really exist. And so we understand where the beginning of bronchoobstruction, we understand how faster fresh air they can lead to pneumosclerosis, emphysema, and other things. So we are working with a prolonged analytics. A period of time, and it started to manifest. You mentioned this is a clinical group B, and that not only dry cough, but they started to have whistling sounds, and this is the bronchitis that can be spasm that much that doesn't have anything, and you will actually hear this whistling sound. We understand that the small bronchus has actually participated when the beta-2 adrenaline receptors are started. We were adding them to cholinergic treatment, prolonged beta-2 adrenaline mimetics, and so only when the patient has either one or two exacerbations, then we are getting into the critical group E, and we understand that under control there is a complication and the inflammation process is going out of the way. And to such patient, we are adding inhalation corticosteroids. Whether it's going to be a double treatment or a triple treatment, or is this going to be 3 molecules and different devices, or this is going to be 1 3-component model for inhaler that would allow us to have all those moments. that require our medicational intervention. We need to remember that based on the latest recommendation, Goldie and other national documents that we're having, when we're starting a patient to use inhalation corticosteroids and COPD, you don't cancel it out. There are reasons when you can cancel them out, when the treatment was started incorrectly or didn't get in depth. This is the mild exacerbation. We are told that if there's no exacerbation, that there's no hormones. If there are exacerbations, forgot to say that this is the mild exacerbation. They have a right to live without inhalation corticosteroids. And so we've started to treat them with inhalation corticosteroids. The treatment was not started in the correct way, so there was no response for the inhalation corticosteroids, and so there are significant side effects or pneumonia that we mentioned during bronchial asthma. But here I would just like to mention that the art is to, during in parallel infection made by bacterial tuberculosis, when we work with the corticosteroids and asthma. So our art is in the choosing the molecule, and here I'm demonstrating a big research of almost 50,000 patients, a meta-analysis of 18 randomized clinical trials that are specifically telling us that increased risk of pneumonia is associated with the use of fluticasone. And when you're using budesonide, there was no increased no risk levels of other things. And so why is it happening that way? Let's look at this slide. You can all see that budesonide likes water, which is a hydrophilic molecule. And the alveoli from the inside have a surfactant, which is bronchus, terminal bronchus, and the small caliber bronchi. And so we need to remember that the surfactant is phosphatidylcholine for 67% or something, phosphatidylcholine, which is a lipid. And budesonide does not like lipids. Budesonide likes water. It's not being held in lipids. And 6 minutes from the moment of inhalation, molecule budesonide, it's already working with your receptors, and it doesn't cause like any other effects like immunosuppression and other things. And when you're using fluticasone molecule the same period of time, which is lipophilic, which is sticks into the lipids, and this molecule will be working in 8 hours as well. So what is done by budesonide in 6 minutes with fluticasone would have more than 8 hours for that. And this is the difference, and this is not great. It's a class-specific effect. And you don't need to have a phobia to usage of inhalation corticosteroids as the class of medication. You just need to understand specifically which molecule to pick, especially when you have a suspicion or present comorbidity or mycobacterial infection that is called tuberculosis in any given form or localization. In bronchial asthma, then we mentioned before that the treatment of patient with the bronchial asthma diagnosis with TB or without TB, without usage of disease-modifying treatment, without using the medication, control number 1 on inhalation corticosteroid is a nonsense. You just need to send them to, I don't know, to a different diploma, and then therefore we have to use inhalational corticosteroids. We need to understand that to bronchial asthma, apart from COPD, the locus morbus is the smaller bronchi that are rich in beta-2 adrenal receptors. And for a patient to feel at ease, we need to widen those bronchi so that they can spasm so much when he will be feeling easier, sometimes can cough. Can you imagine what kind of thing there is, and or to which extent how the whistling sounds is on top of the insipid for COPD is more so than the dry coughing sound. And then so we need to use the molecule that is called prolonged beta-2 adrenomimetic. And then the gene in our documents in the molecule that it's called formoterol. And this molecule formoterol, it's the winner because this is a prolonged action cholineolytics, but this is the fast acting beta-2 adrenomimetics. Formoterol works as fast as the salbutamol. They're asking the first, second, and third minute, just as the molecule of short acting beta-2 adrenomimetic. And tell me which molecule would you add to a fast-acting prolonged-action beta-2-adrenomymetic formoterol to synchronize the activity of both molecules? The one that's acting in 8 hours, formoterol is working under 3 hours, 3 minutes, beg your pardon, fluticasone fully open in 8 hours. Or to a rapid molecule beta-2-adrenomymetic for formoterol will be added a molecule that is working at the hours minute 6 in scolbudesonide. This is the pathway 1. It's more so research. It's much more simpler for patients with the bronchial asthma. So what is the advantage the patient is receiving by inhaling formoterol and budesonide? The patient is feeling the same rapid improvement of their status that they felt before from salbutamol, but with every in-breath, they're taking a small dose of the control medication that is called budesonide. And this medication can be used in the combination with basic and on-demand, which is called a smart option, compared to the pathway 2, where to simplify the symptoms, we are continuing, as in the hypothesis, the short-acting adrenomymetic salbutamol, and then the patient felt more at ease, and then the patient will be using the controller medication that is called fluticasone, which is an alternative pathway. And here we just need to make sure that the patient will be following the daily controlling therapy using the controller medication, and so that we need to specifically understand the advantages of pathway 1 and pathway 2. As of today, it's proven that the combination medication is Symbicort and others, budesonide formoterol, and a smart option. It reduces the risks of complicated exacerbation. This is only because that with every inhale, even by demand or on demand, the patient will be receiving controller, a smaller dose of inhalational corticosteroids with the molecule called budesonide, and not going to be receiving salbutamol. On top of that, you remember about the things that are called the local immunosuppression and the risk of development of pneumonia, the COPD, and then the bronchial asthma. When you're using budesonide, then you're not really taking this into account. And also in TB, you don't have local immunosuppression when you're using different molecules. Please remember that you have a better pathway that you can help the patient with to receive smile on their faces. Another issue that COPD and mucus, this is a wonderful media that allows us to think that different bacteria might be coming in tandem, and you can see how big the number of publication is. If you're seeing COPD and closing this mucus plaques and hypersecretion, it's important the sign of COPD and progression of and if it's in the precision therapy and the separate, the obstructing with mucus of the airways, they decrease, we see the decrease in quality of life, lung function decrease in pneumonia and everything else, and also for TB. High level of hospitalization, death, and mortality. 73% of patients with the COPD that have this mucus plaques, and then in 5 years, you can also see those plaques that are obstructing the airways with COPD are connected with the higher risk of mortality. As the development of the patient can tell you this because in the morning it's hard to cough this mucus, and I would just like to show you the medication, the molecular and erdostain that influences cough and inflammation. It blocks and the trypsin, the reduces interleukin 6 and then increases the level of respiratory immunoglobulin 2, and more than that, it goes in part of the basic treatment of COPD. And difficulty starts from the 2019. As of today, you can see the conclusions of another research. This is the effective of the erdostain that was received independently from the patient history or complications or exacerbation, and the journal the decrease in the complications or exacerbation despite the use of corticosteroid. The decrease in number of was the cough and was the cold 3 and 4. Amazing molecule, and the joint development of which today Fashchenko has been headed there. The name was the National Institute of Physiatry and Pulmonology, named after Yanovsky, and then Ivano-Frankivsk city, the lung disease center, and what you can see that we are with a success story. We use Remitin in Remitin was the post-COVID-19 syndrome, and also in the same time such patients that had other comorbidities at the time as well. And you can see the intraviral effects of Christine Milan, the school. You can see that how tropic it is to inhibiting the SARS-CoV-2 respiratory syncytial virus. And then as of today, there's two forms, and in front of you this oral form, and then there's tableted form, but in the suspension that can also be used by patients that have gastrostoma and even in adult age, not just in pediatric practice. The patients that have nasogastral tubes and cannot swallow well, and also is what I would just like to finish my presentation with. During COPD and other conditions and in tuberculosis, we need compliance to treatment of our patient. They can have the best inhalers in the world but not be using them. They can have the best dose strategy in treatment and not taking the medication. This is our joint problem and issues that are dealing with the respiratory pathology, and because the compliance to treatment is from 55 to 50%. This is the really low. By finishing up, I would just like to say thank you for your attention and to say that the person is not living but flying, but they do have the wings, not just their pharmaceutical molecules and decisions that are giving us those wings, but also such an events as we're having right now under the Professor Litvinenko and other colleagues connected with the academician Feszchenko and others. We are receiving the things that are allowing us to not to go in between but fly on top of the forest by helping our patient with different options. So their respiratory pathology. Thank you so much for your attention.
Дуже дякуємо, пане
Thank you so
Микола.
much, dear
Дійсно,
Mikola.
бронхообструктивні
Really, bronchoobstructive
захворювання
conditions
це
and diseases are
біч
an issue of
любої легеневої
any
патології,
lung
вогнищево
pathology,
інфільтративної,
and then
і в першу чергу, звісно, туберкульозу,
also for
і в
TB,
першу чергу за
and also
причини
for
того,
these reasons
що
that
так складається, що
it
пацієнти,
made in a
які
way
мають
that the
туберкульоз,
patient that having TB,
частота
the
паління
frequency of
у таких
smoking
людей дуже висока. Це
is
як
very
основний
high. This is the
тригерний
main
фактор
trigger
розвитку
factor
хозл,
of
тому
the development
дійсно,
of COPD as
якщо
well.
ми
Therefore, if we
хочемо
are,
допомагати
if we want to help and
пацієнту,
assist
і зараз
patients,
такий підхід
and right now
в
such an
Міністерстві
approach is
охорони
present in
здоров'я,
Ministry of
що ми
Health
лікуємо не
that we are
хворобу, а
treating not a
людину. В
disease of
принципі,
the
такий
person.
підход був завжди.
This approach was always,
Але
but yet again,
зараз навіть і
right
покази до
now, even the indication for
госпіталізації,
the
і взагалі видача
hospitalization
груп інвалідності і
and
так
given the
далі
disability
йде
group and
по
other things is
порушенням
going on the
функціонального стану.
functional
То
disturbance.
може бути така
And then
ситуація,
it
що
can be a
пацієнт,
situation
який
on the
має
patient that
невеличкий
has
обмежений
a smaller
туберкульоз, але
restricted
тяжкий
TB,
хозл,
but
і його
very hard
функціональний
COPD,
стан
its functional
сумарно по
status
двом
is overall,
захворюванням буде
and two
дуже
diseases will
тяжкий.
be very hard.
Хоча туберкульоз
Even though
сам по
TB
собі
in
не буде
itself
мати
is
такого
not
серйозного
having
клінічного
this
значення.
clinical manifestation or
Ще раз хочу
I would like
подякувати,
to
і
say
пане
thank you once
Миколо,
again.
хочу вас
And
також
Mikola,
попросити залишатися
and
в
then I would like
стрімі
for you to stay
до
in
кінця
stream
сесії, тому що
till
в
the end of
кінці
the session,
передбачається
because in the end
дискусія.
we're gonna have a
Колеги,
discussion,
а вас дуже
and then
просимо задавати питання всім спікерам і пані
and then
Миколі. Ось ви
all the
прослухали
speakers and to
першу
Mikola.
презентацію, можливо,
And
вже
in
є
the
у вас
first
питання.
presentation, maybe you'll
Ми
have
все
other
це
questions,
фіксуємо,
and then we are
озвучуємо
noting
їх
this
під час
down,
дискусії.
and we will
А ми
voice
з
them
вами
during the
будемо
discussion, and
рухатись
so we'll
далі.
be moving forward.
І наступна
And
дуже
then the
така
next
серйозна
the next
і патологія, яка і
pathology
маскується під
that is masking
туберкульоз,
under
дуже часто
TB, and then
супроводжує туберкульоз,
frequently
це
supports
саркоїдоз
TB,
легень.
sarcoidosis of the
І
lungs,
я думаю, всім нам
and then to
не
all of
буде
us,
і
it's
не
not going to be
завадить, і не буде зайвим
obstructing us
згадати оновлені міжнародні
to remember
протоколи
updated
діагностики та
protocols.
лікування цього захворювання. І на цю тему ми поговоримо
And then
з
this
Любомиром
topic
Проциком,
with
старший
can talk with
науковий
Lumir Procek, the
співробітник,
senior scientific
зараз уже
employee
завідувач відділення туберкульозу легень
in the Department
в
of TB of the
Національному
lung,
науковому центрі
National
фтизіатрії,
Scientific Centers,
пульмонології, алергології імені Яновського,
allergology,
кандидат
Named Yanovsky,
медичних
candidate
наук.
medical sciences, and
Дивлячись
then
на те, що за основним фахом пан
and
Любомир
then
фтизіатр, але вже багато років
he's a physician, but for
професійно
many years he
займається
is professionally
саме
dealing with
цією патологією,
this
саркоїдозом.
pathology,
І
sarcoidosis, and then
тому просимо вас до
we are asking
доповіді.
you to the presentation.
Доброго дня, колеги.
Greetings, dear
Сьогодні
colleagues.
ми
Today
розглянемо
we will look
питання
at
сучасних
the matter of the
тенденцій
modern
діагностиці
trends and the
та
diagnostics of
лікуванні
and treatment
саркоїдозу.
of sarcoidosis.
Не дивлячись на досягнення останніх
Despite the
років
achievements of the
зусилля
past years and the
патофізіологів,
efforts of the
імунологів,
physiologists,
генетиків і так
immunologists,
далі,
geneticians,
саркоїдоз залишається
sarcoidosis is still
захворюванням
staying in
невідомої
conditions and
етіології,
disease of the
що
unknown etiology,
характеризується формуванням
which is
гранульом
formed
без
that there's granulomas without the
некротизування.
necrosis, and then the
не встановлена,
etiology of
і тому єдиним
unstated,
таким
and then the only
патогномонічною ознакою цього
logical
захворювання є формування
this disease
гранульому.
is to form the
Діагностика
granulomas, and the
залишається
diagnostics is still staying
біопсією. Стадії
done by using
зупинився. От
biopsy.
на
So then
стадіях
the
вони вже залишаються
stages,
незмінними і
they're still unchanged
упродовж
from
більше 50 років.
about more than
Перша
50
стадія
years.
це
The first stage is
внутрішньогрудна лімфаденопатія.
intramuscular
Стадія 2
adenopathy,
це приєднується захворювання
and then there is a lung conditions,
Третя
and
стадія
then
відсутня
this
внутрішньогрудна
third stage is
лімфаденопатія і
absent
наявні
lung
ураження от легень.
adenopathy,
Хочу
and
звернути
then
увагу, що ураження
I
от
would like
легень,
to point your
бачите,
attention
вони
so that the
різноманітні бувають від порожнин,
stage
от
3
розкладу
they
до
can be
от
from
повнішевих і
the bigger ones
дисемінованих.
and then from
Тому все-таки
disseminated
біопсія
and
у
others. So
більшості
it's
от
under the
випадків от
biopsy. In most
бажано
of the
доцільно.
cases,
Четверта
it's very
стадія
much
це
needed. If stage
однозворотній
4, this is
фіброз.
the irreplaceable or
Настанови,
irreversible
якими
fibrosis,
ми
the guidelines
керуємося
that
і від
we
яких
are
будемо
using and
сьогодні
from which we will be
відштовхуватись. Перша от
touching based
настанова
upon. So
була
the first decree was
1991
from 1999 for ATS. The another one, which is a 2021, the ERS. So that the 22 years between the guidelines and sarcoidosis, there's no significant changes. In 2021, there was a report on a target group of the ERS. It was the recommendations on the treatment. So 5 years came after that, and so right now, and within this presentation, we can say what changed in the last 5 years, what are the trends, what are the new vision in diagnostics and treatment of sarcoidosis. Based on the latest publication, clinical research, and other things for the diagnosis stays as the main for the diagnosis. The biopsy still stays the main one, and the presence of the granulomas. And then also by the other clinical and X-ray pictures. The visualization, so what had changed, the primary assessment and staging are staying based on the regular X-ray assessment phenotyping, which is the CT, of high definition CT, the assessment of activity of the process of the emission process, looking for the extrapulmonary injury, as this is the PET CT, and MRI, this is for the diagnostics of heart and central nervous system. CT is being used in almost all the patient from the initially diagnosed sarcoidosis. So it allows us to decide upon where the biopsy has to be taken to exclude complications and other things. So the PET CT right now, and is much more popular. It has just one specific. It allows us to, the CT allows us to decide upon the activity of the process, granulomatosis, condition in different body parts. On PET CT, it has the characteristic of shining. And then in PET CT, it's a extrapulmonary injury. Heart, lungs, anywhere else. And then CT is being used also for the monitoring for treatment, especially in the clinical research. And those patients with the chronic processes in the lungs, with the significant fibrosis, when it's impossible to state the effectiveness of treatment. And then in the controlled PET CT, this is everything. You can see that the areas are being reduced and all that. Morphological diagnostics, the trends in the past 5 years is TBNI. Has become the first method, the first line in diagnostics of chest adenopathy, Also, biopsy is taking much more popular and becoming the alternative to surgical biopsy and comparing chemo injuries. There's many publication in the combination of those methods, and almost 100% of the cases allows us to put and state the diagnosis. So here in this table, in comparison table, different methods for biopsy, you can see that those have TBNI and cryobiopsy, but their effectiveness, they're reaching that's biopsy, and then the risk of complication is much, much lesser. Biomarkers, what's here? ABF or ACE. ACE is one of the most probable markers. I've seen that colleagues are using it a lot, and for the diagnostics and for seeing the changes in effectiveness, regimen of treatment, changes in the doses, glucocorticosteroids. But I would just like to mention here that this ACE, it's non-specific to sarcoidosis. It can also be heightened in other conditions and diseases, and it doesn't have this correlation with effectiveness. So for treatment, this is why for the dynamics, for control of the treatment, it's not always can show correct results. If we are deciding the markers for the control, it's better to use the interleukin 2. Its concern is much more sensitive than the ACE is. And other markers, right now, they're going through clinical trials. And unfortunately, so far, it's too early to say when the treatment is mandatory. So here in 5 years, changes didn't really happen. It's a mandatory thing that the absolute indicator is the injury to any body parts with the risks of irreversible damage. And there's also an absolute indication, which is any kind of injury in the sarcoidosis in the heart and the central nervous system. If we have decided the indicators for the treatment, and then there's also during that 5 years of the first line, which is glucocorticosteroids, the dose of glucocorticosteroids, it's still under discussion. There are advantages in the lower doses and the higher doses as well. Right now, the research has been finished. The STAR court that had finally put even preliminary, but still a full stop in the discussion of what kind of dosages are more effective, which are less effective. So there were groups. One group was that have received the dose of 40 milligrams and started from that dose, and another group had to dose 20 milligrams. So they have received the treatment throughout 6 months. And as you can see, based on the results of the treatment, practically those groups didn't change, no differences. The number of recurrences are high, but they're almost the same groups and the improvement of quality of life, adverse reactions, and also have been comparable. And this research has some disadvantages. It was just in one health facility. It wasn't blinded, not big sample size, but it has shown, and most of the researchers has mentioned that the dose of 40 milligrams, it doesn't have such a high grounds and advantages compared to the dose of 20 milligrams, and the number of adverse events have decreased twofold. This is why right now we still have patients, and patients are going for the consultation when they are receiving higher doses, 60 or 32 milligrams, and the need for such a high doses, we don't see yet. If the patient can be held on such a high doses, sooner or later we'll get complications. This is why modern trends in treatment are foreseeing the inclusion of this steroid saving medication in the early stages to avoid those kinds of complications. The most effective, I would put it that way, and according to the ATRS recommendation, This is the methotrexate, and so it's still number one among the medication of the second line. It, according to the recommendations, most frequently used when there was an ability to use corticosteroids or an ability to decrease the dose. And so who among the clinicians who have used it before, for a long time, we have seen that it's really highly effective. It practically doesn't go against the glucocorticosteroids. So this is why the research was needed that would compare glucocorticosteroids with the methotrexate. And then this kind of research has been conducted in 2025. It has finished. It was called the PredMet, and then the 130 patient has been there. Prednisolone started from 40 milligrams and methotrexate from 15 milligrams, and then slowly but surely increased the dose. Here, the endpoint was, and the effectiveness of treatment was assessed in the in using FVC percentage change, and in a month, glucocorticosteroids and prednisolone had approved effect. Methotrexate it was worse, but then at the end of the week 24, the effectiveness of the types of treatment was fully comparable. But if we are to take a look in the group with glucocorticosteroids, there was practically 2 times more adverse events than in the other groups. Based on that research, I think that in the nearest future, whatever regulations will be given, we're going to have 2 medication of the first line. Here it is unknown remote results, and then we will be able to compare. We're going to have 2 medication of line 1, among others is cytostatics, and then here overall there's not a big clinical base, not a lot of the research has been conducted, but if we are to analyze them based on their effectiveness of methotrexate, there's almost not worse than others, but in the condition using azathioprine, the bigger number of infection and unwanted mycophenolate, a wonderful safety profile, but is not as effective, but also not a significant evidence base. Any TNF alpha inhibitors. So those are monoclonal antibodies that are blocking the key cytokine in making granulomas. This is why there has been high expectation from them. They have approved them, then efiximab, adalimumab, and most of the research has shown a quite high level of effectiveness, and this is why they have been recommended as the medication of the line 3 and non-infective, and if corticosteroids cannot be used and cytostatics cannot be used. And then the one concern is that those inhibitors, TNF alpha, they likely, one of the side effects or adverse events, which is the having higher infectious diseases, especially TB, than during its prescription, especially it's needed to exclude TB, not just active, but even latent TB. In most of the cases, it's recommended to conduct the before prescription, not just an X-ray, but also quantiferon test. Rituximab. Rituximab was included into the treatment and recommendation, but the data on this medication, I would say you can't really make a conclusion here. In the only prospective study, it was effective only in 50% of cases. Not effective in the neurosarcoidosis, only effective in 74% of cases. It was great in being tolerated, but such a variability in terms of effectiveness and not knowing the delayed response. And right now, this most of the recommendations as the medication of line 4 or medication of, in some complex cases, of sarcoidosis with chronic, and then efzotimod. It was a very high promising medication, great results in the second phase. It has shown wonderful effectiveness, and then this third phase and then they will stop there. And ineffectiveness didn't even reach the first primary point. The same types of medication, they turned out to be namilumab, monoclonal antibody. Big hopes, a lot of scale up, international randomized trial has started, resolve long stopped because it's not effective. The inhibitors of interleukins. As I mentioned before, in sarcoidosis, they increase in the interleukin 6, and therefore they were hoping that medication would be effective, but tocilizumab in some of the research has shown a positive effect, but sterilumab, canakinumab, and others, there was no effect on the sarcoidosis. There was just not there. Therefore, their blockaders of the isolated interleukins are not needed. So the future checks are being conducted. The Janus kinase inhibitors, here are the data. They were effective, and right now in most of the cases in the research, like defacetinib, as it was mentioned before, it was highly effective, and this is why they started to be included into the clinical recommendations as a medication, as a line for mTOR inhibitors turned out to be not effective, antifibrotic medication, so they conducted the research in Italy. But in the sarcoidosis there's only 12 patients. This is why the statistically important effects were not found out. Right now in India, there is a specialized randomized trial of nintedanib, and so also in sarcoidosis, we are waiting for their results, and then maybe we're gonna have the practical use for that as well. Sarcoidosis of the lungs, this is the regimen that has been recommended by the EU as their first line glucocorticosteroids, and if they're not effective, methotrexate. Right now, taking into account that methotrexate is possible to use as the first line drug, and the regimen will look like this, that we have two medications for the first line, because there are indications and contraindications. The future holding trials are still there, and monoclonal antibodies with TNF-alpha. There's also research on the long forgotten hydroxyquinoline with the low dosage of prednisone. Hopefully, we're going to have a positive answer to that one. And then what future holds for us. This is as any other condition, personalized care, where there is a development of individualized algorithms for treatment based on their molecular mechanisms, new biomarkers, and then target treatment and other things as well. Thank you so much for your attention. Thank you so much, Lubomir, for such a profound presentation, and with the overview of all of the research that are being conducted right now and with the sarcoidosis, because really the treatment that has been proposed right now in the routine practice, we are seeing its insufficiencies. We see a big number of adverse events, but the adverse events is just one side of the coin, but another side of the coin is that the number of recurrences is very, very high, even though they're looking for optimal longevity, duration, and then doses of that. But this is not a one size fits all. And then, dear colleagues, please ask questions into the chat and to our speaker. You're waiting for your activity, and we'll be moving on. And I would like for us to welcome for the next presentation Yaroslav Dublik, the leading scientific employee of National Academic Center of Physiatry and Pulmonology, Allergology, named Dr. Yanovsky, Doctor of Medical Sciences. There's also another very important topic, this is sarcoidosis as well. This is non-communicable diseases that are not well diagnosed and even worse in terms of treatment. in a very serious and reduction of quality of life after getting treatment. To know that this pathology exists, and to the specialists that are dealing with the lung disease, especially infiltrational conditions, and then at the same time to physiatricians, we need to know that, because differential diagnostics, especially after COVID-19 came to be, it started to have a wider meaning, and then the disseminated to be, and you need to know how to differentiate with any interstitial diseases. Therefore, you need to know and remember about them. Then Yaroslav, the floor is yours. And thank you so much, dear Natalia. Yes, dearest the friends, so the interest in interstitial diseases is reaching the never seen before heights, because of the progress being made, scientific new knowledge and skills, and then it's a very interesting topic because it requires from clinician not just the overall clinical thinking, but sometimes the deductive as well. And therefore, in the small time that I have for my presentation, I'll try to, in different topics, to describe the issues of interstitial diseases, a bit of a classification, and we can talk about the interstitial pneumonias as this subtype of lung diseases, and we'll try to draw a perspective for the future for the development of the therapy in this area of work. First and foremost, I'd just like to mention the interstitial conditions of the lungs. This is the heterogenic list of conditions that covers more than 200, probably more, different diseases that can be characterized with diffuse injury to the lung, and then our colleagues are forgetting that there's diffuse bronchiectasis. And if you and then the group of these conditions is that there's in cycles, and then on the inflammatory fibrosis conditions, and sometimes in the profibrotic processes are just going out and becoming supportive and require a specific views on the diagnostics, approaches to treatment, and then in reality, if we are to mention about the approaches to classify these groups of conditions, then what we can look at is joint idiopathogenic influences, endogenic other things, exogenic risk factors, diseases to come to fruition. We can say that there's joint pathophysiological tools, and then pathobhistological or other patterns that we're looking at. But in reality, to say that there is any final decided classification of interstitial diseases of the lungs, that doesn't exist. As you can see, it's very much different methodologies you can get put into this group, and also sarcoidosis of the lung that has been mentioned by Delibomir Maranovic, and then as other processes we can also put into the diseases of interstitial disease of the lungs. And there is a big number of states that are connected with the influence of the environment into the human body, and also we need to remember about this, the antigenic stimuli, the harmful chemical and physical factors, and infectional agents. And then there's also enormous groups of autoimmune conditions with the that has the lung manifestations, and also as a separate part we'll be speaking about a big subgroup of interstitial pneumonias. And also it's not an exhaustive list, because there are rare conditions of the lungs, as the known to pulmonologists, maybe lesser known to wider groups of experts in respiratory conditions. But still, I'd just like to mention today that the epidemiological data are quite well developed, and then the spread is in 60 to 80 cases per 100,000 population, even though the interstitial condition of the lung connected with the autoimmune conditions. And then 12 cases, sarcoidosis can be under 30 cases, and then we will be also remembering such a complex and not well established pathology as the lung fibrosis up to 1,000 cases, and then the survivability can be vastly different, up to 100% in sarcoidosis, up to survivability in 2 to 3 years in the and most of the patient, they have complaints on the shortness of breath, it's progressive, and then non-productive cough is usually a worry. The other symptoms, since then pleural pain and other parts, they're seen rarely, and sometimes are just presence of other conditions, diseases, or require differential diagnostics with other conditions. By collecting patient history, you just have to be very precise by analyzing the possible risk factors of the environment or medicational influence, or possibly taking into account if they've been in contact with somebody, professional contacts, professional means, and this all have an enormous influence. Speaking about smoking, right now we are trying to stress in the novel types of smoking or tobacco-like products like vapes and e-cigarettes, because usually the reasons of those diffuse lung conditions is those novel harmful things that our patients have. And sometimes we are finding the family cases of having those diseases that just highlights the role. And then the clinical picture during testing, and then be characterized with the specifics of the breathing insufficiency of the diseases, the prolonged states, and then on the physical picture, most likely this is the double-sided B basilar subcrepital crepitus, and then in other, it's called the like Velcro opening, Velcro type crackles, and such as a deformation and the distal part of the fingers, 20 to 40 cases in the but this is not together with the symptom, because it can be causing the symptoms with the other patients with the chronic bronchopulmonary pathology. But still, it's looking at the hypoxia that supports the flow of those conditions, taking into account also the presence of this symptom. As well, diagnostics is the part of not just using the clinical understandable methods, but also the modern thoughts allow us to use an X-ray methods, among which we have a dominating CT, for example, and then the assessment of functional capacity of the lungs with the usage of spirometry, plethysmography, and then assessment of the gas state, diffusion capacity of the lungs when the patient needs to receive the lung biopsy, from less to more invasive, and then finally the state of health overall. It has a vaster meaning than the questionnaires, and then the 6-minute walks. We're not forgetting about those assessment methods in most of the cases, and the first and foremost for an effective diagnostics is using CT in patients with the suspicion for the institutional pneumonias or interstitial lung diseases. And this slide, you can see there's that there's a classification of the main patterns. So it may remain the patterns as the joint conditions that we find in patients on the CT. And it's very easy to use when they experience radiologists that are having this expertise in the assessment of these pictures. So they're putting the patterns there first, because this is the key to an effective diagnostics on those patients. And so when we are assessing what kind of dominating symptoms there are in the CT for interstitial conditions, and so usually speaking about the reticulation, weather changes, the presence of mad glass symptoms, the crazy paving, and then micronods, and then maybe consolidation, and then we are assessing the presence of changes that are saying that there is a irreversible fibrosis, which is the cyst or present, and then traction bronchiectasis, and then the next step is the assessment of additional symptoms, and finally distribution, because the distribution and the combination with the changes are giving us the ability to say that there's interstitial patterns, the most complex for understanding and the worsening prognosis. It's the patterns of the regular interstitial pneumonia in the literature, usual interstitial pneumonia, and then there's many other non-specific pneumonia as well. And also the patterns that are characterized with the violation of the intra-alveolar acquisition, alveolar filling disorders, and also rare conditions and different patterns. Is that the patterns we're looking at in the alveolar change and microlithiasis, omega-gas cell cytosis. Speaking about the separate signs that are most likely mentioned in our radiologist, it's not specific signs for interstitial signs and symptoms, you can see that there are the differences, the met glass and the patients in viral pneumonia with the eosinophilic pneumonia with the professional conditions in the lung. This is why you need to detail to assess this radiological symptoms in our patient, because we looked for many times the wrongful description of the sign or a separate assessment outside of other symptoms that leads to later diagnostics and effective in the future treatment. And the general principles of old interstitial condition, which is usually if we suspect or having the reasons and within accenses that, and then there's the professional diseases of the lungs, which is hypersensitive pneumonia in people who are facing with the inhalation of that are different antigens, and also the protective settings, and then oxygen therapy in case there's indicators in the level of SpO2 is lower than 80%. Frequently, we are prescribing anti-inflammatory medication. We are mostly speaking about the system like corticosteroids, and separately, it requires attention. This is why we are not going to be stopping here. In some of the cases, we are speaking about using immunosuppression. And as of today, the pace of the development of medications that have the anti-fibrosis action, and then the research isn't going into my presentation. Dearest friends, I would like to demonstrate to you what kind of molecules are having the future are now being developed. And finally, in those situations when we can't really control this, when there is irreversible changes that causes the fixed breathing insufficiency, the option is the transplantation of the lungs. And a few examples of the exposition with the pollutants, the prolonged pollutants with the antigens, and then it can lead to the epithelial of the respiratory body will be with the future activation of the inflammatory processes, maybe with the activation of fibrosis processes that leads to and spread of diffuse injury of the lungs. The example of such is the spores of the mushroom inhalation, different spores of different plants, dust aerosols, silica-containing aerosols, and many other factors, autoimmune conditions, quite frequently observed in our practice. This is why a portion of patient history collection, which is finding out if there is a possible system-wide changes in the patient. Apart from lungs, there's also other body systems, and so the patient history to rheumatologist, and then the higher level of markers, so the system-wide inflammatory process. We're also not forgetting about the possibility the lungs are being injured by our therapeutical agents as well, because right now over 315 known medications have adverse events in the harming the lung tissue as the medicated and intoxicated process. And this is why in this situation, when we are suspecting toxic action in terms of lung, I was telling to look out for whether the similar events has been, whether there is in the portals information on the possible iatrogenic injury to the lungs, and also clinical cases have been presented with the such pneumonias where they came hitting with different X-ray patterns, not just met glass, but also others than such a patient, and you need to remember about this. Also, institutional pneumonia, we mentioned here idiopathic under question mark, and so before there has been a name where you had 8 pathophysiological options and fibrosis and the non-specific and the bronchiolitis connected with the ICL and cryptogen organizing, acute lymphoidal, and also idiopathic pleural chemoelastosis. But in 2025, the European Respiratory Community groups of experts has revised this classification with changes, and so right now they're providing new guidelines like bronchial-centric interstitial pneumonia, like BIP, BIP. This is the general timeline that went through the radiological patterns as they, including that the injury of the lungs is connected with the inhalation of that that comes there through the bronchioli. It causes periodontal inflammation in the future. Those processes connected with the injury to the bronchioli. And then the new term, instead of the acute interstitial pneumonia, that is called diffuse alveolar injury. And in reality, during the pandemic of COVID-19, patient was double-sided complex injury to the lung that connected with the acute respiratory distress syndrome. We've seen this diffuse alveolar injury because the classical symptoms describe it Hammond alveolitis, Hammond Richardson, or acute interstitial pneumonia. And so the practical doctors of the latest times are not really seeing, apart from such cases, a new term. So the alveolar, to remove the previous one, this is anatomical and histological clarification. But the most important part, there's no term idiopathic, because the more we know about the interstitial conditions of the lungs, then the much more rarely we're going to something idiopathic, so unknown etiology. So I'm hopeful that in the future, all the interstitial processes sooner or later will become with the proven etiology. And so idiopathic lung or pulmonary fibrosis, separate form, or interstitial pneumonia of a known history that usually happens in the lungs of the older people with the patterns of regular interstitial pneumonia. And then it's very aggressive, as I mentioned before. The median of the survivability is 2, and many patients have, when we had the diagnosis and very fast is progressing the breathing insufficiency, and we can lose a patient. And this is how we'll look at the computer CT, the regular CT. This is deformation of the articulation, and then minimal or small number of metros, and absence of signs of incongruency of this pattern. So, for example, small node dissemination, consolidation, pleural excess or something, and the distribution as well was the increase in intensity of changes from apex to the basal department. So there's such an apical to caudal gradient to this disease.
Non-specific interstitial pneumonia, here we would have the combination of ground glass effect. This was quite characteristic for patients around their 40s. They might be subfebrile, loss of weight, indications of apnoea and dyspnoea. Again, this would be manifesting some interstitial changes with reticulation, but frequently enough, this diagnosis might be hiding some autoimmune diseases. So we have to be very careful when it comes to interpretation of these modifications. Cryptogenous anesthetizing pneumonia is also quite important, because even X-ray presentation can be suggestive of bilateral pneumonia caused by an infectious pathogen. And thus, when you have a patient who went through multiple courses of antimicrobials without effect, with a consolidation, and sometimes our radiologists are describing it as the Atolo or reverse nimbus effect. This is something very poetic, but remember that this is exactly the case when steroids could be helpful. There are multiple cases where you can see the progression with dominating fibrotic changes, particularly of progressing fibrotic impairment, and at the same time you can see that volumetric examination clearly suggests a depression by 5 to 10% every year. And then you can see the CT changes plus the symptoms in the clinical presentation. All of that is suggesting the progressing pulmonary fibrosis. Further on, being limited by the subject suggested today for discussion, we are still reconsidering some of the consequences of the global pandemic of COVID-19. And there are so many joint mechanisms, common mechanism between the pulmonary and interstitial pathophysiological mechanisms resulting in the same progression of fibrosis and the respective lesions. But everything is associated with the duration and the timely extent. And again, there are some certain share between 3 to 5% of colleagues who do agree on the shared approach to manage such cases, although I strongly believe that the COVID-19 pandemic, additionally to all of their downsides, has brought a lot of positive developments in the science and practice. And speaking of antifibrotic drugs, which could be suggested for the patients with idiomatic fibrosis or progressive fibrosis, with having any kind of interstitial process ongoing. So again, these are the drugs which are quite promising into the future as well. Looking into other options, we do have new data, new evidence, new options which can be used, and also in the context of hypertension management. Recently, there were two major publications with nerandomilast, for example. They have not demonstrated the endpoint result yet, but they have quite promising results both as monotherapy, but also in combination with other medicines. So the future options are quite broad in their variety. Some of them don't have their names yet. Even INN is not available, only the codification. Some of them in stage 1, stage 2, 2B. So again, they are quite remote from the clinical application, but they do shed a beam of light of hope for us and the patient. And on that positive note, I'm happy to start thanking you for the kindest attention. So the moleculars are quite remote into the future, but science fiction sooner or later becomes our reality. And looking at the current pace and rate of that science fiction becoming the reality, I do believe that within the shortest time possible, we will have full availability of the new solutions and tools for the benefit of ourselves and the patients. Excellent, Yaroslav. This was extremely helpful information. And this is particularly important, just like the previous presentations shared by the speakers, that you presented the latest and steaming hot information about the diagnostics, the appropriate diagnostics, and equally enough, the management of such pathology. And also, this was very helpful information about the changes in classification. So with that in mind, dear colleagues, please be active with your contributions in terms of comments and questions, making sure that we would be doing the right thing in the course of the reform, and also benefit from that reform to start making some money for our institutions. And to do so, we have to be appropriate and correct with our diagnosis statement, making sure this becomes remunerated. So please stay tuned while we are prepared to continue our session. As you can see, our conference is coming to the end. So I'd like to make a quick administrative announcement regarding the testing session. Please be reminded that the tests will be accessible starting with 1700 hours Kyiv time sharp. So please be prudent with your time management. You will have 30 minutes, half hour to answer 15 questions, and you need at least 75% correct answers so that we could produce a certificate in your name with 9.5 credits of continued professional development. And with that, I'm happy to hand over to Yevgen Nia Marenkova, who is the leading researcher of the National Center for Physiology and Pathophysiology, the National Academy of Sciences of Ukraine. And we have one more very serious pathology for discussion, which has been underestimated for ages. The more so, as long as there exists modern pulmonary care science, well, I mean, we have availability of CT, bronchoscopy, which allows us to take another look at this pathology. And I'm talking about the bronchiectatic disease, which currently is gaining more and more significance because of improved diagnostics, because of the other infectious diseases coming to the front of the stage as compared to the earlier time when we disregarded the NTMs, for example, while others, the tuberculosis itself, really loves harboring and causing chronic inflammation, namely in such bronchoectatic tissues, and thus we cannot avoid discussing the importance of that from the point of view of diagnostics and treatment as well, because again, one of our next steps and steps forward, I'm certain in the new direction, has resulted in having the new guidelines applicable thereto. So dear Evgenia, the floor is yours. Thank you cordially, and I'm happy once again, extending the opening remarks of Natalia, to pay attention to the fact that the earlier edition on bronchoectatic diseases, bronchoectasis, was published in 2017 by the European Respiratory Society. But looking at that statement, their guidelines were based on the clinical observations primarily, and did not have enough evidence coming from the randomized trials, which would be offering the solid evidence based for diagnostics and treatment. In 2025, 8 years later, the European Respiratory Society had another meeting, having enough results of randomized trials, which lay as foundation for revising this guidance. So let us try and see why and what the point of view was given to this condition, to this syndrome, remembering that among immunosuppressive, congenital, and autoimmune diseases, this has a very special place, remembering that treatment of bronchoectasis was also performed with quite extensive practice in different settings. So again, in this report, this is not included yet, because not all of the trial phases have been completed at this moment, but at least we indeed are moving in the right direction with some clinical as well as evidence-based observations and conclusions. Thus, bronchoectasis, this is a chronic inflammatory disease with such symptoms as coughing, with excretion of the sputum, relapsing respiratory infections, and also based on the CT imaging, it can be defined as bronchial dilatation. The basis for its diagnosis, managing such patients in such cases, we have four key targets. Number one, identify the origin of disease. We do understand that bronchiectasis can be a congenital condition caused by mucoviscidosis or cystic fibrosis, recite in some of the international publications. This could also be the primary acellular dyskinesia, which is associated with development of bronchiectasis. Also, this could be manifesting in case of chronic obstructive diseases, particularly severe obstructive diseases, and also chronic diseases like TB. Bronchiectatic complications are quite common in case of aspergillosis, immunodeficiencies, as well as immunosuppressive conditions. And obviously, we have to identify the cause of the disease. Then assessing the severity of the case, because that determines the management tactics, mild, moderate to severe, using our classification. So currently we have 3 stages of severity in Ukraine. And looking at this guideline, we can see that the suggested severity would be scored using a scale. Then looking into the complication rate, looking into the future complications, understanding how complex a human body is and how variable could be the list of concomitant or associated conditions and diseases. So in order to identify the cause, we do the CBC first, looking at the immunoglobulins G, A, and M in plasma to identify any deficiencies, then immunoglobulin G to aspergillin, and sputum sample testing to identify anti-M availability. Why is this important? Again, you can see this is the opening section of this guideline. Why so much attention is given, namely to non-tuberculosis mycobacteria? The matter is that this will be determining the treatment tactics, which will be different from other infectious processes. Additionally to that, if we have a suspicion, let's say alpha-trypsin deficiency, then we will have to identify the current level of alpha-trypsin in blood with basal emphysema or obstructive lung disease, particularly in the young age of the patient. And if we see any indefinite origin for the transaminase elevation, or there are some congenital obstructive diseases, and patient history, family history clearly suggesting that mucoviscidosis also would be an indicative condition, especially at the young age. There could be chronic rhinosinusitis, plus pancreas difficulties and bronchiectasia, particularly in the upper lobes and sections of the patient. So here we'll have to perform genetic research to look at the regulator of transmembranes. And also we have to perform the primary microcellular dyskinesia when we are suspecting such pathology. That would be the Cortagener syndrome as an example, or distress syndrome, which was detected in the prenatal period, chronic rhinosinusitis, chronic bronchitis, particularly starting at the young childhood age. Also, if we suspect any autoimmune diseases based on clinical presentation, then we are looking at the rheumatoid factor, cyclic tetrapeptide, and testing for vasculitis. Additionally, conducting the bronchoscopy and external breathing function test. So this would be the starting point, and that is important to identify the cause of the disease. Next, the block would be identifying the risk for future complications. In a given patient case, we can see that we have to make a weighted decision to better understand that patients with severe COPD with pseudomonas aeruginosa isolated or having 2 or more incidents per year, especially the severe form, as well as patients with regular and severe symptoms of sputum production, including the patients with NTMs or patients with aspergillosis. These are representatives of the high-risk population and candidates for severe conditions in the future. And again, this is also suggesting the treatment selection. And once we come to the treatment options that we have in case of such disease, it should be based on the, well, additionally to managing the primary condition, the etiologically driven, once we have identified the reason, we have to treat the primary condition first. And the secondary objective would be the pathophysiological or pathogenetic treatment of bronchiectasis. Pathogenetic approach is based on the concept of the vicious circle. And here we have 4 mechanisms involved that we are trying to affect via the intervention when prescribing therapy. These 4 pathophysiological mechanisms would be inflammation, then violation of circular clearance at the start of this elements, and we will take a closer look at each of these sections and how we can affect in terms of treatment and management. So again, please pay attention to the flowchart suggested by the ERS, the European Respiratory Society, and this provides a very nice presentation how these 4 elements and stages of pathogenesis can be affected, starting with the element number 1, which is a mucocellular clearance, and the first objective would be to improve the mucocellular clearance.
Learning how to clear airways. There are simple methods. What do you mean by the postural drainage? Regular exercises. You can also use additional equipment to improve cleaning of the airways. Or to use the mucolytics, mucoactives. Also use this as a nebulizers so that there is a local effect from that. This is what this equipment looks like. A section, and then for mucus as well. Right now in the market in Ukraine and then the world market, there's many different equipment dedicated to the improvement of that removing sputum. And the second thing that we are influencing the pathogenesis that you need to influence, this is an infection. Before the treatment to infection, we all understand that there is a periods of exacerbation and then the remissions as well, and so that the antibacterials are used in treatment of exacerbation, but one of the ideas in the guidelines, which is saying that prolonged inhalation antibiotics to a patient with the higher risk of exacerbation, chronic infection, and to the prescription of prolonged inhalation treatment to a patient that have a high risks of exacerbation. Together with that, we've looked at which patients are the groups of high risks, and also to those risk groups, and also to patients that who has something conducted by Pseudomonas aeruginosa, prolonged inhalation antibiotics. If patients have more than 2 or more exacerbations a year, one a complex exacerbation a year, inhalation antibiotics are being prescribed for a prolonged period of time. There's no specific recommendations that this period or another period is supposed to be, but an explanation to this point was mentioned that it's better to have it for 1 month. So it's recommended longevity of this antibacterial treatment, which is 1 month. If the doctor clinically assesses that the treatment is not clinically sufficient, then in any time we can stop this treatment at any time. And also in other recommendations, it also says that it's possible to do the test and the inhalation antibiotics, take into account that in the antibiotics and inhalation ones as well can cause the bronchospasm. For that, there is a test. They're recording spirometry before the inhalation antibiotics being put in and a bit of time later. And so then if we don't have this hidden bronchospasm, then we can use this antibiotic treatment. As the next point, or the next idea in treatment of the infections in bronchiectasis, which is the conduct of eradication therapy, of Pseudomonas aeruginosa. So they recommended for that the prescription of system-wide antibiotics for the course of the 2 to 3 weeks, and then the next follow-up. And the second one, we recommend additionally for those patients to prescribe inhalation antibiotics. Most frequently used apomycin, the term for 2 months to 4 months for the successful elimination of Pseudomonas aeruginosa. Apart from that, another special part is that you can't propose the prolonged oral antibiotics that are not macrolides as the first-line treatment and for adult patient with the bronchiectasis. And then what is meant is that patients that for prevention of exacerbations, you can use macrolides, and antibiotics is not recommended to use. This is the second part. This third part where we can influence and we have to influence for the treatment of bronchiectasis, which is inflammation. To inflammation, they have 3 main points, or the guidelines or recommendations on how to correctly treat that. The first one, the possible prescription of short-term courses of macrolides for the prevention of, but you don't need to prescribe macrolides to patients that have non-TB mycobacteria. This is why, especially before the beginning of the treatment, this has to be excluded. This means that macrolides are effective to those mycobacteriosis, then you cannot prescribe them as the preventative treatment for the prevention of the complication among those patients. So they are effective in patients with high risk of exacerbation, and as the treatment with macrolides, recommended azithromycin 200 milligrams, 250 milligrams 3 times a day, and then 500 milligrams 3 times a week. It's recommended to have the monitoring of and test for the liver function. And also in treatment of the inflammation, special attention is being given that you can't really prescribe inhalation corticosteroids to patients with the bronchiectasis, and especially if the reason of bronchiectasis is not COPD or bronchoasthma, so the inhalation corticosteroids can be prescribed only in case there is additional bronchoobstructive syndrome is present, chronic obstructive diseases, or asthma, for example. And the stage 4 that we have to influence is, or we are influencing in the management of those patients, which is the pulmonary injury, so that we have to conduct to patient with the violation of the physical activity. What we have to conduct is the pulmonary resuscitation. So those are the main ideas that we have for the management of such patients. Thank you so much for your attention. Well, thank you so much for dear Eugenia for such a modern pieces of information, for providing us a wonderful opportunity to our colleagues, to us as well. As a matter of fact, to simplify the access to information, not looking for things ourselves, and then to, during such an event as we have during this conference, at least to point your attention of the clinician that the recommendation have changed, approaches have changed, and this is an important part because in reality, the pathology is being faced much more often that we point our attention to it, and most likely this is just was the coming in of CT everywhere into pulmonology. They started to see it, and probably not fully, or not always, and not in the full amount, to sort to say how it's exists or functions. Okay, dear colleagues, there are a few questions in the chat, and I would kindly ask for all of us to, all the other matters, to ask questions into the chat, and we still have one more presentation, another nosology, which is the around cancer, canceromatosis, aspergillosis, early invasive diagnostic, forecast, and the indication for the surgical treatment. And I guess one of the hardest topics here was the worst kind of prognosis, even though here we can, any pathology can be of different stage of complexity, but oncology is there. And so if we have any round things in the lungs, we need to suspect either, we need to exclude first and foremost the oncological conditions. And then on this, we will give the floor to the thoracic surgeon, to Johan Miyatny, who is a senior scientific employee of Thoracic Surgery Department of National Scientific Center in Physiatry and Pulmonology and Allergology, and so the Academy Medical Sciences. And then given Johan the floor. Greetings, dear colleagues, and as of today, I would like to propose for us to discuss some of the matters of the treatment of the cancer and aspergillosis as well. We do know that the lung cancer is the most widely spread cancer among all the conditions. More than 20% are considered to the lung cancer, and then the burden of mortality is the highest, as also on the lung cancer. What patients we are facing in our practice? A patient with the flat cell carcinoma, tested in a few house facilities, hospitalized to us with the low functional status, with the pulmonary insufficiency, respiratory insufficiency, deficiency, and the patient, it was this very specific emphysema, more than 5 years been treated with the went for surgery upon surgery, and then the nostril was formed, and then the patient with the cancerous, and an X-ray. This is what we're seeing. You can see the injury of the lungs, injury of the pleura, almost total injury. And as the consequence to such patients, there's a very complex surgery being conducted. It's a life-saving surgery. Question is, how do we prevent the development of such situation? What do we do to avoid this from happening? So we have calculated that oncological screening allows us to detect cancer in early stages. And so we're trying to be as developed countries are, and so the information in the US is showing us that more than 50% of patients that went through the need and screening of cancer went through that screening. Among them, only 5% patients that really needed to go through that screening and went through that screening. Based on the research of the data from patients from 2015 to 2019, the patient that required testing, they only had 5%. From the other side, there is a significant cohort of patients, more than 20%, patients that never smoked, never had signs of oncological conditions, that later on had lung cancers. In Asian countries, the percentage of such patients is even higher. To prevent those kinds of situations from coming, they're recommending throughout the world to do CT, to detect any nodule things in the lungs, early detection, early prevention, early assessment in case needed, inpatient treatment as well. And point your attention to the fact that around 50% they require future assessment, that having 10% relative susceptibility, and only 1% they have lung cancer. This is from the data that is being given to us by the United States of America. The Association Thoracic Surgeon and our leading oncological experts are telling us that we've covered 22% of the population, but as of today, around 5%. And so as a consequence, in 2005 to 2010, in the later stages of the lung cancers, are grown into the 30%, and as of today, 44% of patients have later stages of lung cancer. What does it tell us, and how does this manifest? The funds of the government to the first stage cancers is calculated by the experts on oncological service. Around 5,000 an equivalent by the treatment of the stage 4 cancer. It costs around $80,000. So then the question is, how do we prevent and how do we not allow the development of cancer of the lungs? So there was a research conducted that the CT allows you to detect lung cancer in the early stages of the process. And quite frequently, the early stages of lung cancer can be visualized as the small nodes. The line of work with those nodes is being regulated by the experts of Russian Society. So the basic concept has been formed in 2018. As of today, today's recommendations, they have some updates. They're clarifying the rules or how things are being measured of solid components and partially solid components as well. And then there are changes in the paradigm, morphological assessments being conducted, and then mathematical modeling of the possibility development of the malignant processes. It is known that around 90% of smaller nodular things in the lungs and doesn't require any further intervention, but the risk of under detection of cancer in the lungs causes our future actions to go as they are. The present models for risks, and then in Mayo Clinic and other places, and during the detection of, in random detection of breaks in the lungs, we are following the recommendations of the Fleishman Society. And then during the specialist screening, right now we're using the recommendations of Montrust. In detection of any things that we can see on the CT, we are pointing our attention on the iodine calculation, and then we are calculating what area has the solid component, which parts have subsolid component. And in the last recommendations, they're assessing the widths of the camera or anything that's cyst or looking like a cyst. An important part here during observation is the time. The British Thoracic Society reaches out to a point on the important component of the VDT, or volume double time, and there's number of days that is considered critical for the observation over any new formation, and then it's considered, and if there's in 400 days, then it's malignant. If it's more than 600 days, then it's most likely a benign structure. Then the algorithm for clinical practice. In our realities, we are separating patients with the low risk level, the small, the not smoking, younger age that are requiring dynamic observation control in 3-6 months, and then the patient that have a higher level of risk, they're being referred to the surgical verification, the surgical biopsy for resection, and then for stenting as well. As of today, you can stage those cancer process through transbronchial as well biopsy or through a thoracic biopsy. Depending on where and which part this new process is located more centrally, we're giving the advantage to bronchoscopy, and then We're striving to verify that from thoracic biopsy. The indicators for the referral to the surgical treatment is a high chances of malignant process, morphological cancer, then proof in different parts of the node, and then another component is being assessed, which is the change in the solid to subsolid component, and which is also presented on the slide. In the surgical practice, we're using VATS biopsy or transthoracic biopsy.
As of today, we can see the robots are successfully performing in our country in both public and military settings, I mean hospitals. And the surgeons are debating on the particular type of the surgery to be applied, as well as about the scope of intervention in case of neoplasms. And as of today, in the specialized departments, whenever there is an anatomical opportunity available, meaning the neoplasm is within 2, maximum 3 centimeters in diameter, or maybe a resection thoracoscopic would be acceptable, then we are giving preference to thoracoscopic interventions. When conducting such intervention, this would be quite difficult to qualify the nodes in the pulmonary tissues. But there are different approaches, such as pre-surgical puncture, fluorescent elimination of the nodes, or 3D reconstruction using the augmented reality technology, namely to identify the nodular lesions or neoplasms. Definitely, there are some situations which stand out of the everyday routine, and that will require commissioner meeting with a panel of experts who would be using the algorithm as you can see described here, and we're using the Grant-Huntsman criteria. This is publicly available information. I will not be reciting it here, but in case we have such findings in patients older than 30, then we're using the Fleischner criteria, respectively. Every case would be analyzed by a multidisciplinary team, including radiologist, endoscopic examination, and thoracal surgeon. So definitely we do not operate on everything which is identified in a CT, but only after making the well-weighted decision with the specimen which require morphological validation and confirmation. In most cases, this would be a single port or dual port interventions, just as you can see here in the images. This would be the access point and the results of micro-invasive interventions. And this would be the overall picture and summary on regarding the neoplasms, and the radiologist here specifying the key patterns. But in case of cancer, aspergillosis, chromatosis, all of that is well described in respective radiology guidelines. So I suggest we won't be reciting that here again, but rather focus on aspergillosis of lungs. We have performed more than 30 interventions over the recent history, remembering that after major post-TB modifications, the caverns can be serving as the harbor for developing the neoplasms, and frequently enough, the patients with aspergillosis have complications. And this would be the image, which is clearly suggestive after the conducted intervention. And based on the looking at the results of our performance, there have been no relapses of aspergillosis in our patients. Speaking of lymphogenic aspermatosis, recently enough, this diagnosis seemed a science fiction, but early diagnostics and modern CT allows us to find such cases, identify them, and perform the respective interventions with the patients who are full candidates for the therapy or surgery. This would be the X-ray picture, which would be a definitive of lymphogenic cancerogenesis, which has the quite peculiar combination of clinical symptoms and presentations with the respective specific features, including the infiltrations of peripheral and lymphatic nodes. But the major role here would be the time again when it comes to verification of the disease as such. The sooner we can find and verify and respectively start the therapy, the better would be the recovery and survival rate among the patients. As of today, the basic algorithm of action of the neoplasms in pulmonary, if this is within 5 to 6 millimeters, it has to be observed. Over 6 millimeters, then radiological control, 3-month window of opportunity. If it's more than 8 millimeters, that would be requiring verification by all means, either via thoracic or transthoracic or fibrogastroscopic, respectively. As has been demonstrated by the developed nations like United States, over 50% of patients who should have been examined are getting lost to follow up. These are the so-called dropout patients, and this is the routine statistics of developed nations who are designing the guidelines and algorithms for the follow-up. While at the same time, the same guidelines are indicating that there is some risk-oriented and risk-relevant cases which have to be brought together for the benefit of consolidated management in specialized centers which have one team working without any deficiencies in terms of logistics, with clear set priorities and techniques. And thus the advantage of having a one-stop shop for such patients who come through primary counseling and testing, including diagnostics, then staging, then verification, when and if necessary or applicable to treatment, and the follow-up observation, which means that all these steps to improve the situation would be using the standardized guidelines, because currently there is a variety of those in case of suspected cases, and the Fleischner criteria in case of spontaneous findings. But the only reliable solution and the pathway, and also the only formulation applicable thereto in case of CT findings or findings via surgical interventions, and the only pathway to post-surgical follow-up that would be allowing us to perform for automated and AI-augmented solutions, plus clear communication between the provider and the patient, as well as between the service providers and the respective centers in Ukraine and beyond. And on that note, I thank you for your attention. And we thank you so much, dear Yevgen. Again, this was an state-of-the-art presentation with demonstration of the modern approaches, demonstration of the modern equipment, which is utilized for the benefit of diagnosing all ball-shaped neoplasms and collecting the material for biopsy, demonstrating the navigation pathway, which for Ukraine, the country at war, will be indeed information for implementation in the future. But in order to be better prepared for that future, we have to make sure we have some technology on our side available here and now. And speaking of the future, that would be beneficial not only for Ukraine, but for the global community as well. And now we have a small block of the question and answers before we come to testing. And my first question goes to Mykola Ostrowski. Speaking of broncho-obstructive conditions, speaking of COPD primarily, so how frequently COPD is occurring in case of TB? Is it more frequent among the patients who do not have TB? And or at what degree of manifestation do we usually state the initial diagnosis? Speaking of TB positive versus TB negative patient population, to the best of my knowledge, your department, your team did fundamental research, and you have a lot of material and you have some statistics, hopefully. So could you enlighten us in that respect? And most importantly, also, at what stage of chronic obstructive disease are we diagnosing in case of TB positive versus TB negative population? Thank you so much, dear Madam Natalia, for this question. My quote would be about 60% patients with confirmed TB diagnosis is associated with chronic bronchitis. And also, once we look at the chronic obstructive pulmonary disease, then percentage of such patients would not exceed 15, maybe 20%. But speaking of the stage of the chronic obstructive disease of the lungs, then here we'll be discussing the phenomena where patients with pulmonary TB, when COPD is diagnosed, as a matter of rule, they would have the bordering indications of the bronchial volatility. So that would be dancing around the 50, maybe second, and the borderline between the second and the third line. But again, looking at this comorbidity of COPD and TB, usually the smaller bronchi would be involved. Namely, when talking about the COPD, with the TB process as the background. And that would be highly relevant because of some rapid deterioration of the draining function of the bronchi because of their design and anatomical structure. But here we have to distinguish between the chronic obstruction versus the so-called constrictive bronchiolitis, which also has very clear criteria for diagnostics, which allow us to differentiate between these two diagnoses, with the basis for that being such diagnostic method as the computer tomography. And here I'm fully supportive of the idea suggested by highly esteemed academician Feshchenko when saying that COPD and bronchial asthma cannot be diagnosed not only without spirometric examination, not only without functional tests, but also without having CT results available. And thus, we have not only the hypothesis, we have a dogma, which is suggesting all spirometry. And we have to make sure that every patient, either to be positive or to be negative, also has to go to the CT imaging first in order to make sure that we can see the clear picture. Thank you so much for such an extensive answer. And just one more additional question to follow up on that. In your opinion, from the organizational point of view, what would be necessary to be done additionally, maybe at the national level or regional level, speaking of activities to allow for COPD diagnostics to be effective not at the second and third stage or borderline, but as soon as possible? Thank you for that question. My prompt answer would be the functional assessment, spirometrics, accessibility of spirometrics, making that accessible at the primary care level, knowledge and awareness of the family care providers who will be checking their airway functioning, making sure that we have the patency assessed and the slightest suspicion of such conditions should result in immediate referral of the patients, which will make diagnosis at the earliest stage possible. So again, once we are stating diagnosis of COPD, then thank God bless such patients to make sure that they can progress from COPD-1, the golden stage, the life expectancy and his aptitude, they will be able to not only survive but live with a diagnosis to GOLD 2 and 3 and 4. In case of association with TB, we will see the rapid deterioration of the obstruction, so definitely that requires particular attention. Thank you so much, dear Mikola, for that response. And we have another question from our online audience regarding the sarcoidosis and diabetes mellitus. Sure, if we have a case of severe diabetes mellitus, let's imagine type 1, and this would be sarcoidosis, initially diagnosed. So what would be the drug of choice? Methylprednisolone or methotrexate? Under such circumstances, but remembering about the severe diabetes mellitus, we should be starting with the cytostatics. And if this is type 2, well, diabetes mellitus will be definitive because the steroids here will be elevating the sugar. So definitely we have to be mindful of diabetes, but the corticosteroids, in case of severe form, when the non-active cytostatics together with endocrinologist, you might be deciding on that combination, but they should not be counterindicated. And majority of patients with diabetes mellitus, they should be starting with the cytostatics, methotrexate as an example. Thank you so much. And one more question, which will probably be addressed to both Lyubomir and Yaroslav. In your presentations, you referred to quite a big number of elements of hope manifested via availability of drugs, which currently are at different stages of clinical trials with some greater or smaller degree of expectation. So just a couple of statements about sarcoidosis, interstitial pneumonia, remembering that such pathologies have quite a lot in common. So what would be your opinion in what would be giving the most promising results in the immediate future, and what we as clinical providers should be expecting in the nearest future as compared to the current drug availability? Speaking of sarcoidosis, first and foremost, the most promising would be the inhibitors of Janus kinase. They are available, they are effective, they're included into some guidelines. The only thing is the price. Tofacitinib, 50 drugs will be something like 15,000 Ukrainian hryvnias, and this will be twice daily. Well, this is not available in the official guidelines yet. In the European, yes. Okay. Majority of them are still on approach as soon as we have the new evidence that will be included, but the price is yet the factor. I also would like to follow up on that. Frankly speaking, remembering about the sarcoidosis as well, we are managing it in our department. We do not strongly believe, I do not strongly believe in any promises about the drugs coming anywhere in the visible immediate future. But again, this would be my subjective opinion. But in general, interstitial diseases, including sarcoidosis, this is quite challenging, heterogeneous process. And there are some sub-variants of sarcoidosis, including some ethnical peculiarities and features of our patients. And speaking of interstitial pneumonia, in fact, I do refer to just a part of pharmacotherapy options, including the drugs against fibrosis. We don't expect any panacea to happen and evolve, but there are some drugs which might slow down the fibrosis process in the lungs. And hopefully these drugs will come either sooner or later and helping us to bring lungs back to their original architectonics and thus relieving the key manifestations of disease. And thus we'll be giving more time to the patients to take a well-balanced and weighted decision, maybe considering transplantation and improving their quality of life.
They're quite far from any good solution, but the information and the knowledge is being acquired, and everything is moving in a foreseeable way and a positive leap forward. Just hopefully we'll be able to finish positively, essentially. So everything for the betterment of the patient, and then hopefully science will not stall. We can even imagine what will happen tomorrow with the treatment. This is just subjective, but yet again, thank you so much. And then I would have a question to give Evgenia, just a practical, what is frequently being asked by clinicians. First of all, we all know that bronchiectatic conditions, which is the reversible state, is impossible to cure it per se. What are your recommendations on to stop progression and spread to other areas of lung tissue? And then the second question, the main method for treatment was surgery. So you would just remove those parts. And then what happens in this stage, because surgery is not mentioned at all in none of the recommendations anymore, by answering the first question, we have to, is any condition, disease, or anything else, we need to ask the main objective and then try to achieve it. And in this case, also our objective is to reduce the number of exacerbations, to improve the quality of life of the patient, to improve reduce the risks of the worsening of the state, and then reduction of the functional insufficiency. So the less the patient will have exacerbation, then the better prognosis they're going to have, the slower development of the condition, and then the risk for mortality will go down. And that way we would need to stop the exacerbations coming in. This we can influence if we will decide upon what the reason of disease is. We are treating it heterotropically, and then the preventative is the area of work, which is pathophysiological activity for the eradication of the sputum, so that it's not going to be staying there, or for that the big meaning and value there is in any means that we have voiced already for the improvement of the sputum excretion. And also, please don't forget about the simplest of ways, and so meaning the treatment, rehabilitation, and also which we need to give a lot of attention to, so that the patient are, which is important because the patient needs to feel that they're constantly doing something for themselves and they're improving not just physical but also emotional states, which is very important in treatment of any exacerbation or any condition. So we are directing our pathway, so there is some eradication dispute them, and so that it's not going to be accumulated. This is a prevention of the complications or exacerbation. Regarding the second one of the surgical treatment, right now we only have the small branch of patients to whom there's still indication for the prescription of surgical treatment, which is if there is localized bronchiectasis. But this is happens quite rarely, to be sure. So it's localized, and if it's localized in upper portion. So thank you so much, dear colleagues. I would just like to say that it's 5 minutes the time for our testing, so that the platform is open. What you can do is you can start going through testing, but I would just like to ask another question, and then there's a few concerns, and I will voice them out right now. And then Mikola, it's and then I think this is important, and then spirometry from family doctor, and then you need to send it to the pulmonologist for them to send to spirometry, and then another participants is commenting to send it to the pulmonologist. You would need to do to give the referral from the physiologist. So that how can you comment this organizational cascade? And the patient to get to spirometry. And we are living in the time when the population of the different processes, and then the organization medical care, where we have the idea, the truth, and then of course is the family doctor, and then pulmonologists that are regarding the specialty, National Health Service of Ukraine, to conduct the spirometry as well. To get to the pulmonologist, the previous consultation, we don't think that we need that, so that the family medicine is referring to the consultation to the pulmonologist. He can prescribe the testing that is needed. Thank you so much. And then I think that this answer will satisfy our participants, but the explanation and how to move and what to do. And yes, then we will be finishing our event. I would just like to say thank you to all the speakers on our session, and I'd just like to say it was an interesting presentation. We had one comment there from the participant on that the event was overloaded, and then the different topics, and then there's a lot of things. It's better to have a few events, and then if somebody is thinking of me, if somebody's not taking with the test, you can give your comment, and to our colleagues as well, and how to perceive the information. But from our side, I would just like to say that all the international platform, they're conducting conferences on the international level in this format, and then also from the 7 in the morning in 4 to 5 days, and then nobody is foreseeing that every participant of the conference would be just sitting there and listening to fully from the beginning to the end of those sessions, especially if this is an online broadcasting. In the same way, we are supporting the international format of our event, so that we structured the event was separated to 6 sessions on the topics of interest. And then every specialist would have an ability when to listen to each session. And also additionally, if, for example, everything is interesting and nobody had the time or something, that during the broadcasting, during the admissions, there is a YouTube channel as well. On the YouTube channel, the recording, as I mentioned before, and the National TB Hub of our training center. And then this is free of charge. It's in the full access, and at any moment of time you can went to the YouTube channel and listen to what you've missed so far, or if you're interested you can review, and then mm, and then we are waiting for a response from you, and also for the closing of the conference we have our NTV manager Yana Terleva who's joined us, and it's timely just as soon as the and then to Yana, we would like to pass the floor for closing remarks for the conference, and then Yana, hopefully you've been listening to us. And what is your vision, and what can you wish to participants? And thank you so much, dear Natalia, dear participants of the conference. And we are being filled with the emotion, the honor that we have so many speakers and such a thing that we're getting to know on such a platforms. And I'm seeing such a big space for it's very much the medics really need to gather together, need to speak about this, need to have this space for growth. And this is wonderful to get together and then to change the future of the country. And then we need to be regarded their colleagues so that we would have more recognition and for financial growth and other types of growth. So the certainty of the next day, so that we have the wonderful opportunity to live in our country. And then yet again, I'd just like to say thank you to all the organizers, to all the speakers, everybody who has joined and put their efforts so that this event, in my opinion, is as successful as possible. In such events, they have the right to live, so that regularly we'll be continuing such a unified joint community that is placing ambitious professional goals in front of themselves. And so we pointed out that there is a list of practical working matters, and then we've collected them also from our site to speak with the Ministry of Health, maybe scale something up, maybe to revise something, and then also this platform, it's such a wonderful space so that we can raise the socially important questions, so that really we would be able to speak about the health of the lungs through the prism of TB. So thank you so much to everybody, and then let's see you next time. See wonderful new opportunities. Thank you so much, dear Yana. And then I see in the chat then some of the more of the, and there's no more constructive questions, and I'm also seeing that a lot of people have already filled the tests, and then to whoever didn't do that, to do so successfully, and then I wait for you to the next events together with partners. We are not stopping the work, and then we will be planning this for you. And you'll be writing this test and then the questionnaire of the event as well. And so whoever has the comments, wishes, or anything else, your idea, and then on the platform to plan next activities. And we are also taking into account all of your wishes, and then all of your peacefulness and other things, and then the skills and knowledge that you received in the conference to your practical activity. Thank you so much and have a wonderful day. Thank you.